faccio, invece che mettere il pezzo di scrivere non abbiamo usato un po' il faccio.
Direttamente dal tuo computer per cambiare.
No, per favore, se faccio solo PowerPoint.
Da lì non si cambia.
Uscire in fretta. Ma guarda, ce l'ho. Io. Tira il capo clic. Ma guarda, ieri ce l'avevo.
Che si può.
Io una volta, io più di una volta mi ha preso il certificato, sì, l'ho
Fatto bene.
io in sala già parla solo il reparto.
Si parla anche oggi.
Buongiorno, vi comunico che ho avviato il live streaming su YouTube.
Sì, grazie.
Come lo viste? Ognuno se levanta temprano, debe interpretar. ¿Sabe quién está allá también? ¿Quién? Y hay otro más, italiano, de esa fila. Ahí en la entrada. Deja que no te da café. It throws everything you want in his watch. Lo estaba diciendo a ver.
Good morning to everybody. It's a great pleasure to welcome you here for it's a feast. It's all friends in this hall, and the scientific content of the friends is up to their time. So for me, it's a double pleasure. It's a triple pleasure because it's also my retirement. I will carry on seeing patients for Dr. Cristaldi for another 5 years, but officially my handing over the unit to her, and I'm extremely proud of that. And I'm extremely happy to have all you as friends here. The friendship that, as we see from other compagnons who have retired, will continue in the forthcoming years. So this is another thing that fills me with pleasure. So I hand on the microphone to our master to open the Congress. We have the opening ceremonies later, but let's open it now for us.
Pietro is our host. Until now, I think it is perfect. So thank you, Pietro. It was very nice. The first day was a real success. Thank you. You are the host. I take care of the scientific program. We will go. So I have only one thing to say to the speaker and the discussion. 5 minutes. The good news. 5 minutes. I may accept 6, perhaps 7, 8 be the maximum. But after 8, you'll be killed. So, Nick, you are the first speaker. You need to give the example. This is the best example of the company. Follow him or not follow. We will see. Thank you.
Always pleasant to receive the information 30 seconds before your presentation that the time is kept down to only 5 minutes.
Give me 5.5. We started on time, thanks to Pietro. We are in Lugano, almost on time. So Swiss time. So thank you very much. I will present the same slide time. Does this count as one slide? Probably it does. So a hybrid room on top where we can have 3 encounters in one. We do portal vein embolization first stage on CT scan. And of course, you know, this is part of the revolution of technology in the OR, surgeons not alone, technology. And we have now the molecular biology. And I will focus today on these, you know, these point mutation here. Some of the point mutation is in red because it's very complicated, but in fact, I will try to show you that it's more simple than what you think. So driver mutation, what drives the prognosis? Because there's a lot of fluff in molecular biology, and you don't need to know about it, but you need to know about mutation. We'll talk about recurrent. We'll talk about ctDNA, which is, you know, you draw blood and get essentially a biopsy. You don't need a needle now, percutaneous, to find out about cancer. So these are the driver mutations for colorectal cancer. It's fairly unique colorectal cancer because we have here 7. You see 7 mutation, NRAS, KRAS, but we call it RAS, very simple. And then you have the 3, the elephants in the room, the most common, TP53, KRAS, and APC. And I'll talk about it in terms of prognosis. in terms of prognosis. So we have this pathway here of colon carcinogenesis, and TP53 obviously is the most common driver mutation. APC, RAS, BRAF, MAT4, FBX, W7, very rare, 5 to 10% of the mutation. They all adversely affect prognosis, except for APC. APC improves the prognosis. We don't know really why. We've been searching for it. At MD Anderson, we have essentially a group of researchers for every mutation that have gathered the APC team. It's a small team, and they couldn't tell me. They still can't tell me. So maybe next time I'll tell you why. But what you can do with these mutation, you can raise essentially colorectal cancer, metastatic colorectal cancer, resectable on the left and unresectable on the right in 3 tiers, So grade 1, 0 mutation or 1 mutation with APC, because APC improves the prognosis. It's really based on the number of mutations. Grade 2, 1 mutation or 2 with APC, and grade 3, 2 to 3 mutations. And you see, this is this is not because Memorial Sloan Kettering was very generous with MD Anderson, because that's the competition, but we got from the public domain all their mutations. They published a basic science paper, and we got these results. So this is the unresectable, same grading, if you will, of prognosis. So the question is, do driver mutation predict recurrence? Do they predict recurrence? Well, in the era of parenchymal hepatitis, we have more and more and more positive margin. And does this matter? Well, if you look here, no, and we know that sort of from Guido, the size of the margin that doesn't matter. But do mutation predict local recurrence? The only problem with positive margin is really local recurrence, and it doesn't. And any of these mutations. Size of the largest CLM, yes. When you have greater than 5 centimeters metastasis, you have a more chance of having a local recurrence. So, do not predict recurrence. Surgical margin, mutation do not. But what's very interesting is the combination of 2 mutations here, RAS P53, predict intrahepatic recurrence. Predict recurrence, and that raises the question, is this a group we could target with hepatic artery infusion? Currently, we do not perform hepatic artery infusion opposed to Memorial in New York, but we are certainly interested in it. Now, as you see here, you can also use Sankey diagram to look at this grade 1, grade 2, and grade 3. I showed you earlier this 3-tier. And clearly, from the size here of the blue and the yellow, you can tell already that this grade 1 and grade 2 are probably part of a group that is more favorable. And in fact, if you look, there's in each group, grade 1 and 2, you have 20% have no recurrence, and you reoperate, and again, the same proportion, 20% no recurrence in the yellow and the blue, grade 1, grade 2, no recurrence. So this is groups of interest. Now, conversely, you have more extrahepatic and unsalvageable recurrence in grade 2 and 3. So we have this grade 2, which is intermediate. We think certainly if you consider liver transplantation, since, this is a situation where you have to wonder, well, which group really you don't want to have a banana peel and transplant and have an early recurrence. I think it's grade 3 for sure. So 2 mutation or more, I think you should refrain. Now, ctDNA. ctDNA, you do a blood draw, and we do that. We have a program, intercept program, now where we do circulating tumor DNA, essentially at presentation before chemo, after chemo, after surgery, and we follow now 3 or 4 times a year. That's how we follow our patients with colorectal liver metastasis. And we check the ctDNA essentially. Very interesting. I had a patient not long ago from Colombia, in fact, with a single nodule in the lung after resection for colorectal liver met, and it didn't look like colon cancer based on this footprint of ctDNA, and it was in fact a melanoma metastasis. He insisted on having a resection immediately of this nodule. I was not convinced. I said we could do some chemo, but so you have to be, I think, using the ctDNA, it puts you in a better position, and you have the footprint again of the tumor. Now we call minimal residual disease this interval of about 5 months. You have cancer in the blood, and the imaging does not show really recurrence. So we call it minimal residual disease, and we feel that this minimal residual disease, here in blue on white, minimal residual disease, this interval is an opportunity to treat early cancer recurrence before you see it on CT scan or on PET scan. You can tailor also the intensity of therapy. This is something we do. This is the intercept program, again, effective at our institution. We started this in 2021, and we do this at all the stages of the disease. It's reimbursed right now by Medicare and Medicaid. It's about $3,000 if you pay for it. And you see, this is our initial result here, recurrence-free survival. So this is the ctDNA measured within 10 weeks after surgery. You have the 2 groups, and you see that surgery does very well, at least in the immediate postoperative course, because you have 80% of the patients, 70 to 80% of the patients which are ctDNA negative. They became ctDNA negative from ctDNA positive from surgery. And this is the hepatic disease-free survival. It's going to be very interesting to measure the quality of the surgery based on the ctDNA measured right within 10 weeks of surgery. Is this group doing good surgery or not good surgery, leaving disease behind? With a lot of opportunities. This is the Nakamura trial, a very important trial, circulate 2,000 patients from Japan, published very recently. And now it raises the question. You see that on the right, patients who have ctDNA negative do not seem to benefit from postoperative chemotherapy, as opposed to patients on the left, where you seem to have a benefit. These were a small number of patients with stage 4 disease resected. This was a study of 2,000 patients, which included 80 or 90% of patients with stage 2-3, 1-2-3 colon cancer. So we have looked now at our institution, and you see, we find the same thing, in fact, in a much larger number of patients, this Japanese study for stage 4. And you see here again, in stage 4, really a difference only of chemotherapy. Look on the right side, chemotherapy here, chemotherapy patient in brown, better than patient who received no chemotherapy. And these were patients with ctDNA positive. Patients with ctDNA negative, maybe not. This is not randomized, but maybe no chemotherapy for these patients. This is to remind you that you can, with this blood draw, get all the mutations you can do the exome, essentially, the entire exome, and this is very valuable for us. This is a reminder that commutation is really important in terms of predicting the positive postoperative ctDNA. So before surgery, you can predict really based on the mutational grade, essentially getting the footprint of the disease before you do anything, any surgery, even before you give chemotherapy. So you have the footprint, 3-tier prediction. I would say probably very, very bad group, grade 3, grade 1, 2, in the same category. Minimal residual disease may guide adjuvant therapy. And then at recurrence, we always wonder, it's not a black and white, these mutations and ctDNA, because that's the question. The Society of Surgical Oncology, they tried to get me cornered, ask me, well, are you going to say no to surgery? No, it's not the answer. This is never white and black. Thank you very much for your.
Not sure you spoke for 5 minutes, but it was excellent. Thank you. And now I don't know what we have the whole presentation should be 25 minutes. So there's a discussant. Who is the discussant? Jean-Philippe Adam.
You decide, Chairman, you decide according to the interest.
Okay.
You have to finish, you know which time you finish the session, but only one word. I did not check the time. I was so interested, I did not check the time. But
Well, thank you.
it is sure you will not have the award of the shortest. It's an award. I was ready to say a price, but Pietro say the budget of the Congress. Not. It is impossible to have a prize, but award is okay. Award,
Penalty.
but you will not use award. The shortest communication could be 3 minutes, 2 minutes perhaps. So the competition is open. Now the discussion.
But the discussants, they didn't see the presentation before, right? We were discussant at the ESA or ASA, they have the paper before. Here, the discussant doesn't have anything. Just yeah.
Very much, Professor, for your talk. I have one question regarding nowadays. We have any mutation which contraindicate upfront liver colorectal resection?
So there's no mutation contraindicated. There's no single mutation. As you know, the BRAF, I showed the BRAF also in red at the beginning, very rare, and it's been discussed a lot. But we resect these patients also in the context of response. We still use response also. So I think you have to use other things. That's why we use also, we like to use preoperative chemo. I think you have to, and we like to use also multiple imaging before surgery. We get 3 CT scans before we operate on colorectal metastasis, and that helps also. So it's a context. So even BRAF. So no, the answer is there's no mutation contrast. So it makes you feel good, right?
Yes.
Good.
Any question?
Other comments?
Yes, for example, nowadays, the biopsy, can we use it to predict early recurrence?
So as I showed you, I think you can predict, you can predict whether the mutations are going to be based on the grade. You saw here, I couldn't go into detail, but again, you can predict in grade 3, 2 and 3, they are more commonly extrahepatic and there are more multiple site in grade 3. So yes, you predict this worse biology. You can predict the worst outcomes. So you've seen this group of 150 patients out of 700 total. This group of 150 clearly, I would be reluctant to consider for transplant. And this is in line with the Norwegian data. I think they have a paper recently looking at mutation. If you look at, they're very good at selecting the mutation without knowing the mutations.
Nicola, I didn't quite catch. How often do you repeat the liquid biopsy, and whether they drive your imaging, or, for instance, we can expect the patient with negative liquid biopsy, it's not useful to do check-up CT scans, for instance. And cost-wise, it's say $300.
So I couldn't go into the detail. That's very important issue. So we do ctDNA every time we do an imaging, because ctDNA is very sensitive in liver, very specific. When it's positive, we know almost always it's a recurrence. It's a matter of time to see it. But in some locations, ctDNA may not be positive. And that's particularly the case in the lungs or in the peritoneal cavity. So our patients want to make sure there's no recurrence. You miss a recurrence. So that's why we still would do the imaging. But again, you can wait and less surveillance after a while, you know, and there's going to become the question, you know, the cost benefit. Yeah.
This is a very interesting talk, and I think the future has to pass through the systematic evaluation of this type of markers. So about the APC mutation genes, you've shown us very clearly that extrahepatic recurrence is much more frequent in groups 2 and 3. So, for example, now with the advent of liver transplantation for colorectal mets, do you think it's absolutely necessary that you include this in the criteria for transplantation in the coming times?
Oh, for sure. I mean, if you don't do that, I think you're not, you know, you're dancing on thin ice. Yeah.
Raise your hands. How many hands? 1, 2.
I said, the biology is so strong that you are very modest. The surgeon, in the beginning, the prognosis is determined by the tumor, the biology of the tumor since the beginning. So my question, right, can we change the biology of the tumor?
So that's an interesting question. So there is concordance in this mutation throughout the course of the disease. In colorectal cancer, it's very interesting. You don't have a selection, you know, you give chemotherapy. So at the beginning, you have this footprint and it remains the same footprint, except that in patients who have a KRAS wild type and they are treated with cetuximab, they may become KRAS mutated, but it's the only example. But otherwise, it's the same. Yeah.
I'm sorry, a short answer. Can we change or not?
Oh, okay. Maybe I should sideways. So no, it's a footprint at you have it.
So as I understand it, your genetics are comprised of extracting samples from the entire tumor. Is that correct?
So I didn't go into the details of the circulating tumor DNA, ctDNA. There are different platforms. And we use now this Intercept. It's a Signatera. It's supposed to be the most accurate platform because it's based on, they draw the blood and then they check from a biopsy of the tumor to make sure there is concordant, and they eliminate, there are some mutation that's come from the stem cells in the bone marrow, which are not cancerous mutation. You want to exclude them. So that's what exclude.
Because I was under the impression that within a tumor, there are diverse populations of cells that
Yeah.
have potentially different signatures.
So
And if
it's mostly, no, it's
targeted, if
No.
you use targeted therapy, you would selectively delete the susceptible cells
no, it's
and
well,
end up with a resistant tumor. Isn't that the
No,
Achilles heel?
no, in this cancer, it's very interesting. It's concordant, mostly concordant, 95, 98% concordant, even if you have multiple mets. If you look at it, if you look at the somatic mutation, I'm talking about the somatic. Yeah.
Nick, congratulations. I appreciate this wonderful talk, despite it was long, as our master said us. I have a short question. You've mentioned that the APC mutation carries down the power of KRAS and TP53. Do you know, in general, what's the mechanism of this benefit?
Oh, we don't. We really don't. That's why it's interesting. I think it's interesting, but we don't know why. We don't know why.
The same for the other tumor, for potential carcinoma.
No, so it's very different. Very different. The ctDNA, first of all, it's a lot of mutations, very diverse, very heterogeneous. And in the blood, you have it 30% of the patient. So you do ctDNA and you don't necessarily capture it. So there's this shedding. It's like the CEA. Also, it's a little bit like a CEA, an expensive CEA, because you remember CEA, it's not often as high when it's lung or peritoneal cavity. It's the same. Yeah.
Very short. Thank you very much. What is today currently the impact in your clinical practice in treating these patients of these data? Extremely interesting. But what is in your practice now, the impact? How do change your decision and your therapeutic approach?
So when I look at the CT, at the response from the chemotherapy before surgery, I have always in my head the mutations. So I know what I'm dealing with. So it comes at each step, and you have these 5, 6 mutations, not many. It's very easy to remember. So we present the patient, we say it's stage 2 disease, resection, whatever, negative margin, and these are the mutations. When the patient is presented, it's presented. Now, does this change what we do? Yes, it does, because it's changing slowly. It's changing the surveillance. It's changing the adjuvant chemo, not pushing for adjuvant FOLFOX. You know, another 4 months or 6 months of FOLFOX after surgery, when the ctDNA is negative. Why should you do it?
Thank you so much. We'll have we have some time left. You addressed something which we also do ctDNA, and we're exploring it at the moment. What we do with it is not, and this is why it's very interesting for us to hear what you have to say and what you write in your paper. One thing you addressed in your presentation was this post-op cDNA. When it's negative, you say this is a marker of the quality or the radicality of surgery. This, I suppose, depends. So pre-op ctDNA, because if it's negative pre-op, just so maybe, but plus pre-op and negative post-op may have a meaning. And you said a marker of the quality of surgery. Would this become standard?
Oh, it would become standard for sure. The idea of the quality of surgery just came to my mind this morning, just walking here. I just realized, you know, we could use that. Yes, we do this before everything, before the
Before surgery and after surgery.
and before the chemotherapy also.
Yeah, you said that.
So I think this is something that's going to change.
And do you have the survival curves for the ctDNA plus pre-op and or negative?
Yeah, so this
negative
I
post-op?
presented 2 years ago in Milan. I didn't want to represent slides, but this is so when you have liver mets, it's 95% ctDNA positive. So it's only for lung or peritoneum. So it's gonna be positive. But we have actually a very small number of patients who are negative before everything, before chemo, before surgery, remain negative. But 80% will change with the surgery. So they become, you do surgery, becomes negative in 80%, as I showed.
Okay, thank you.
Thank you.
And it's correctly metastasis, some lesion may completely disappear and the chemo and some other will recur. Using biology, how you to predict complete response to chemo?
No, you don't. It becomes negative because there's less shedding, because there's a 90% response in the liver. But so it will become negative with chemo only, as I showed in this diagram. It's not only surgery, but it's chemo also can make it become negative. Yes, so it's but you still have the remains the paradigm that chemo does not kill 100% of the disease remains. You still have 10%. Even with 90%, you still have 10%.
More questions? Thank you.
Good morning. So I'm here to talk to you a little bit about one of the areas of research in our department and to present our recent results in the area of colorectal cancer liver metastasis. We all know these numbers. We know that the high incidence and prevalence rates of colorectal cancer translate into a high health burden, and making this topic and the research surrounding highly important. And we also know that studies over the past decades have demonstrated that inflammatory immune cells are essential players in cancer-related inflammation and in the metastatic process. And efforts have focused on understanding how immune cells affect tumor behavior at different stages of the disease. We also know these patterns. We know that the tumor microenvironment and the interface between the tumor and the host determine the histopathological growth pattern. And it's already known that different patterns translate into different prognosis. And this desmoplastic one appears to be associated to the most favorable. So the aim of our work was to characterize the immune cells of the tumor microenvironment of the colorectal cancer liver metastasis through the characterization of the T cells and the innate immune cells, and comparing these cells in the tumor and in peritumoral tissue, and comparing with the histopathological growth patterns. So we included 47 patients with liver metastasis who underwent resection between October 2020 and July 2022. At the time of the surgery, the largest lesion was removed, and in the anatomopathological department, 3 to 5 cubic centimeters of the tumor and peritumor lesion were collected and sent to the flow cytometry unit. Most of our patients had about 2 lesions with less than 4 centimeters. The majority of them presented a non-desmoplastic pattern, and the primary tumor was located mostly at the sigmoid, and half of them did preoperative chemotherapy. So starting by acquire immunity, we identify around 60 different T cell subtypes, and we verified that these T cells were significantly lower in the tumor samples, except the TCD4 cells that were more frequent in the tumor samples, which means that this tumor microenvironment has less cells with cytotoxic activity. When we analyze the frequency of these cells within the patterns, we realize that the T cells with cytotoxic capacity were increased in the desmoplastic samples. So this may justify its favorable outcome associated with this pattern. Regarding Treg cells, the role of this cell is not consensual, but in our samples, they were significantly increased in the tumor, and suggesting that they are associated to an immunosuppressive environment, promoting a more anti-inflammatory microenvironment and reinforcing the resistance of the tumor T cells. Regarding the T follicular cells, this was a kind of a surprise, so it was not according with the previous results, because the cytotoxic cells that were previously the CD8 that was previously low, here in this subtype, the follicular one, they were high in the tumor samples, and this follicular CD8 included has a higher capacity or cytotoxic capacity, so they are in higher density in the tumor, which probably means that the tumor cells must exert some kind of inhibitory mechanism to suppress the immune function of these cells. We also evaluate the functional phenotype of these cells, and we realize that the tumor has a lower frequency of T cells with Th1 phenotype that has a cytotoxic activity, showing a tendency to increase interleukin 17 producing cells in these tumor microenvironments. And we also verified that as the tumor burden increases, the density of these cells also increase. We also analyzed the activation phenotypes of these T cells presented here, and we verified that most of the T cells in the tumor are in an intermediated stages of activation, which probably means that it is likely they do not reach full immunologic capacity. So, regarding innate immune cells, the percentage of immune cells does not present any significant difference between the tumor and non-tumor, except the files and kappa cells that have the cytotoxic activity. So in the tumor, they are in lower frequency. So this favors an immunosuppressive tumor microenvironment. When we analyze the monocytes, and we know that they have an impact in tumor progression and in the metastatic process, so we evaluate the subpopulations of these cells, and within each subtype, we analyze the density of this pro-tumoral phenotype, the M2, and that is identified by these two membrane proteins, the CD20, these CDs here. And these CDs correlate with aggressive disease progression. We did not saw a difference between the tumor tissue and non-tumor tissue, but when we compare with the histopathological patterns, we observed a lower percentage of these M2 macrophages in the desmoplastic growth pattern. And this finding is in accordance with the fact that these desmoplastic pattern are more likely to have a better prognosis. And considering these previous results, we analyzed the tissue or the concentration of these monocytes in the tissue, and we were able to identify two different groups based on the frequency of these cells. A group with higher percentage of CD 206 and 274, and another group with a lower percentage of these cells. And we found that the group of patients with lower percentage of these cells were associated with higher disease-free survival. So these results cannot be integrated in an easy way. It's something complex, but we can affirm that the immune microenvironment of colorectal cancer liver metastasis lacks of infiltrated lymphocytes and presents an immunosuppressive profile. The desmoplastic pattern presents a more cytotoxic T cells and a low density of this M2 macrophage phenotype. Which justify the better prognosis. And there are some potential applicability of immunotherapy in some of these findings here, but we need obviously more research to this topic. And if we are able to translate these results to the liquid biopsy, we will probably help to improve the treatment strategies to these patients.
Patient is Pietro Adeo, right?
Not an immunologist, but just one question for methodologists. You say to us that you analyzed the biggest metastasis, the larger metastasis. Seldom patients with colorectal metastasis have spirobar disease. Is there any data about immunologic heterogeneity between metastasis sites?
Yeah, we know that there are heterogeneity, but we have to establish one method, and we choose the largest size. So we know that although there is heterogeneity, the percentage of concordance between the lesions are high. So, but we cannot ensure that the lesion that we analyze is similar to the rest of the lesions that the patient had. So like a method thing, not something we saw right in the literature. That should be the largest one. It's like a criteria to select.
Okay, thank you. Second question, you tell us that this kind of situations, that the tumor produces a kind of immunosuppressive. How you can modulate the practice with immunotherapy?
So all of these cells that are associated to this immunosuppressive phenotype can be targets in some ways. There are some techniques described regarding, let's see, Treg cells, techniques depleting these Treg cells, or targeting CD25 that target this intermediated stage of activation. So we can supposedly target these cells that contribute to this immunosuppressive environment, but there's a lot of interactions here. We don't know for sure. There's nothing already conclusive regarding that.
Thank you.
Questions?
So what makes the liver so, it's very immune resistant?
It is.
Why? It's what the sinusoidal, it's like the spleen, or it's full of sinusoids and what makes the liver so different?
I don't know how to answer that. There are a lot of other cells that need to be considered. Not only these E cells, okay? A lot of other cells in the liver. I don't have an answer for you.
So I like, the desmoplastic reaction. It's the angiogenesis type of, right?
Mhm.
Of development of metastasis, the
Yeah,
desmoplastic
it's not
reaction.
by
That's when you have this 90% response to chemotherapy. So that's a very, and it has implication like bevacizumab is, they are very responsive to bevacizumab. I think what makes it so different?
patterns are not associated to this angiogenesis for vascular cooption, so the mechanism is not the same.
What makes it one side or the other? No.
I don't know.
And
I also
cannot,
It's just related, if I may. You have shown that the desmoplastic metastases are linked to more cytotoxic cells.
Yeah.
So do we know, can you speculate on whether the cells are creating the desmoplastic feature or whether it's the desmoplastic microenvironment that brings these cells?
We don't know if it's a cause or consequence, right? The existing cells there, so I cannot answer that for now.
Can we isolate these cells and inject them in a normal liver somewhere else, in mice, for example?
These cytotoxic cells? Yeah, we can. We can.
so thank you for your good work. I know a little bit about this through colleagues who study renal cell and prostate. And one observation is that when the genitourinary cancers metastasize to the liver, they become immunoresistant. So this gets back to Jean-Nicolas' question. We have some interest in autoimmune liver disease, and the liver is very rich with long-lived CD8 memory, and also the NK population and specialized dendritic cells. So these might contribute to the immune microenvironment of the liver that makes it so resistant to immunotherapy. Just a suggestion.
More questions? Okay, thank you very much.
To the next speaker, Professor Guido Sottili, who will speak on airborne vascular revolution.
The last slide, and I will finish because it's a little bit longer than scheduled. So nothing to disclose. I would like to, the premise could be cut, of course. Resectability is something that is not well defined. What do you mean with resectable? And then I started provocative talk. I mean, the dogma is amputation and amputation because there are no other solution. The parenchyma sparing is here in the corner with radiofrequency. A sort of Ptolemaic ideas of the universe. Indeed, the aim was the hard zero. Stage procedure were based on that. And then the solution that you could have in this kind of concept of the universe of solution for the liver is a few opportunities in terms of resection. And despite the good one is still high, the mortality is not negligible. So the dogmatic background is that the solid complexity of the organ is not transparent, but inside is really complex. And then we have if you don't want to explore the complexity, you have to interact with the in and out, and then based on the occlusion, division, or whatever, following the vertical dissection for what it appears on the surface, according to the manipulation of the hilum. The hereticals, those is the Galileo, and that this is the concept that is, I think, is really fascinating. Surgery is intra-organ, main only part of our body is the brain and the liver. But in the brain, if you move 1 centimeter, can be a disaster. While in the liver, the cells are doing the same function everywhere, not like in the brain. So you have more facility, the degree of freedom. And then could think about something that is keeping scaffold, exploring the complexity. And the concept is the R1 vascular. The R1 vascular as the background from where is based on the surgery of the IVC. This is the paper of 2001 in Tokyo, and it was related by the fact that, and it was also in relation with what I saw yesterday, the experience in Tokyo University, they were always detaching as much as they could the inferior vena cava, and this is a case of real operation. This patient received surgery without substituting the inferior vena cava. So this was stimulating me the idea of detachment, and this is a case that we did. This is the inferior vena cava. This is a cholangiocarcinoma in segment 1, and this is the intraoperative finding. It was published this series in Journal American College of Surgeons. This is the inferior vena cava. This is the canyon after the detachment, and this is the specimen. Here was the tumor. The tumor. Here was the inferior vena cava. The anatomy is the other aspect, and this comes from the fact that the intravascular main vessels are, in the fact, separating different organs, extra segment, bone, and whatever, and then it is different, theoretically and conceptually, with the parenchyma from the vessel, and then the leg neck capsule. We know that as the inferior vena cava, all the intrahepatic vessel and the surface of the liver is covered by capsule. This enforcing the division between the extra and the intravascular. So if it is true, we detach, and we challenge that. This was the first paper in which we were promoting kindly the idea of the detachment that was started in 2004, and then we published and knows these results that has been confirmed several times, and then R1 vascular became for us something that was going to be common practice. These are large tumor that can be treated with R1 is everywhere. This patient should be unresectable. Nowadays, probably addressed other center, but this patient was treated with vascular detachment with several solutions. And the other aspect is the parenchyma sparing vascular amputation. You can also amputate the vessel, but taking profit for the anatomy and the fact of the reaction of the liver to the compression of the outflow, the development of and enforcement of the communicating vein, you have the chance to offer surgery. And nowadays we can predict in this paper on surgery the presence or not of communicating vein based on the density at the contrast enhancement CT of the parenchyma. This leads us to offer surgery to patients with multiple contact with major vessel cava confluence, like in these cases, and the confirmation of the communication. So it's detachment and amputation combined with sparing all the parenchyma that you could offer. And the rate of major hepatectomy is minimal. And more, this is the main outcome. We can devise in the years a lot of new kind of operation, but there are more operations that could be introduced by any other one. The aid of technology was that measuring the liver volume of this complex procedure could be a problem, but 3D cast allow us to give a pretty adequate measure of the future liver remnant. And then we can shape the liver accordingly. This is a case of, yesterday I saw a case with tumor also here. It could have been an also procedure like this one. Or you can do also just a mid-transverse hepatectomy when the cluster of the lesion is in this fashion of presentation. According to, you see, the unique experience that is now published has been accepted in Annals of Surgery. This is our series of 390, almost 390 parenchyma sparing major hepatectomy. The principles, so we have now standardized the procedure, identify the compass point when you have multiple disease, the deepest lesion and the peripheral one of the theoretically visible cluster. Then you define the cluster. You, as a negative picture, you can define the resection line. The resection line define you the remnant liver. Then you can calculate the future liver remnant and estimate the possibility or not to do surgery for this patient. This was a real patient, and this is the result. Sliced liver hepatectomy. In and out is fully preserved. Incremental complexity. In our experience from 2004, we were increasing, splitting the period in 5 groups, the complexity of the disease that we were facing, and the tumor burden score was more than 9 in 55%, the FONC criteria 64% at 3 to 5 points. This is a single cluster hepatectomy. 2 cases of this one, of this kind of surgery. And the evolution of the complexity, incrementing the patient with the tumor in this position, in bilobar setting, and also the R0, was quite stabilized by around 20% of our series. This is another example, but move on. This is the sliced liver combined with the liver tunnel. Technical evolution means that with these 3 pillars, the 2-stage hepatectomy has extinguished since 2017. So nowadays, since 2024, do anymore the 2-stage hepatectomy. And this is despite the fact that the complexity, number of resection area, and number of resected tumors decrease the ratio, it means more complex disease. And the short-term and long-term outcome, the safety is always 0.8% is the mortality. Yes, 0.8% is the overall mortality. Here, 0.3 at 90 days. The survival, more than 10 and less than 10, more than 10 were 40% of our series, more than 10 lesions, is equal. Of course, the recurrence-free survival is significantly different, but not so different, I may say. I could expect more. R1 and R0, R1 vascular, are performing better. R1 parenchymal is dismal, vascular and parenchymal is that should be taken into account, especially for the larger, which is not rare. But the other aspect in advantage of this procedure is 76% of our patients had the possibility, in case of liver-only liver recurrence, reoperated. And this means a lot. 64% of patients had resectability at the multidisciplinary team. And moreover, those who had the redo hepatectomy had a survival approaching 60% of 5 years. So it's almost a transplant survival. And the comparison, and I am finished, we did comparison previously that this paper, this was the short term
compared to the two-stage and to the Italian registry of ALPS, it is better in terms of safety. The overall survival, we don't have the dropout. And the recurrence-free survival show that the two-stage does not select the best patient because in the case my series, the recurrence-free was equal between the two groups. Concluding, well, we are, I recall as I did in Coimbra, the quantum physics. As you know, when you observe something, you modify the object. The observer is not neutral with the reality. So because something has multiple states. And delivery is a fantastic example for that. Entanglement means that if you observe a one particle, you can observe, you modify everything, also a particle that you are not observing. They are correlated. And if you think about in medicine, a similar aspect is the abscopal effect. You treat one disease and the other disappear. It's a quantum effect. Then with this concept that you use of your cellular phone and whatever is based on physics theory that has proven, and your life is impacted by that. Well, I think that the delivery is a sort of quantum organ because the observer can modify the observed according to a lot of factors, and instead of a few opetectomy, you can have infinite solution in such a complexity in an intra-organ environment. The positioning of this approach is between the intrusion of the robotic surgery and the transplant. We will see. Thank you very much.
Yes, very impressive. So the description is Dr. Maxime De Wolf, yes?
Thank you very much. You wrote a beautiful position statement in BGS lately on the open surgery being an innovator for minimally invasive surgery. I'm very interested to hear your opinion if you show this beautiful resections, roller coaster resections, tunnel resections. Do we have to try to do this minimally invasively, or what is your opinion? Do we make the quality worse?
No, but the paper that I wrote in BGS was related with a face-to-face discussion at the ESSO with Mathieu Don. And I was just showing that, you know, it's particular because I think that we did an innovation in technique, in surgical technique. And now when I discuss in the session, it looks like if I am a middle-aged surgeon because I defend the open surgery. But I just want to stress the fact that technique, there is no improvement in surgical technique by the minimal access. There is the major improvement, and what we did in the 20 years are something that is provocative and maybe follow it. I don't know now if it will be completely done also. And I think in the interest of the patient, this is not a clue for you know, really. And then the safety and the interest of the patient is the most important aspect. So I was just claiming that in that paper because I want the young people should be fascinated also by this aspect, not only of the fancy aspect of the, you know, the computer is important, but what is important is the computer is let you having to see a lot of things, but the interest is the object that you're looking at, not the computer. The robot is the computer. That is facilitate some kind of approach. But we have to keep in mind, first of all, that there is a conversion. Now that very famous minimal access surgeon claiming nowadays a completely different recommendation, you know, minimal access should be pulled down. I think that in the interest of the patient, this is a major advancement. It is not the clue for me now, try to transfer in the, at first I want to that this technique established in many centers can be repeatable. At that time, someone will try to, maybe not me, and it's okay. But results should be the standard of reference is that.
So I think the question here today is not about minimally invasive.
Yeah, but it was
No, sorry. I think we should discuss about what your techniques,
yeah,
which are very impressive. You show unique procedures. Number one, who else does that kind of surgery outside of you? And is it reproducible? And is it a problem when you have 10 metastases on the right liver to just do a right liver? Because you have 0.7% major hepatitis. So I mean, you never do a right liver.
very good.
When do you do a right
Fight by the tube, and they have no solution. So the parenchyma sparing is the right hepatectomy. Could be something, but there are many surgeons. You know, really, roller coaster. I have many pictures I receive on WhatsApp several times. I mean, they are not coming from a study center because if you have a tradition, it is difficult to change. For me, it's difficult to make robotic surgery. You know, but I think we are an established center. And then, if you have a tradition, it's okay. But in the community of the growing group, in several countries, I have hundreds of visitors that are coming in our institution. They came back and they do it's surgery, so they offer similar results.
We don't. What I say, this is the perfect demonstration of mastery of anatomical liver resection. This is sure. I only one critic. It is the title of your presentation. It's not that. It is my biography, your CV here, totally. Perhaps you miss one or two abstracts. You have to correct this.
Can I make the answer? You know. I agree. I fully agree. I have to stress the fact that there is a history. And if I am the unique and just show the muscle without publication, is nothing. I always try to publish. And it was difficult because the referee were always very hard with me because you have to convince the community and it takes time, 20 years. And is not yet convinced sometimes, but it's okay. This is the scientific discussion. I am pleased of that. So I am not, he said that I am unique as a group, which is not anymore the true, but in some part has been. And then who can I cite to prove? I have to cite myself. It's an over-citation, but if I do not cite, they cannot see my story. And if they don't see the story, they believe that I'm a crazy guy that suddenly doing something that is foolish. It's not foolish.
So you're only one to, you may not be the only one to do it, but you're the only one to publish it.
Yeah, I mean, I think that publishing is.
I respect very much what you.
No, but I understand. I mean, I think in the interest of the communities, publishing is. I don't know. If you don't publish, you don't exist. I heard a great surgeon that was saying this in a meeting, and it's true. So I have to publish, and I like to publish. It's difficult. And what will remain of you is that the citation I tell to the surgeons that are now so fascinated by the multicentric study with 2 million cases, looking whatever. Remember that this has a big citation, few short time, and you have a good index, and you win any application to become professor. But in the long term, if you do something important, it will be cited 20 years later. This is the success.
I would like to go back to a couple of thoughts. But one is, this kind of surgery is good for desmoplastic tumors, not for infiltrating a budding. And
was
this is,
expecting
I think, biologically is also the other thing. In desmoplastic tumors, you see that the Linux capsules thickens, and you can develop a surgical plane in this. Can you comment on those 2 points, which I think are crucial? We do that kind of surgery when needed.
In the interest of time,
you have time.
Take your time. Take your
I
time.
didn't insert the publication that we did, and we explore exactly this, and the replacement grow pattern is unfavorable. But in this case, you know, we minimize the contact and we did the partial resection, and we have a lot of cases. So when you cannot, of course you do the partial, most of the time, you minimize the contact.
Yeah.
There is a...
Okay, Guido. It's a very interesting talk as always. I want to stress some points. First of all, I think discussing minimally invasive makes no sense. It only makes sense if it adds something, adds some advantage to your technique. There's no sense to change the technique. I think we will see later if with the evolution, if it can be applied here or not. Two questions about the urban vascular and the detachment of a tumor. It's a little difficult for me to understand the limit of the detachment, because we're shown here a cholangiocarcinoma with extensive compression of the IVC. And in that situation, I would say it is very difficult to detach the tumor. So this is one of the questions. The second thing is, your technique you've shown that has very good results. And we come back again to the issue of reproducibility. I think this is the next step for your technique, is to show that this can be done and this should be done in many other centers. How do you propose to do that? Because I really think it should. So how do you think is the way to expand this to other centers?
The way of expanding our center is transferring the ground. I received colleague and I help them if they have, you know, in India there are a lot of surgeons that are doing this kind of surgery. A lot. Of course, most of the people that are visiting me are coming from the country that has less scientific impact. Like East Europe in general, all the I do not receive so many colleagues from you know, Western countries, because the tradition is stronger. So I can understand, and it's difficult to change some policy. It's a question of time. But nowadays, publications are starting. There are some upper transversal described by other group tunnels and whatever. You know, I cannot. I already travel a lot, and everyone say me why you travel a lot. But I cannot also go there and operate. So it's they have to apply. Way.
I'd like to make a comment and a question. Number one, you're obviously very smart, so thoughtful, and you try to make people understand. And I think we understand better and better what you're doing. I'm showing later the cholangiocarcinoma R1, R0, R1 vascular. And I was working with residents, and he couldn't find the answer in the pathologic report, because the pathologist has their R1 but doesn't know what's on the other side. So one very important point is that don't expect that the R1 vascular or R1 parenchymal can come from the path report. It's all in the operative report. So you have to make this clear to everybody, that they have to write exactly in the operative report where they're doing, if they're detaching, if they're coming into contact, if they see the tumor. I think this is the only way that the results will go around, if you see what I mean. My second thing is the difference between R1 vascular and a hepatic vein or the cava. and a Glisonian pedicle. On a Glisonian pedicle, I don't like to shave the Glisonian pedicle because what you do when you see that, you do that is you open the bile duct and you have biliary fistula. So when it's in contact with the Glisonian, I think, and I'm asking you, we should resect the pedicle which is in contact. Because the hepatic vein you can repair, and the vein is alone. So you stress in your papers that you don't make a difference between our R1 Glisonian and our portal and R1 hepatic vein. Can you comment on that?
We have now the data, and there are no difference in terms of recurrence, but there is a bias. The bias is when we have a slight dilation of the bile duct, even sliced, we cut. We do not accept because there is the possibility that, and the circumstances in which we have some recurrence are at the portal bifurcation, when there is a tumor, the main trans, without dilation, but maybe bracing the.
Because when you shave, you leave tumor cells.
And at that time, you have at that time you have no chance. It's a portal bifurcation. You found the detachment at the end of the resection, a tunnel or whatever, and then what we do is the burning the capsules superficially, not avoiding, any biliary fistula. Only that if it is detached. Otherwise, at that time, if you at the end of the resection you underestimate the contact, and you cannot detach. You have to close the patient with the tumor inside. So we remove and we burn it happens sometimes.
So you think that Venus R1 is better than the
Venus
Glisonian
offer,
R1?
yes, Venus
But
offer
I haven't read that.
But we are going to make this paper ready. No, it's true that it's ready. I have the quote, but the interest of time.
Yeah, one last comment for me. When you do this kind of surgery, it's important to warn your oncologist, your pathologist, and your patient that you will get under one vascular resection. Otherwise, they'll be disappointed afterwards. It's important to educate.
My check of a patient, every patient that 1.5 hours of explaining everything. So, and also knowing the family and whatever, because I am very careful in.
Maybe a very short question. Ido. Oui. Simple question. Technique is changing. We started in the time from Bismuth with 1 centimeter margin. We go now to the 0.0 R1 resection. Brilliant technique, but now looking in the future, what's going to happen? Do we parenchyma sparring and targeted therapy or transplant? What do you think?
The question of the transplant, I think that the transplant is an important advancement. As nowadays, the transplanted patients are tall, not me, blue eyes, not me, with hair. Selected patient, highly selected. So, and then nowadays we clean the dust. And I think that we have to define the burden. And then we are investigating essentially the next step is to challenge the series of the transplant. Unfortunately, we have to ask because we do not do the transplant. I think that it will be like ACC. Surgery for the ACC didn't disappear. So also for the metastasis, I think surgery still will appear, and this kind of surgery will be more and more important also for them.
Yes, I have a comment and a question. The first comment is, I understand, you should understand why it's so difficult for you to convince the community, because you're too good. Because when we see your result all these holes in the no biliary fistula,
8%.
no access, no morbidity, or very few, no mortality. It's very difficult for us to understand that, okay? And I want to know your secret to avoid all the morbidity of liver surgery. Second point is there is a hole between what Jean-Nicolas showed us about the biological. Your results, again, are amazing about those patients with more than 10 metastases. This is macroscopically. And it's difficult for me to understand how is it possible to have such good results with so many metastases. You show that you reoperate and you have 50% of survival at 5 years. It is really amazing. It's not reproducible.
But it's not true, because the two-stage hepatectomy, the only difference is that you don't count the lesion. You remove the right liver, whatever. Then you can have 100 lesions, but you don't know. You don't have the interest. You have the interest in counting on the left side because you have to remove. But the right side, you count. And then we have to count exactly, because if we miss one, is a recurrence. So we have to study in detail the disease. And then we know exactly the number of the lesion. The maximum is 83. And
how many?
83.
Okay.
From 83 to 50.
So how do you
You
select?
can count.
Please excuse me. What is for you the contraindication? What is the limit of your technique? No limit? 83?
There are limits. If it is
Which one?
scattering and there are no areas which I cannot find, there are no free areas, or the free areas are not enough to warrant a 40% of liver remnant, this patient is not resectable for us. Both. We always do the MRI because the detection of the tiny lesion is mainly done with the EOB MRI.
So how do you define an area? What is an area for you? It's a subsegment or it's an area? What is an area? Because you can have how many areas in the
infinite. In reality, almost not finite, because the quantity of surgery is finite, but uncountable areas. Any micro areas is a micro segment. So conceptually, you can identify the area in which there is in and outflow, it's okay. And if you look, and another concept is nice, very nice, is I have the picture, and I want to publish this. I have the picture of all the operation. Look at the margin, and we divide the dissection without clamping and whatever, just following the arboring of the anatomy. And then you have the margin that are perfectly perfused, so there is no ischemic area.
So you'll continue with but we have two very short questions.
Very, very short. Yes. Thank you very much. Just one question. Today, yes, what is,
Quick question, we can.
yeah, what is today your indication for liver transplant? For patient with the colorectal liver metastasis?
When there is a scattered lesion in which I cannot identify any part of the organ that can be preserved and achieve 40% of the liver, future liver. Then to me, and if it is under response and whatever, I start addressing the patient to the liver transplant to Bologna several years ago. The first 5 that they did, 4 were my patients.
Of all patients that are referred to you, what is the percentage of these patients you recuse for surgery or you don't do surgery on?
64% of patients are resected.
So that means 36 you recuse.
Okay, the liver surgeons do not understand you because you are not using the same concept. You are not a liver surgeon, you are a liver sculptor. And so you are a student of Professor Makuchi, and I know the meticulous way they work and the long duration of operation. What is the duration of such type of procedure?
This question was the last one that I was missing because it's an important question because substantiate the fact that it's a meticulous surgery. We occupy one room for one patient, 12 hours, and mean number of hours is 8.
8 hours, okay.
Only the way of, you know, if I conclude, I said the three communication, the three presentation this morning, we see the reality of the metastatic tumor liver by the biology, by the immunology, and by the morphology. You are the architect. Okay.
Next presentation by Dr. Mel from Houston. Disappearing colorectal liver metastasis. Another very interesting topic.
Okay. Small task to follow Guido. Try it out. So I'm here to address a topic that's very commonly faced by all of us who do liver surgery for colorectal liver metastases. And I'm not here to kind of try to push any agenda, but just to kind of recapitulate the data and ask us to think about this problem together. So we'll start with a case presentation, 70-year-old patient with rectal cancer with a CA41. Staging workup, you can see on CT scan shows a tumor in segment 6, and then MRI confirms that it's there, right? The patient receives Zelox. This is all on the outside, 4 cycles. CA goes down to 4.2, and on restaging, the tumor is no longer visible. So really, this brings up 3 main questions. Number 1, if I can't see the tumor on imaging anymore, does it really mean that it's gone? Can I see it on ultrasound in the operating room? Number 2, if I can't see it on imaging or on ultrasound, does it mean that this tumor truly is gone? And number 3, what do I do with that tumor that's now disappeared or missing? So we already know this. I don't need to belabor the points. We know that colorectal is very common. We know that systemic therapy has become very effective for this disease, which has allowed us to be much more aggressive with surgery, as just demonstrated by Guido. And this here is a schema that we more or less follow, at least at MD Anderson. I know a lot of people follow the same kind of schema where you're going to give chemotherapy ahead of surgery for colorectal liver metastases. So a disappearing liver metastasis, by definition, truly is just a liver metastasis that is no longer radiographically present on post-treatment preoperative imaging. So you can see here on this imaging, some of the tumors that were there are no longer visible on imaging. The true incidence of this phenomenon is difficult to quantify. It depends on imaging. It depends on the treatment that the patient has received. But so what is the incidence? So if you look at some of the data and the studies that have been published on the subject, this kind of sums it up for you. Anywhere between 6% and as high as 50% of patients may have tumors that disappear with chemotherapy. And if you look by tumor number, this number goes anywhere between, again, 18% and as high as 70%. And this is mostly on CT or MRI. Now, here's the thing. We know that CT scan is not super sensitive or specific to the detection of colorectal liver metastases. And at the same time, we know that preoperative chemotherapy that is most effective for this cancer tends to cause problems in the liver, steatohepatitis or steatosis, where the liver then becomes darker and the ability for you to detect these tumors from the background becomes reduced. At the same time, we know that there are some factors that can predict or associate it with disappearing liver metastases. Number 1, if you start with a small tumor, it's more likely to disappear with chemotherapy. If you have multiple liver metastases, almost by definition, some are going to be smaller, some are going to be bigger, and therefore they are at a high risk for having some disappearing liver metastases.
And the more chemotherapy you get, the more likely you are to have some of these tumors disappear. At the same time, we know that MRI is a better tool to evaluate colorectal metastasis. Okay, you have fat suppressing techniques that compensate for steatosis. You have diffusion weighted imaging that use the fact that METs restrict diffusion of water molecules. And you can see that when you compare MRI to CT to PET scan, MRI is the superior modality to detect colorectal metastases. We also know that now MRI, especially with the use of liver-specific contrast agent like Eovist or Primavist, can really help to ameliorate our ability to pick up these tumors, especially in that delayed 20-minute phase, because that contrast is extracted and uptaken by the hepatocytes and later on released into the biliary tree. So you can see that this is a very helpful modality for us to use when looking for liver metastases. And we know that performance of this type of MRI is better than contrast-enhanced CT scan. You can see this study here, for instance, detected 26% of tumors that disappeared on colorectal metastases on CT scan. They were able to pick it up on MRI, and when they resected these tumors, 92% of these tumors were viable. So clearly, there is something to be said about being able to detect them on MRI. But it's still not perfect. It's still not perfect because still 38% of these tumors were still not visible on Eovist MRI. And so you can see here size matters. Size, the smaller the tumor, the more likely it is that you're not going to be able to pick it up, whether it be on CT scan or even on MRI. So if you look then by whether you're able to pick them up on ultrasound, so if you cannot see a tumor on CT scan, if you cannot see a tumor on MRI, how often can you see it on an ultrasound? That's the next question. Well, again, you can see here, this is a summation of these studies. Anywhere between 10% of the time, you're going to find them with ultrasound. As high as 60 or 70%, you're going to be able to find them on ultrasound, right? But again, you can see the range is very wide. So the question is, if you can't see it on CT scan, if you can't see it on ultrasound, does it mean it's a true complete response? That's the key question. Is it a true response? And that's defined in two ways. Either it's a complete path response, meaning you take out that tumor, you take out that area, and when you look at it under the microscope, there's no viable tumor left. That's a complete response. Or if you don't remove it and you leave it in place, there's a durable clinical response where after a prolonged period of time, the tumor will not return in that same spot. Definition of true complete response clinically. And if you look at that, again, how often do you have complete response? Again, wide ranging, but as low as 17% is that the case, as high as 70%. So if you want to sum it up, really, a disappearing liver metastasis does not imply true complete response. So are there things that we can do to try to find these tumors now that we understand that they're not truly gone? So we know, number one, there are such things as enhancing detection intraoperatively with the use of so intraoperative liver ultrasound, of course, we know is central to liver surgery, but by using contrast enhancement, whether it be with SonoView or Sonozoid, you can potentially increase your ability to pick up these tumors. And Guido has published on this, as have others. Now, despite this, though, unfortunately, even with the use of SonoView, the sensitivity of ultrasound is only barely improved in terms of the ability to pick up these tumors. Sonozoid seems to be a little bit better, including at detecting tumors that disappear on MRI, on Eovist MRI. And if you could not find them on contrast-enhanced ultrasound, it did seem to have greater correlation with true complete response, whether it be path response or durable clinical response. Another technique we use is the placement. Fiducials are these little metallic clip that you basically place in the area of the tumor. And it's kind of like X marks the spot, right? You bury a treasure, you don't want to lose sight of it, you put an X on it. It's the same idea. You put a marker near the tumor or in the tumor or around the tumor, you start chemotherapy, and even if the tumor disappears, you have something to go after. So when we've used it at MD Anderson, of course, the use of fiducial was able to help us detect these tumors. And of course, you're not going to need to do it if the area you're going to remove is going to be taken out as part of a major hepatectomy anyway. So which lesions do we place fiducials for? Small tumors that are not subcapsular, because subcapsular tumors will leave a scar that you can identify before or soon after you start chemotherapy, right? Because you don't want to wait too long after chemotherapy because they will have disappeared. If the tumor is not in the planned hepatectomy specimen, which burrito would be everywhere, and then in the background of the fatty liver, because again, the fatty liver will mask these tumors more so than a non-fatty liver. And you can either mark the tumor or you can bracket the tumor, but these are ways to do it. Another way to look at this is the use of ICG or indocyanine green. There's a lot of centers around the world that use this technique. They inject ICG green as early as 3 days before surgery. And what happens is that because the tumor tends to cause a halo effect, basically the drainage of ICG from that part of the liver is compromised. It will collect a little bit of a green halo around the tumor. And you can see that in this particular study published just a couple of years ago, with the use of ICG, they were able to detect 5 tumors that were not seen under white light. And when they resected them, they all had cancer. And then another technique you can use if you cannot find the tumor in the operating room, despite everything that you do, is do what we call a completion ablation. So for those that you cannot find, we're not going to do blind resections. That's not indicated. And so what you do is you clear all the ones that you know you have to clear because you don't have better alternatives. So look for the ones near Gleasonian pedicles, look for the ones near superficial lesions, near the stomach or the colon where they cannot ablate it. And then later on, you rely on your colleagues to do the ablation. And in fact, with the use of software imaging that allows them to calculate and map out margins, their ability to ablate tumors in the liver is better than under ultrasound guidance. And that's because they have not only CT guidance, contrast CT guidance, but also, like I said, software that allows them to map and see whether they've achieved the intended ablation zone. So what are the long-term implications of disappearing liver mets? So if you don't remove them, the median time to recurrence will be 6 to 8 months. And half the time, the tumor was disappearing somewhere else. Now, there's some data to suggest that the use of HAI pump can, in fact, decrease the risk of intrahepatic recurrence when you have these disappeared liver mets. But despite the reduced recurrence, the survival is no different. So even if you don't treat these disappearing liver mets originally, and you end up treating them later when they recur, the overall survival does not seem to change. So here's an algorithm that kind of recapitulates and kind of inserts into the picture where people could do things. I'm not saying we have to do all these things, but these are the strategies you can use. So certainly you can place fiducials early. If you're going to do pre-op chemotherapy and you're going to go to surgery, consider ICG. In the operating room, things you can do is add contrast-enhanced ultrasound. I know in the US, we don't have access to that. If it's completion ablation, and worst you can see here, as Dr. Vote presented earlier, we do use ctDNA to guide us, but if it's missing and you can't do a completion ablation, you're going to follow them, and if they recur and when they recur, you'll treat them. So, in summary, disappearing liver mets does not mean complete response. You can set yourself up for success by understanding what can predict disappearing liver mets. You anticipate the phenomenon and you plan accordingly to limit chemotherapy, place fiducials. In the OR, you can use certain techniques to help you enhance your ability to detect them. And if you can't, you can still do completion treatment. At the end of the day, though, there's still no consensus on the management of colorectal liver mets. If I asked the room how you would manage the first patient I showed, I guarantee you we'd have a lot of different opinions. And so I don't want to ask the crowd. Although the recurrence risk is going to be high, there does not seem to be survival difference as long as you follow the patient and continue to treat them at the end of the day. So I thank you for your attention.
Thank you
very much. The discussion of Dr. Guilherme Marina.
Thank you very much. Congratulations, Franco. It's a very brilliant presentation and much up to date of the issue. And after this, obviously, and you said quite rightly that we probably won't be in much agreement, and that doesn't mean any of us are doing wrong. But when you go and look for disappearing colorectal cancer metastasis in PubMed, you will find that for disappearing, you'll find 900 entries. Yet, if you look at it from missing, you'll find 400 entries. It'll also come under vanishing, vanished. So there's not much agreement in there. And actually, when you look at it, in fact, we are confronted to the epitome of a surgical dilemma. And to start with, we don't have much agreement on that. We don't really know what we are naming. I mean, what are your thoughts on that?
Yeah, I think the terminology can be different if different people use it differently. I think there's an implication, right? The concern is vanishing. It can imply that the tumor is truly gone. So some people prefer to use missing because they think it's there, but it's just missing. You can't find it. So I think it depends on how you want to think about it. There is a proportion of tumors that truly are gone because of very effective chemotherapy. We see it, complete path response does happen, but it's still the exception rather than the rule. So I think whether you want to use vanishing, disappearing, missing, hiding, that's okay, as long as you understand what's implied by it.
But yet, let me push the idea, because one would think, okay, disappearing colorectal cancer, it's clear in our mind, that should be the name. And probably other names just sort of stay out of history. But yet, there's, for instance, a very nice paper on directed surgical orientation for treatment of these lesions, published less than a year ago. And the title was surgical oriented vanished lesions and disappearing, and they're referring to that.
Yeah.
But I mean that if some of the information is going other ways, we are missing information. We are actually missing. It's disappearing in the stream of.
I think that's a fair point. I think that's a fair point. We should try to use the same terminology.
Yeah, we should reach an agreement on that to start with.
Yeah.
Yes, and then because you have a very big you work in a very big institution with a large number, but yet when you, for instance, you publish on fiducials, you were talking about 38 patients, which is not a large number coming from a very big institution, and it's the main experience of all the groups you've presented.
Yeah.
So that means that every group may be acting differently and have their own way of doing, but we don't have a sort of. It comes out very nicely what we should do, but at the end of the day, it's not the case because there's so much scattered information. It's not concentrated.
Yeah. No, again, I think that's fair. We use, personally, at our institution, we use fiducials selectively. We don't use it for every scenario. We use it when, again, you plan on going after a tumor where it's going to be isolated, where you need to go after it. To be honest with you, now with more data supporting ablation as a good option for liver mets, you could make an argument that as they go in to place a clip, you might as well, you could as well have them just ablate the tumor and be as effective, right? With now the collision trial and other things like that. I'm not arguing that it should replace surgery, but I think you can afford to be more selective and thoughtful about when you want to use what technique.
Okay.
Yes, thank you. I appreciate it a lot. I was told that the 1 centimeter tumor is 30 million cells. That means that when you reduce to 10%, it is 1 million cell remaining. This is why at surgery for colorectal liver metastasis, I always ask to put the first CT scan on the screen in order to do surgery. And when an oncologist say, oh, I did a very effective treatment, 5 nodules, now there are 2. I say it's a catastrophe. So we have to now look for the 3 disappearing metastases. So I think that you gave a good definition of disappearance of the tumor. I agree with you. That means, for me, it is 10-year survival without recurrence. So my question is, do you think today, even with all the new efficient oncology treatment, do you think it is possible to have a tumor disappearing totally? That means all the cells disappearing without resection. That means today, can we consider a treatment, maybe cure, without surgery?
No, I think, look, we embrace your approach. We do the exact same thing. You go off of the original scan before any treatment. That's a true reflection, at least of the visible, the gross disease. And of course, we also know that for every tumor that you do see, there's going to be tumors you don't see, right? So the rule is you should go still after them all. The exception is that chemotherapy, modern chemotherapy, targeted agents can help to improve the ability to have a true complete response. But you can't rely on that. You can't rely on that currently and say, because they disappeared, that means they're gone. So in our minds, they're still there. So I don't think you can quite act as if they're truly gone. Can we get to the point where we can be more selective? I think as we better understand ctDNA, for instance, as we have better informed kind of like AI models that look at radiographic, morphologic, and biomarker response, you may get to a point where you can decide to withhold surgery. But I don't think we're anywhere close to the point where we can say that today, to say no surgery is indicated.
That means that could you consider?
Yeah.
That means. That means that today you consider that chemotherapy is neoadjuvant treatment and that you must resect the patient.
That's still our approach, just like
exactly.
100%.
And the other side.
In the future, surgery will become adjuvant to
agree with
you. Neither do I. So we have 2 more questions. We have Gina, who has for a long time now. Because I'm sorry.
It will go on.
Please quick. Question, quick answer.
But my question was, having said that,
yes,
we all agree, complete response can be only shown on the pathology.
Yes.
The question is, to be pragmatic, what is the take-home message? Meaning, I personally, the oncologist, is to make sure that intermediate clinic to see the patient and to see the imaging before disappearance. However, even if the image has completely disappeared, do you still resect based on the original CT, or you yourself, do you say, okay, I'm going to follow up the patient? I personally resect, but that's what I want to know.
Okay.
What do you want to do?
I'll answer it quickly. Number one, really important for you to work with medical oncology so that you don't have them extended chemotherapy. So only 4 cycles at most before you decide to act if they respond. We don't believe in blind resections. So if you cannot find the tumor, we're not going to resect an area just to say it was there, because you don't know where the tumor has shrunken to. We've seen that with systemic therapy, tumors can shrink this way, that way. You don't know where. So if you can't find it, we're not going to do blind resections. We'll follow them very closely, and then if they recur and when they recur, we'll take care of it.
Just the adjuvant surgery is removing completely complete response tumors.
Yeah, that's.
I raise the hand.
Long time ago.
No, I just wanted to, in the interest of time, remove the slide. We use the 3D cast based on the pre-chemo imaging. And we reinsert the disappeared lesion in the cast of the preoperative setting. And then we routinely, as you imagine, according to our surgeon, is very important and dismal, the disappearance. We recommend it for quick cycles, but they don't care. They do see it. And this is a problem. And the other problem is the imaging of the oncologist when they see the patient, that is always underestimating the disease because they don't care about CT, MRI, and whatever, which is important. And so because of this technique of inserting and artificially in the placement, we used to remove all the lesion, all the disappear.
I think again, that's fair, but I think it comes down to your philosophy and how you want to approach these tumors. Ali.
Do you see any role of radiomics in helping detecting?
Yeah, that's a great question. I think, we already know that radiology can predict the degree of response, right? Morphologic response goes a much better, it tells you a lot more than RECIST response, for instance, in whether a colorectal met is truly treated well. So I think ultimately, yes, radiomics will be part of the different tools you're going to use to predict how well you're treating it and whether surgery may be omitted. But I don't think today we can say that.
Non, c'est pas Laurence. Ce serait
Okay.
Dimitri.
Short.
2 words.
Quick, 2 seconds.
2 words.
So I have, first of all, a question.
No, just first of all, only a question.
Quick comment. Question. When you look at disappearing metastases versus metastases that have completely reduced massively in size, as we kind of saw yesterday in my case, and you explant them and you find no tumor in the scar, but they're visible, do you see any oncological difference in the pathway of the natural history of this disease, completely disappearing versus scar down to a minimum and no detectable tumor in the scar? How do you see the evolution of this disease?
Yes. Okay, this is for the coffee break. No, sorry.
Yeah.
Can you say one word?
I mean, I think if you're going to see it, you're going to take it out, and then we'll see what path shows. I think that's the bottom line.
Very quick comment on ablation. You mentioned that radiologists do a better ablation, but with the new navigation technology, I don't want to mention the company, but
I know that.
I'm sure we know all that.
Yeah.
Do you still think that radiologists will do a better ablation than us using that navigation technology?
I think so, because they have the ability to predict margin on a software and then retreat if they haven't filled up that margin. Okay. We don't have that with ultrasound.
Thank you for this stimulating discussion and topic. It's really think this session is amazing. The next is about minimally invasive surgery. All right. So Dr. Imai from Japan, open the laparoscopic for colorectal liver metastases, right?
I'm honored to be able to speak here today. This is my topic, consideration of hepatectomy for liver mets, laparoscopic or open. I don't mention about robotic surgery today. So laparoscopic liver resection is nowadays a standard approach for hepatectomy. Now we can do almost all procedure of liver surgery, including segmentectomy, sectionectomy, and lobectomy, and so on. However, almost all liver surgeons are still wondering whether open or lap hepatectomy should be done for each case. So in the literature review, most of the papers demonstrated that lap hepatectomy has several superiorities, including reduced blood loss, reduced RBC transfusion, shorter in hospital stay, lower post-operative morbidity, and so on. But most of the papers included only selected patients, such as smaller tumor number, relatively easy tumor location, and so on. There are two RCT comparing RAP versus open hepatectomy for chronic liver mets regarding in terms of outcome. As you can see here, the long-term outcome was similar between the two groups, but you can see the tumor number is very low. So only smaller tumor number, and they excluded major hepatectomy. This is almost all the papers in the between lab and open. The result is the similar, but as you can see, the tumor number is very, very low. So most of the papers were retrospective, and even in matching was performed based on lab hepatectomy. So almost all studies address that lab hepatectomy appeared to be a safe and feasible alternative to open in selected, but what is a selected patient? So what is a good candidate for lab hepatectomy in patients with liver mets? It means in what kind of cases should we avoid lab hepatectomy? Meaning select open. So I read 5 factors, the cases we should avoid lab hepatectomy. So today I mentioned about 4. First, resection and reconstruction of major vessel. So in this case, there are huge tumor invading right, middle, left, big vein, and also IVC. After chemotherapy, the significant tumor shrinkage was obtained. In this case, wrap or rope open. I selected partial hepatectomy with middle right hepatic vein resection and reconstruction. For such type of liver surgery, open hepatectomy should be done. I think open. So in contact with the root of major vessels. So in this patient, the tumor was located in the segment 1 and in contact with the bifurcation of the main portal branch. After chemo, the tumor shrinkage was again still in contact with the main portal branch. So open or lap. Select it open because the tumor was in contact with the Grisonian pellicle, not hepatic vein. So we pick up the tumor from the Grisonian pellicle, and for in this patient, there is no recurrence for 3 years. So open. On the contrary, in this case, the tumor was close to the sorry, the video is not working. The tumor was close to the of the left Grisonian pellicle, but secure the margin.
What's the video? Click on it. The margin is secured. So in this case, the lap hepatectomy is up, I think. Regarding multiple tumors,
Oh, video is not working. I'm sorry. Uh, this patient has three tumors in segments 3, 8, and 5. All tumors were subcapsular and not need to change the body position.
Which side? This one? Okay. What's, I don't understand.
Chicken. A nulla. Oh God.
We'll do without it.
There you go, should have.
Okay, just describe what's on the video.
What I want to say is in this patient, three tumors, subcapsular small, and not need to change the body position. So in this patient, we performed laparoscopic hepatectomy in combination with the primary resection of the rectal tumor. Operating time was about 8 hours, so it's acceptable. This is another case. You can find 6 tumors in segment 1, 4, 6, and 7, and 8. Most of the tumors were very small and subcapsular, except for this one, segment 1 tumor in the deep part under middle hepatic vein. In this case, we selected a laparoscopic approach in combination with percutaneous radiofrequency ablation. So after percutaneous radiofrequency ablation, partial hepatectomy of segment 1 and 4 tumor was performed in spine position and then position to left hemilateral partial hepatectomy of segment 7, 8, and although the surgery was successfully performed, the percutaneous RFA postural change and segmental tumor was very difficult to detect. So very, very long operating time was needed, over 8 hours. In this case, I wonder that RAP approach was truly justified. Should be open. I'm not sure. So regarding multiple tumors, of course, it depends on subcapsular or deeply located, post change needed, or distance to measure vessel, and combined surgery. But within common sense, 3-block resection in many centers, I'm not sure. The last one is in case that the parenchymal sparing strategy is impaired by RAP. This is what I want to say today. We always need to consider the next surgery because recurrence after hepatectomy is very frequent, and repeat surgery obviously influence prognosis. So parenchymal sparing hepatectomy is a crucial strategy for the treatment of liver mets. So parenchymal sparing strategy including parenchymal sparing hepatectomy. This is not just any partial hepatectomy. What we should preserve is not only the liver parenchyma, but vessels. So it is the same with vessel sparing hepatectomy. The second is parenchyma sparing induced by chemotherapy. Tumor shrinkage lead to the separate from major vessels. And the final one is intraoperative radiofrequency ablation as a part of parenchyma sparing. Extended hepatectomy can be avoided by ablating small, deeply located lesions. So this is one case of surgery based on parenchyma sparing strategy consisted of tumor shrinkage by chemotherapy and vessel sparing hepatectomy. Main tumors were located in the right anterior section and involved middle hepatic vein. After chemo, significant tumor shrinkage was obtained, but still contact with middle hepatic vein. We diagnosed resectable and choose open, not lab hepatectomy. We successfully preserved all main vessels. This patient developed multiple liver recurrence 1 year later, but we could perform repeat surgery. So in such cases, I think open approach should be selected. I'm talking about RFA. Intraoperative RFA is dedicated to deeply located small tumors, which require extensive liver parenchyma resection. This is a part of parenchyma sparing strategy. However, LAP, as you know, LAP RFA is technically very difficult for deeply located small tumors. So in this case, other than main tumor, very small tumor were located in the deep part of the liver. For these tumors, maybe wide resection were necessary, so we selected open hepatectomy in combination with 2 RFA. This strategy may be impossible by LAP. So here is a summary of indication of open hepatectomy. For multiple tumors, maybe 3 to 5 tumor max. There is no well-established evidence, so RCT for multiple liver mets will be needed. In terms of parenchyma sparing strategy, the purpose of surgery is not to make incision small, but to contribute a prolonged survival of cells. So we should avoid to impair parenchyma sparing strategy by performing lap hepatectomy. So this is my final slide. Open hepatectomy is essential for patients with liver mets. Lap hepatectomy will probably contribute to expand the indication in the treatment of liver mets. Essentially, however, lab and open should not be conflicting, but to be complementary. So less invasiveness is meaningful only if the safety and curability are secured. The final purpose is longest time survival of the patient. Thank you for your kind attention.
We have 7 minutes for the question. Nobody wants to. 7 minutes. Oh, yes.
So thank you, Professor Imai, for the presentation. The presentation was really important to send the message that of the anatomic factors to consider the minimally invasive hepatectomy, and the main message also of preserving as much parenchyma and blood vessels as possible. But we also would like to hear your thoughts about the technical difficulties of posterior superior segments, such as the 6, 7, 8, and 4A, and the tips and tricks that give to surgeons who are trying to improve their skills in laparoscopic hepatectomies.
Thank you for your comment. Nowadays, laparoscopic hepatectomy is a standard operation for liver surgery for not advanced tumors. So, for example, young surgeons, young liver surgeons start the surgery recently by lab. So the technical aspect, it is very difficult to explain here, but what we can do is it's very difficult to explain, but how can I say? Sorry. The it is very difficult to explain to in terms of the technique. So it is in what I think the important thing is the oncological or the laparoscopic surgery. So we need to teach the younger surgeon the importance of the oncological importance of the liver surgery, including laparoscopic appendectomy. Sorry, it's not
Like,
an answer.
comment. I really enjoyed your talk because oncology is first, and my message, I've been doing laparoscopic liver resection for a long time. And comes the last question when we do a multidisciplinary tumor board. Number one is the mapping of the lesions, and is there an indication for surgery? Number two, what is the operation? Number three, how can we do it? Open or lap? And if lap, no, number three, are there intraoperative decisions? Can we plan the operation completely before surgery? Or do we have to make intraoperative decisions? Often we have to make an intraoperative decision. So basically, if everything is okay and you can do the same operation by lap, this is where you do lap. Anything missing, we do open. So I think that joins exactly what you're saying. So it has to be a completely planned preoperative operation that then you can go ahead for laparoscopy. So I think the discussion, the approach, open or lateral, comes last. And you never change the indications because you want to do minimally invasive surgery. That's what
Indeed, what you said, laparoscopy is a mean, is not an objective.
Yes.
Thank you very much. I really appreciate the matter. It's very good. My concern is about ultrasonography during laparoscopy, and particularly the radiofrequency. I saw that sometimes you said it is open because we have to do some radiofrequency quite difficult. Do you sometime anticipate that and do the frequency pre-operatively in some deep and posterior lesion, very difficult to access laparoscopically, because I think that it's the best way to do laparoscopy with superficial lesions and do the radiofrequency before the operation.
Yes.
Do you think it's a good approach?
You mean another day?
Before the operation, before
preoperative radiofrequency.
preoperatively, you do radiofrequency.
And
Continuously,
yes, yes.
and it's
then you operate.
Do you think it's easier to do that preoperatively with deeper lesion and particularly posterior lesions instead of doing that operatively? Because sometimes I understood that you do open surgery because there is very difficult.
Yes. I understand, and the answer is yes, because but in the same days. I
Just
mean,
at the same days.
yes.
But that's not necessarily the same day. I think it's a very good way to go, and this applies. We see a lot of presentations from the United States of laparoscopic frequency ablation or ablation of lesions. This is very typical of the United States. So I'm looking at you. No, not you. Not the country you live in. So, for example, when you have a pneumoperitoneum, that is do. So in our unit, we do what you say. We do pre-op the same day or not the same day, ablation percutaneous, and then we operate. But sometimes when you work with a good radiologist, you can send a patient a couple of days before to radiology ablation, and then you do. So why do the Americans do laparoscopic ablation? But I know you don't.
So we just do the complete opposite. We do what Hop Dr. Trankau showed, we do completion ablation, always. Because if you do before, you can have a situation where you have, it's done in radiology very often, it's done by interventional radiologists. You can mess up your resection. You can cause damage. So the patient may not be a candidate for resection.
This is a planned procedure. You have one,
Yeah.
7, and
So it's planned afterwards. It's planned afterward. It's planned in interventional radiology suite. That's why the collision trial, the Dutch have showed that very well. If you do the ablation under CT guidance with new software, with IV contrast, you do a much better ablation than microwave and all the things.
Oscar?
What this one do is to put a fiducial intraoperatively and by CT scan guidance afterwards, 3 or 4 days after surgery. What do you think about that?
Okay, we were told that.
Bye.
That's why. Enormous.
of gynecologic ultrasound. Maurizio. Panadería. Which is the ceremony, called the ceremony. And I have to present, I have to present the company. I don't know what we are. No, but there are silence. So I will could be family group, scientific association. Yesterday, that somebody outside say you are a sect. I don't know. We are something, but what is sure, we are people. And the people are not more, but of course, those who are present here, normally I would like to present. I call by name, you call, you come, and you stay in from like here. Yes. So, Argentina, one pickle. Here. Then, Fernando Alvarez.
Oscar.
Laurent Coupeau from Belgium. Laurent Coupeau, Jean-François Gibault, Yann de Ruth, Valerio Lucidi. I have no time. From Brazil. Brazil, I have not the girl. Antonio Cadil, Marcelo Linares, Angelica Andrea, Daniel Shureiva. I put also the associate, the new associate are there. From Colombia, Juan Manuel Rico. From Egypt, Rashford El Masri. France. This is a kind of nepotism. I am Marc-Antoine Allard. Philippe Bachelier, Laurent Daniel Chakli. Ah, Gério. So, Philippe Bachelier, Laurent Chiche, Daniel Cherki, Mario-Anne, Gina Crissat, Guardé. Antonio Sakuna. Already, I didn't. Olivier Choupran. At night. Françoise Van Then, it stopped. Block. Yes. From Italy, Antonio Robecchi, Toto, the first from Bruce from Italy to train with me more than 50 years ago. I love you. Francesco Ardito, the young, the associate, the new associate. Matteo Donadon, Gennaro Nuzzo is coming later. Guido Torsini. Guido. From Japan.
Attendez, Monsieur Felice Giuliani.
Qui? So from Japan, Tatsumori, Isamu Usukawa, yes. Egypt. Combien? Voilà. Ah, Macao, Macao. Ah. José Costamagna. From Mexico, José Luis Beristein. From Netherlands, Marc Bebelmans, Maxime Wolf. From Peru, Ramiro Fernandez. Poland, Christoph Jedewitz. From Portugal, the big now. Almost the sporting. No, nobody know you. Silvia Gomez, William Trayao, Ricardo Martins, Anna Rivo. Now, Manuel Jalis from Spain, Guillermo Marina Real, Ricardo Robles, Victor Lopez, new company, the new associate. Comme Pierre-Alain Clavien et comme Alessandra Pietro Maino, Mathias Fizer, Christian Touzeau, Turc et Ibrahim Assafa. From United Kingdom, John Isaac. Big team. United States of America, Jean Aymon, Andrés Katz, Samo Kikato, Laura Kua, Nicolas Voté, Bob Trankau.
Dimitri and Dimitri Alder.
And now, well, I forget somebody. Venezuela. Nicaragua. And now, the remaining, your duty is to applaud.
And we change the flag. One, two, three. 8 seconds. 8 seconds. C'est bien ça? Much better. Yes. As soon as you can. Very much.
Please sit. Please sit. Please sit. Now you sit.
You're welcome.
Please sit. You sit. Now the opening ceremony is closed.
Conseguiu pegar com a bandeira do Brasil, passou muito rápido.
That's a genuine pleasure to open the after the successful morning, to chair the session with a good friend of mine. So we open the session on the liver, and the first speaker will be Christian Tozo from Geneva. Christian, please.
Yes, thank you. So we discussed a lot of clinical topic, and I switch to some more basic, discussing neoadjuvant versus adjuvant immunotherapy in the surgical management of HCC. Obviously, immunotherapy is now reality and daily practice in the management of advanced HCC. The IMbrave 150, a better survival in patients receiving atezolizumab and bevacizumab compared to sorafenib. We have other lines of treatment that are also available. Regarding the surgical management of these patients, we have some studies out, like this study using sintilimab, which was given after surgery and demonstrated an improved recurrence-free survival in patients receiving treatment compared to those with surveillance on. We have another study, which is the IMbrave 150, which was initially demonstrating some improved disease-free survival compared to surveillance, giving atezolizumab and bevacizumab after surgical resection of HCC. With a longer follow-up, this study is not significant anymore. And today, such a treatment has not entered clinical practice, and it's not in the guidelines. And there is a debate on whether we should give adjuvant treatments, and beyond that, whether neoadjuvant would be better than adjuvant. And this is why we have designed basic science, so mouse experiments comparing neoadjuvant and adjuvant treatment in the surgical management of patients of here, mice with HCC. And our first aim was to investigate how an hepatectomy can affect the anti-tumor immune response, so given after surgery, immune checkpoint inhibitor therapy. For that, we used mice that were injected with HCC cells. It's real 175 cells. And we followed them with the intravitreal imaging system. These cells are bioluminescent, and you can trace the cells and accurately monitor the volume of these cells. On day 10, we performed an hepatectomy, moving the left liver probe. And I draw your attention on the fact that we left the HCC in place. We just performed an hepatectomy of a non-tumoral liver. We further injected PD-1 antibodies or isotype controls, further monitor the mice until cytosis. First, we have seen that by giving the antibodies, we could significantly reduce the growth of these tumors, demonstrating that the antibody was working. Second, by performing the hepatectomy, we had no impact in this model of the HCC. It was a relatively minor hepatectomy, and this didn't change the growth of the HCC. striking is that when we were giving the immunotherapy after the hepatectomy, this was significantly decreasing the effect of the immunotherapy, almost completely washing out this effect as if we had not given any immunotherapy. And the other way to show that is that when we monitor the tumors over time, we can see that the only group which responded to treatment is the one without hepatectomy, just received immunotherapy. And it's the same when looking at the liver body weight ratio, only seeing a decrease in the group treated without hepatectomy. So that means that giving immunotherapy after surgery has less effects than giving immunotherapy outside the hepatectomy setting. We obviously have performed some immune analysis and demonstrating that the immune response was suppressed after surgery. Here looking at CD103 positive, CD8 positive cells tend to accumulate in responding tumors after PD-1 treatment. And we can see that in the animals treated with immunotherapy alone, the gray bar, you see an increase in these cells in the tumors. It was not the case when giving immunotherapy after surgery. And beyond that, the immune profile of the tumors and the TILs, the tumor infiltrating lymphocytes, was sharply different when you were giving immunotherapy after surgery and immunotherapy alone. Interestingly, this effect, so the effect of surgery, was washing out when we were waiting longer. So if we wait longer between surgery and the time we give immunotherapy, the impact of the immunotherapy was less present. This is the pink bars. It's a delayed treatment, and you can see that the effect of immunotherapy was less present compared to the light blue bars, both looking at the volume, the tumor growth, or the liver to body weight ratio. We further wanted to understand whether the immunotherapy was working better before, so as neoadjuvant, compared to after surgery. And we designed another set of experiments, again injecting real 175 cells, monitoring them with intravitreal imaging system, performing an hepatectomy prior to the treatment in some mice, and after the treatment in the mice, but all received treatment at the same time point compared to the injection of the tumor, and we further monitor these animals. Here we look mainly at the orange bars, so the animals treated with either immunotherapy or isotype control before surgery, and you can see that in this specific setting, the effect of immunotherapy was restored. So giving immunotherapy prior to surgery had a significant effect in decreasing the growth of the HCC on the left, or the liver to body weight ratio. Again, also in this set of experiments, in blue, you can see that giving the treatment after surgery compared to isotype control, the dark blue had no effect. Black, the gray bars are those without any surgery, again demonstrating the effect of the treatment. So giving a neoadjuvant treatment had a significant effect, restoring their impact as the one we could see without any surgery. We further performed some sequencing of the infiltrating immune cells. We could demonstrate some altered immune pathways in the neoadjuvant treated mice compared to the isotype controls. This is a list of the pathways that were distributed. And we further, guided by the volcano plots comparing neoadjuvant and adjuvant animals, we further could demonstrate also altered immune profiles in the various settings. Here also looking at adjuvant compared to neoadjuvant and having the neoadjuvant very close to the one without any surgery, and the adjuvant one being far demonstrating also at the immune level a better profile of the neoadjuvant administration of the immunotherapy. So the key messages, in order to remain in time, are that hepatectomy does alter the immune liver environment and prevents adjuvant immunotherapy action, at least in our model. A longer delay after hepatectomy is associated with a better activity. Immunotherapy given prior to surgery is associated with a better function and a better immune profile. And all of that overall speaks and suggests that neoadjuvant immunotherapy should be favored over adjuvant immunotherapy, surgical management. I'd like to thank the whole lab, the core facilities, our supporting agencies, and you for your attention. Thank you.
Christian, as a discussant on this paper was appointed from Waki, please.
Thank you very much for the opportunity to discuss the paper. Beautiful presentation of animal study. I do have a question. While this adjuvant, neoadjuvant discussion makes sense in favor of neoadjuvant in HCC settings, but in a lot of HCC cases are developed underlying liver disease. And even without underlying liver disease, such as a chronic hepatitis B infection, so those recurrence could be multifocal occurrence, not necessarily the recurrence of the original tumor. So my question to you is that in a clinical setting, the adjuvant immunotherapy show the efficacy. Maybe it is because of the immunotherapy is suppressing the neo-tumor, de novo tumor development of the liver, not necessarily treating the leftover tumor from the original disease. So in that setting, this probably experimental model does not really show any relevance to the clinical. I just want your comment on that idea of this de novo occurrence of the tumor versus the recurrence of the original tumor. If you cannot differentiate that in that way in a clinical setting, maybe that's the reason the adjuvant immunotherapy had an efficacy as compared to your experiment.
Obviously, it's true that HCC recurrence can be either the same HCC coming back with cells shed in the circulation and then implant back in the liver, or elsewhere in the body, or the newly developed HCC. At the end, I'm not sure that it really matters. So what we want to have is an efficient way to treat and try to control both events. We have multiple data that suggest that the surgery has a negative impact on the risk of a recurrence, whatever the type. Also that when you leave some more ischemic liver, those liver are more promoting or more at risk of seeing a recurrence coming. I'm guessing also that when you have a complication, those patients with more inflammation might be, but that's a guess, might be the cancer come back. The big question to me is with less surgical injury, when we perform a minimally invasive compared to an open surgery, whether this also has an effect on the overall immune system, whether we can prevent some recurrence, but that's a question I have. And whatever the treatment, the overall recurrence and environment that we want to manage in order to prevent the cancer.
Okay, Professor Vincenzo Mazzaferro.
Yes, congratulations, Christian, for this study.
I have a question on the opposite side of the spectrum on neoadjuvant. I mean, you proved that neoadjuvant may be better, and this is also the evidence of a lot of literature on that. But one of the possible consequences of neoadjuvant is that you have a complete or near complete response on the tumor. The treatment of the tumor with immunotherapy in not a, in a significant proportion of patients in humans is responding very well. And some of the patients, complete response. So the question is, should we, it's like, disappearing metastasis is the same kind of, frame of discussion. Should we resect? Should we operate? Should we transplant patient with complete response after immunotherapy, in your opinion, or not? It's a question that comes from the oncology world. The oncologists were in our discussion, they all, put this question. You had a complete response. Why you want to transplant it? Why you want to resect this patient? Because you have a complete response. Just a question.
So I was last weekend at the EASL, and we debated this question with Sherry Burry, so from your center, regarding transplants. But I guess the same question is relevant for resection. The answer is I don't know, but the current practice is to resect the patients. But really, I don't know, because of course, you have established with the immunotherapy an immune balance, which is keeping the HCC under control, or maybe has treated the HCC fully. And of course, by coming with the huge insults or the huge impacting surgery, whatever the type, because anyway, it's going to have an impact on the immune balance. Maybe you disrupt this balance, and maybe you, in a sense, put the patient more at risk of seeing a recurrence coming later. But honestly, I don't know. I mean,
My answer to the oncologist is that even if you, do not resect this patient, the patient remains cirrhotic. Even if we treat this with immunotherapy, longer is the time after resection or after no resection, the patient remains cirrhotic. So like the previous question, the probability to have another cancer, you have a recurrence, remains there. So this is why in our discussion, I, insist for resection even in patient with contribution.
I would like also to draw your attention to these data, because until now we say we give neoadjuvant because the tumor is still in place, and because the tumor is still in place, there is antigens, and the immunotherapy works better because the antigens are still in place. So this data, because all mice still had the same amount of HCC in place, shows that it might be relevant, but it's clearly not the only factor, and that the surgery itself also has an impact, independently of the presence or absence of HCC.
What about with respect to the immunosuppression therapy? Do you have any thoughts or ideas to share?
So regarding immunotherapy?
Yes.
So I guess there are two questions in your question. So the first one is, has immunotherapy an impact on the risk of rejection? Because that's a concern. So the answer, based on all meta-analyses and gathering all papers and all studies that have been performed, is that yes, it looks to have an impact, and that there is a safe washout, which should be of around 50 days. We published on that recent hepatology. And the second response to your question is whether we should alter the immunosuppression in patients that had received immunotherapy. The answer is we don't know really, probably not really, especially if you have an appropriate washout period. But of course, target for them to be at the higher level of your immunosuppression levels than lower down.
Thank
you. Christian, congratulations on your really nice work. My concern is that we've the compagnons 3 or 4 years ago in the mice and in patients, real world, the pathway of PD-1 and PD-L1. What we know is that only 30% of the patients express this pathway. Okay, so this antibody blocks only a pathway that only 30% of the patients express. If you do the right tumoral line that you inject in the mice and you block that line, you will get the result in 100% of the mice. In the real world, if you do the neoadjuvant treatment of all the patients, you are going to get 30% that will respond, but you get 70% not respond, and you won't have a benefit for the general population, but you have the benefit for that subset of patients that express the PD-1. Because you can have the antibodies, but if they don't have the ligand PD-L1, you won't block anything. That's perfectly demonstrated already. So my concern is that with this kind of work, that it's amazingly designed, if you inject the proper cancer cell lineage, you are going to block it. It's 100%. But in the real world, only 30% of the patients, and we've shown it in Lisbon and the past year, and in our patients, only 30% of the patients express the PD-1, PD-L1 pathway. So that's why in oncology, when we try to do a general population treatment, normally it fails. We have to develop tools that can identify before we operate the patients, which one of the 30% of the patients express the PD-L1, PD-1 pathway. And those are the patients that we might think of doing neoadjuvant treatment. Otherwise, 70% of the patients, the majority, will recur. Regarding the question of Professor Christoph, the pathway of PD-1 will never blockage the immunosuppressant that will be in transplant. That's already. Thank you.
Yeah. So I want to follow up on I want to follow up on the question from Vincenzo. I think the problem here is not to treat the patient. What we should look for is, do we treat the patient or do we cure the patient? And the best patients to cure are those, even with a complete response, where the tumor or the metastasis disappeared. Because we know now very well already from the TransMed study, especially, that many of the missing metastases completely disappearing when you do a precise pathological examination of the total hepatectomy specimen. And this is the main importance of transplantation, that you can destroy the tumors, but there are almost always cells in place, tumor cells. And we should not forget also in the decision taking, if a patient has immunotherapy, I read papers in the literature, in the Journal of Hepatology, patients who got 20 to 30 times immunotherapy, this is almost double the price of a liver transplantation in Europe. So we must integrate economic thinking, because we speak now about treating, but you cannot do this everywhere. And a transplantation, tumor disappear, you cure the patient. Vincenzo showed this already 20 years ago with 10 and 20 years tumor-free survival in 95% of the patients. That's important to stress, especially for young people. And the second thing, and then I stop, there is a new medicine coming. We have to learn to use together immunotherapy, immunosuppression, and chemotherapy. And the basis for every now be minimal suppression. We do this since 25 years in Brussels, tacrolimus monotherapy, and it is now been shown by the Philadelphia group that if you raise the immunosuppression for the same tumors, the recurrence is much higher.
But so maybe I can. So first, I think we said that we don't know whether surgery is going to have an impact on the immune system, but we also said that, I said that from my point of view, we should be resecting these patients. I think we are in agreement with you. Also, I agree with you that on the mid and long term, immunosuppression should be minimized in surgical patients. Only those having received immunotherapy, because there is an increased risk of seeing some rejection in the first 1-2 months. We should be careful not being too low in the first few months. But I agree with you that lower CNI is going to be a lower risk of origin. Selection of patients. Yes, obviously, some patients will be better suited for a neoadjuvant or an adjuvant, probably more neoadjuvant because it's going to be more effective. But all what I showed is still valid because it's only a question of selecting the appropriate patients. What we currently don't really know how to do, and even based on the PD-1, PD-L1 exposure, it's only partially matching the response to the treatment.
Very short one, no?
This information, there is a very good paper from the MD Anderson Oncology Group showing that you can very well combine transplantation for every solid organ with immunotherapy after transplantation. We should read it. And this is the meaning of making transplant centers. You raise the number of immunosuppressed patients with an organ, then you know how to combine chemotherapy and immunotherapy. It has been published, I think, in Cancer.
Thank you very much. Compliments also for basic research talk here, which is very important because that's the basis of our being here. Front top from MD Anderson. Surgery for intrahepatic cholangiocarcinoma.
And of course, while the slides load up, I just welcome also the participants on Zoom. Professor Surendra Mathur from India sends his regards. And we have also on the YouTube channel that broadcasting this Congress, greetings from somebody from Vietnam. So it's really a worldwide Congress.
Hey, it's me again. Thank you very much again for the opportunity to present the work here. And the challenge today is to ask you to reconsider upfront surgery for patients with high-risk intrahepatic cholangiocarcinoma. And this is something we saw a little bit of yesterday during the case presentations. So I think it's quite timely a topic. So again, we'll start with the case presentation. You can see this woman here, large tumor in segment 5-6. There was a satellite nodule right here in that measured 2.2 centimeters. She also had enlarged portal lymph node that was biopsied and was negative. Her CA19 was 3%. So she went to the operating room, underwent an anatomic segment 6 with lymphadenectomy. Path came back PT2 and 0 with 2 tumors. She received adjuvant capecitabine as per the BELCAP protocol. Unfortunately, 4 months later, she develops multiple bilobar metastases as well as a number of large pulmonary metastases, and her CA19-9 has gone up to 592. I would think that most of us in this room agree that this represents futile surgery and an unwelcome outcome. And this is something we're going to have to face more and more of because cholangiocarcinoma, intrahepatic cholangiocarcinoma is on the rise, both because some of these were misclassified previously as cancer of unknown primary, but also because of the onset of the metabolic syndrome and the emergence of fatty liver disease. And when we do have intrahepatic cholangiocarcinoma, even when they're localized, the survival is really quite dismal. And a lot of that is driven by the fact that this is a disease with overwhelmingly high recurrence rate. Over 75% of patients will recur, and especially when they recur very early, the price is costly. You can see here, this study showed that patients who recurred within 6 months of surgery, their overall survival, the median overall survival was no better than systemic therapy alone at about a year. And so the first question to ask ourselves is, what can predict early recurrence? There's been a number of studies that have looked at this and have consistently shown certain factors that can predict this. Multiplicity of tumors, positive resection margin, vascular invasion, all predict higher risk for disease recurrence, but especially nodal disease. When you have nodal disease, the recurrence rate is very high. This was proven in multiple series. This here out of Italy that basically showed that the larger the tumor is, the greater the risk that you're going to have these features like multiple tumors, nodal metastases, and vascular invasion. And the conclusion was that these, along with a high C19-9, independently predicted adverse prognosis. A lot of these factors have since made their way into nomograms, both in Western series and Eastern series, that have shown that if you have these high markers, the higher the tumor marker, you have vascular invasion, you have multiplicity of tumors, large tumors, they all add up to give you a very high score, risk score for disease recurrence and limited survival. So that was from Asia, and this one here is from a Western series, which again, if you look at the factors involved in these nomograms, they're consistently the same. So what you conclude from this is that nodal disease, vascular invasion, multifocal disease, maybe large tumor size, maybe elevated C19-9, all of these should tell you biologically high-risk feature. And fundamentally, this is borderline resectable on the basis of biology. So even if you have a tumor that's technically anatomically resectable, but they have these features, you should think twice about it. And so if we keep doing the same thing and having these same outcomes, clearly that's not what we want to happen. And in fact, if you look at the series out of MSK back in 2008, they said resection of intrahepatic cholangiocarcinoma in the face of these findings should be considered carefully and perhaps should be combined with adjuvant therapy. And this is years before BELCAP was even published. So clearly, we all know that this is a bad set of disease. Now, adjuvant therapy has limitations. So even if you say, okay, bad disease, I'm going to resect, and then I'm going to just give them adjuvant therapy. Well, number one, morbidity and mortality after hepatectomy is still significant. So some patients may not get to adjuvant therapy. Number two, you can see that a delay to adjuvant therapy can lead to a decrement in survival. And also, the current standard of care is capecitabine monotherapy as adjuvant therapy based on BELCAP. And I would argue that most of us look at that BELCAP trial and we're not super convinced that it's a very effective strategy in the adjuvant setting. And the tolerance of multi-agent regimens remains in question. Now, there's a rationale for neoadjuvant therapy in this cohort of patients. There is a potential for tumor downsizing that may convert unresectable disease to resectability. You can improve your chance for R0 resection, which we all believe to be a positive thing. You can tolerate treatment better when in the neoadjuvant setting before you have surgery. And ultimately, though, the key about neoadjuvant therapy is patient selection. And in the case of immunotherapy, Christian just showed it very nicely, IO may be better, more effective in the neoadjuvant setting than the adjuvant setting because your source of neoantigens is there, because the local regional immune environment is intact. And in fact, there are some clinical studies that suggest that to be the case. This is a study looking at gliomas, and if for patients treated with neoadjuvant immunotherapy, their survival was better than if they got it adjuvantly. So does neoadjuvant therapy work? When we looked at our experience at MD Anderson of these patients treated with neoadjuvant therapy, again, these are high-risk patients with unresectable, but some of them have high-risk features. The median survival was almost 4 years for patients with high-risk disease. That's very, very good compared to, again, historical numbers. And if you look at the national data in the US, looking at the National Cancer Database, if you're able to get the patient through neoadjuvant therapy and surgery, their outcome was better than if they went straight to surgery. Now, these are all retrospective data. We did have a prospective study that we conducted with 3 other institutions called NeoGAP, where we use gemcitabine, cisplatin, and Abraxane on the basis of this trial here with patients with initially unresectable disease, 20% of whom became converted to resection. So clearly there's some efficacy to this regimen. And so we used it for exactly the cohort of patients I just described with high-risk disease. The primary endpoint was feasibility and safety. Secondary endpoint, resection rate, objective response rate, survival. So definitely feasible and safe. All patients were able to get through neoadjuvant therapy, no problem. 77% ended up getting surgery, which is not different from the rate of upfront surgery and the number of aborted cases historically. There's good disease control. 90% of patients had disease control. And you can see that despite neoadjuvant therapy, these were still very high-risk disease, right? We had an R0 resection rate of 73%, but nodal disease was still very highly prevalent, even after systemic therapy. Now, I'll tell you, the recurrence-free survival has been very dismal. Even despite this, only 7 months, but the median overall survival so far, when they can get to surgery, hasn't been reached. But when they can't, and when you include everyone, it's still 24 months. So here's the lessons that we've learned from that trial. Neoadjuvant therapy is feasible. Neoadjuvant therapy is safe. It does not seem to negatively impact your ability to get to surgery. It can be associated with favorable R0 resection rates. And while the RFS is disappointing, the impact on overall survival seems to still be significant. But are there better options than just GemCis and GemCis Abraxane? After all, GemCis Abraxane was a negative study when we submitted as a phase 3. It did not bear out. Although it should be noted that in the locally advanced rather than metastatic setting, there was a signal in difference in survival with that triplet therapy. We now know, of course, that immunotherapy has become standard of care as part of both the TOPAZ-1 and the Keynote 966 trials. So inclusion of immunotherapy with GemCis is what should be done in the metastatic setting. We also know that cholangiocarcinoma is a very target-rich disease, the most target-rich disease. About 40% of these patients will have some targetable mutation. And so in the setting of these developments in the last few years, there's a number of current or upcoming neoadjuvant or perioperative trials ongoing, 2 of which we at MD Anderson are leading, studying GemCis Durva or GemCis Pembro, again, for high-risk resectable intrahepatic cholangiocarcinoma. There's also a study out of the University of Toronto looking at a very similar regimen. There's a multi-site study being conducted now using FGFR2 inhibitor. So there is definitely a lot of interest and a lot of movement afoot to study these regimens in the perioperative or neoadjuvant setting. That said, better systemic therapy is needed. Yesterday, Sylvia made a mention that the objective response rate with this regimen are still very meager. In fact, for those who look at IDH1, ivosidenib, objective response rate is only 2% in isolation as monotherapy. And even with immunotherapy, it's about 30%. Now, some of the other agents like BRAF targeting FGFR2 can get as high as in the 40% range. But the good news is that the disease control rate, as I said, is in the order of 80%. So you're not losing out the opportunity to operate as long as they remain controlled. So in the future, I suspect novel drugs, novel targets will come along. And then as we start combining systemic therapy with liver-directed therapy, I think we may have even better opportunities to achieve good outcomes. So in summary, biology for intrahepatic cholangio remains king. These high-risk features, high rate of recurrence, poor outcomes. A surgery-first strategy has limited efficacy in this setting, and neoadjuvant therapy certainly has a sound rationale and can lead to improved patient selection. Better systemic therapy options are still needed, and personalized treatment strategies must go beyond just identifying 1 or 2 features, but instead will benefit from an AI-informed model that considers treatment. So I thank you again for your attention.
Thank you for this wonderful talk.
Well, great presentation. My congratulations, and also my congratulations because I actually totally agree with you. I think all in these rooms are unsatisfied when we operate intrahepatic cholangiocarcinoma at a high risk of recurrence. So I agree. I mean, if we do not operate these patients up front, we actually don't lose any chance for the patients. Probably we spare the patients future surgery. What I want to say, because I think that's the truth, is that we shouldn't expect a downsizing of the tumor, because that's not the time yet. If you look at the top of the trial, objective response rate is reaching 30%. So basically, we treat high-risk patients, being aware that we are selecting patients, those patients with a better biology, probably with a chance to stabilize the tumor. And so I think this is the idea.
Yeah.
But I'm totally agree with you that going on to operate upfront high-risk patients is not giving a better future for the patients, and the problem is just a way, you know, to fill up our operating rooms, but without any result.
No. Well, thank you very much. Good to see you. I mean, I agree with you, right? I think at the end of the day, patient selection, identifying those patients who stand to benefit from these operations that we do, that's really key. Now, you could argue a small resection, whatever, very safe, not a problem. But again, these are high-risk features. So these are tumors that tend to be large, tend to require a very complex operation. So if you're going to submit the patient to that, you better make sure that they will benefit from it. I agree with you. And to your point about neoadjuvant therapy, you can't expect the effect to declare itself right away. So it is common for us to at least wait till 2, 3, if not 4 cycles before you're going to see an impact.
If I may add something, I think we all agree that the BILCAP trial, I mean, is the only trial showing something.
Yeah.
But I'm not sure that we really do trust in it. Okay. So just to be clear,
yeah,
I believe that we can share something more before surgery, because so far we cannot expect that much after surgery.
You know that in Japan, they use S2, which is a kind of 5FU, which is very similar, but they believe strongly on that. So I think that because we don't agree, we kind of find funny the BILCAP study.
Yeah.
However, the Japanese believe very much in this S2 drug. So can you comment also?
Yeah, actually,
it's the same type of.
Yeah, but you know, I think you're right. But at the same time, remember, they did have a study of adjuvant therapy that failed. It was a negative trial out of Japan, looking at S1, I think, if I'm not mistaken. So BILCAP is the only study out of 3 randomized trial that showed any quote unquote positive results of adjuvant therapy. And even then only on the intention to treat, I mean, per protocol and not intention to treat. So I think the jury's very much out on whether adjuvant therapy really works for this disease.
Just the last word, then I will shut up. We also know that cisplatin and gem after surgery not working.
Yes.
So that's another important point. It is telling us that we have to do something before surgery, because probably after surgery, nothing is working so far.
Yeah, well, you know, the Actica-1 trial is, we'll have a readout hopefully soon, and we'll see whether that's going to be really helpful.
Okay, Dr. Kato.
So great presentation. I like this title of time to reconsider high-risk intrahepatic cholangio, but your talk in a conclusion in the end did not really sound like how to differentiate, discriminate the patient who we should avoid upfront surgery. So just want to know your opinion. You know, you show that the multiple tumor,
Yeah.
and you saw that the lymph node. Those are probably pretty much no-brainer
Yeah.
to think about that as a high risk. But what are the other features that you consider really high risk to avoid upfront surgery? Is there any in your mind, or you just recommending everybody should get a neoadjuvant?
No, not everybody. I think, again, patients who have high-risk features defined here, again, this is born out of the data retrospective series, but these really are the best data we have. I think tumor size for me is probably the softest call, but certainly multiple tumors tells you, and there's data to suggest that multiple tumors is very much so like a metastatic process. So multiple tumors, nodal disease, high CA19-9, all of those are really indicator that this disease has started to spread. And because it has started to spread, does it really make sense to go local therapy alone and local therapy up front? I think that's a big question.
You recommend 4 out of the 5 criteria?
Pretty much currently, so we have a couple of trials going on. The inclusion is any of these features. But you're right, that's not sensitive enough, a selection set of criteria. Down the line, I foresee that if we start taking into account genomic data, and we have better ways to inform us as to who will really benefit from, neoadjuvant therapy, will have a better sense. And even which regimen to give, we'll need to find out as well.
Yes, in line with what we just said. One of the problem of these trials is the stratification according to prognostic factor. And the most, I would say, underestimated prognostic factor in clinical side, let's forget all the molecular profiling, is the lymph node status.
Yeah.
So in most of these patients, you have sometimes you have a significant underestimation of lymph node. So and in our center, for example, we try to do some kind of lymph node first assessment.
Sure.
Okay, so trying to do laparoscopic or robotic lymph node assessment ahead of any other decision and then stratify.
Gotcha.
Because I think that if you stratify on lymph node factor, you will find the significant difference on treatment, both on resection, R0, R1, and survival. So what your opinion on this? Second, what do you think about radioembolization in cholangio? What is your feeling on radioembolization in cholangio, combined or not with
Sure.
ahead of surgery?
Yeah, no, you're right. So nodal disease tends to be underestimated. There are certain some radiographic features that can tell you pretty, effectively whether a lymph node is involved, but the absence of those features does not mean they're not involved. So to your point, I agree. We currently don't have that approach that you're talking about in terms of doing like a lymphadenectomy or just to stage the disease and tell you whether or not it's involved as a separate procedure, I assume, right?
Yes.
Yeah. So we don't do that now. If we have suspicions, we'll either, again, get a PET scan, get a biopsy, understanding that biopsy can be also not super sensitive. But I think that's the extent to which we'll assess the lymph nodes. We won't do a separate lymphadenectomy. I don't think that's a wrong thing to do. It's just not what we do at Anderson. To your question about Y90, as I kind of mentioned yesterday, so classically, people used to think that, that intrahepatic cholangiocarcinoma was not very responsive. But we now know that there's different features of intrahepatic cholangiocarcinoma, different morphologies, some of which are going to be enhancing, hyper-enhancing, or rim enhancing. For the hyper-enhancing diffusely, they will respond to Y90 well. So it does work. Those rim enhancing, it kind of controls the disease around the periphery. The hypo-enhancing ones are the ones that we don't use Y90 for because you're just not going to get good penetration into the tumor. So Y90 can be used. It can be used effectively, even as neoadjuvant therapy. And I suspect that we will start combining either Y90 or something like that with systemic therapy ahead of surgery.
This is in the same line. Because we had this question yesterday. I was presenting a case and you asked a question about 190 and cholangio. Our experience with 190 and cholangio is good, except when it's in the contact with the hilum, because we had radiation-induced cholangio, radiation-induced biliary injury that led to bad biliary fistula. We contraindicate 190 patients with large tumors in contact with the hilum. That's just a word of caution because this is published now.
Yeah, Danielle, you're completely right. And I think there's ways to modulate that. So we had a similar situation of high dose Y90 that led to exactly what you talked about. The bile duct disintegrated, bad fistulous process going on. You can have a lower dose of Y90. You have to talk to your IR colleagues. They can do a reduced dose, kind of preoperative dose, that will have less injury to the biliary system.
Okay, very nice. You convinced us perfectly that this is the way to go for intrahepatic cholangiocarcinoma. What about, so considering patients with high-risk features that do preoperative systemic therapy, you are selecting a group of patients that are going to do much better.
Yeah.
What about ones that don't respond? Meaning, are we having some adverse selection? What's going to happen to those patients? Are we losing the chance of some of those patients to be operated and have a slightly better prognosis or not?
So no, again, I'm not looking, these are not patients in whom we're looking at downsizing or shrinking or anything. We're primarily looking for disease control. If the disease control is established with neoadjuvant therapy, then you've kind of given yourself a shot at identifying those patients who will not progress. So we're not converting. If you're talking about conversion, that's one story. But these are patients who are trying to make sure that you're not going to have the scenario play out that I just showed you at the beginning, where you operate on them and then they're going to recur within 3 months. So by giving them this neoadjuvant therapy, it's really about patient selection more so than anything else, in my mind. And so I don't think you're losing out. As I said, disease control is 80% with a systemic therapy regimen, right? So, and those that will progress, your operation wouldn't have helped them anyway.
I just have one question, practical question. Do you do all the genomic testing for these patients or not?
Yes.
Systematically?
Yes.
And did you try to have a sort of data, large data involving specifically these patients that you consider as a high-risk patient? Do you do that sort of profiling? Because we are going anyway more and more to targeted therapy.
Yeah.
Anyway, it's not going to be a general systemic. You just spoke about the data, the prospective trial. I'm sorry to say, but all these prospective trial, we don't trust them. We haven't seen that in the reality that it's working.
Yeah.
So there are a lot of bias. So my question now that we're going to immuno-targeted therapy, I think because I haven't seen that in most centers, they don't do systematically genomic
Yeah.
typing. And I think it's important, especially for the lymph nodes and everything. And do you do that prospectively?
Yes. So number one, NGS testing should be obligatory for every patient with intrahepatic cholangiocarcinoma at the very least. And so we do it routinely at MD Anderson. Whether it changes our approach remains to be seen. FGFR2 mutated ICCA have better prognosis. They behave better as a general rule. Now, whether you can include that as a neoadjuvant regimen, we're studying that in the OPTIC trial. We'll see. It does take some time for the NGS to come back. So can you leave patients untreated during that time? No. So OPTIC trial will give the patient one cycle of Gemcis durva, and then when the results of the testing comes back, if it's FGFR2 mutated, then they'll be, futibatinib will be added onto the regimen.
Thank you very much. Thank you very much. That will be delivered by Dr. Silvia Gomes da Silva. We keep the same or similar topic, robotic resection for intrahepatic carcinoma. Silvia?
Thank you. Thank you very much for the opportunity to present our work today. So now I will talk about resection. So as we all know, the incidence has been rising in the last few decades. The surgery is the only potential curative treatment, but actually we only achieve a 5-year overall survival of 25 to 40%. Although the use of robotic technology has not been specifically evaluated in HCC, encouraging results have been reported. In the last consensus meeting about robotic liver surgery, the limited evidence suggests that the robotic resection has less intraoperative blood loss, shorter hospital stay, and a better overall survival than open surgery. And we have only reported two works in comparing robotic resection and open resection. I chose this one from Tampa Group in US, and you can see here that actually a lower blood loss, similar, even better tumor margin with robotic approach, R0 and R1 comparable, and comparable lymph node harvest. So we can show that there's no inferiority of the oncology outcomes. We have greater R0 resections, greater tumor distance to margin, and equal results in lymphadenectomy. Even overall survival seems to be better in the robotic resection. Some authors say that minimal invasive approach to oncologic resection may attenuate the perioperative inflammatory markers, which appears to play a role in carcinogenesis and cancer recurrence. My personal opinion is this is a bias selection, and if the future will respond to this question, but we have not enough data for now. So I will show you our experience. I can't talk about resection, robotic resection of HCC without talking about our experience. Nowadays, we perform 700 surgeries a year, only for HPV surgery. At liver transplantation, we transplant 115 last year, the same, almost the same as last year's. And here you can see how was the distribution of our surgeries. We start earlier with laparoscopy. We don't grow as much as other centers because we believe that some things we can do by laparoscopic way. And we start our program, our robotic program in October 2019. And it starts to grow, as you can see. We start slowly, but now we performed 150 surgeries a year. Actually, laparoscopy decrease as soon as we start our program, but minimal invasive surgery still increase. So at now we performed at last December, we have performed 500 robotic resections, 455 only for liver and bile duct disease. Here you can see all of the surgeries that we performed. In the others, I put in the others all the wedge resection, segmentectomies, subsegmentectomies, bisegmentectomies. But you can see that we can perform a lot of complex surgery by the robotic way, like the treatment of Klatskin tumor with 25 patients, vascular surgery like thrombectomy of portal vein, thrombectomy of the vena cava, and transplant surgery. 13 robotic whole graft liver transplantation, and 3 living donors. These are our results in cholangiocarcinoma of all the three approaches: open, laparoscopically, and robotic. We have performed in the last 20 years 142 liver sections for HCC, 38 with bile duct resection, 28 with simultaneous vascular resection, 128, 19% with lymph node dissection, and with a median lymph node resected of the 8. This is our survival curve with 55% of overall survival at 5 years. And here you can see our experience in only robotic intrahepatic cholangiocarcinoma. We have performed, as you can see, we start in November 2020. We start the program 1 year before we performed the first HCC 1 year after start the program. Till now, we performed 27 resections. 77% of them major liver resections, with an operative time, with a median operative time of 4 hours, a estimate blood loss of 100 millimeters, only 2 patients transfused, no conversion, with a median hospital stay of 5 days, and morbidity, Clavien 3 and 4 of 11% with no mortality at 9 days. This is our room setting, operating room setting. You can see that surgeon console is the same room as the assistant and the patient. Here the port position. Here I want to tell you that when we start our program, we are always talking about the best position. We change port position to the left side of the resections, or to the right side of the sections. After the surgery, we take notes, talk, but then we achieve the perfect port position, and we think that is this one, is the convergence of the line of the xiphoid appendices with an axillary anterior line, and we count 20 centimeters in direction of the middle line, and this will be the camera part. This will be the second arm. After this, we respect the principles of robotic surgery, and we put the other parts and the assistant ones, and it looks like that. And we do this to all liver resections. Here I will show you a case. A 45 years old man with an HCC of the left lobe invading the median hepatic vein. It's proposed to left hepatectomy with the middle hepatic vein resection. Here you can see the lymphadenectomy. The vision is incredible. Here we have the artery. Now we are ligating and section the left hepatic artery. Here the left of the portal vein. We performed Indocinian and green to all the patients and confirmed the resection area with echography with ultrasound. And here the transection. On the left hand, we have the synchrosil that cuts and the ligate and cuts. And in the right arm, the bipolar here with the Maryland. Maryland is good to perform a caliclasia like in the open way. And we can isolate the structures, vessels, and the portal branches to perfectly ligated with homologs, with staplers, what we need, just like in the open way. And here we have the middle and the left hepatic vein that will be sectioned with a stapler. So my final remarks are robotic resection of HCC appears to reduce the perioperative morbidity without compromising oncological outcomes, and this is the most important. As the robotic platform continues to increasingly adopted, larger studies may allow to matching and randomization that may clarify the benefits of the robotic approach.
Thank you very much, Silvia, for this comprehensive overview of robotic surgery for HCC. And the first remark and discussions will start. Professor Vincenzo Mazzaferro, please.
Yes, thank you very much, the organizers, for giving me this assignment. Less qualified in this room to discuss on robotic. We just had the robot 6 months ago, so I'm not going into details, into technical issues, because I'm learning here. I'm not teaching anything, but just to remain on general question on robotic for this indication. My feeling, also looking at the papers, at the reports we have, is that, of course, robotic is better than laparoscopic. Of course, you can do a lot of other things. You have a magnification and other features, but complex case remains complex case. I mean, if you have let's say a very regulated resection and a very straightforward, let's say straightforward operation, you can do it with the robot and you can do well. But if for example, if you look at the day in the hospital, complication rates, even, I mean, in a difficult case, the complication rate and the day in the hospital is more or less the same. Look, if you dissect into the paper. So the problem is, let's say, the magnitude of the benefit of robotic surgery decrease as the complexity increase. This is my personal feeling. So I want to comment on that. And the second one is the fact that there is despite there is a tremendous number of description of robotic surgery for these indications, we don't have a very good study. We don't have a very good prospective indication. The problem remains the selection. We have a lot of, scores, but we don't have a good selection. So I think as a surgical community, for beginners like me or for, you know, advanced users like most of you. And we need a prospective investigation independent from, you know, the pressure of the commercial indication, etc. So in order to show the other part of the oncology work, that we are not working only on case series and on prospective analysis. This is crucial for the future of our role in treating cholangiocarcinoma. Thank you.
Thank you much for your comments. I will start by the end. Actually, we don't have data. This study that I show is the biggest one, and we have 34 patients. But is the better one, 34 patients consecutively operated by the open way and by the robotic way. So here we have a simple but a kind of matching. But actually, we need more data with more patients and prospectively. But for now, all the data that we have are the first patients of all the centers. And we know that the first patients doesn't represent the real patients, because first patients are the better patients, the less complex patients. And on the other hand, the surgeons are starting. The surgeons are developing their skills and their tips and tricks to treat this pathology. So I believe that we need to have some time to stable the technique and the patients and the selection the patients, and then we need to perform a largest multi-center study prospectively to understand the results. About the complex surgery in robotic resection for complex surgery. It's possible, and we are performing that now, even for transplantation and for Klatskin tumors. And we think that actually the benefit of robo is on complex patients, on complex surgeries, not the complex, not the health patients. Robotic resection is not for all patients. It will be for all kind of surgeries, I think, but not for all patients. Very ill patients that will stay in the hospital for a long time will not benefit from the benefit of the robotic. So we perform these patients in a open approach. But complex cases, I believe that that is better with the robotic way.
Thank you, Carlos.
Why I am going to do a comment, Vicenzo. I say the same thing 35 years ago about laparoscopic. If you saw our results now, Isugu, one of the reasons laparoscopic was so I decided, no, you don't do my laparoscopic. But why I am going to do this comment? I went to the room to see Ugo. I teach him to do this open surgery. That's very complex. And I tell you, when I saw the robot working, I think that's not possible to propose other way as robotic surgery for Klatskin. I tell you, I was there. I never did a laparoscopic.
I'm not against that. I'm not saying that I'm against.
I tell you, believe me, I was there. I was afraid. More nervous than and I said, after so, I said, okay, this is not possible to do by open. I couldn't do by open surgery so well. Believe me, in 10 years, I'm absolutely sure that the improvement is like laparoscopic. It is the best way to do that. It's impossible for an open surgeon, even a good surgeon as me, to do better than a robotic approach.
Luca?
Just a quick comment. Well, actually, two comments. If we stay in the area of minimal invasive surgery, complexity gives advantage to the robotic approach. This is what we know. For resection with low and intermediate complexity, laparoscopy and robotic approach are same results. In high complexity, you spare conversion, you spare blood. So I think the more complex is the case, the more the robotic has an advantage if you want to face it by minimal. And this goes to my second question. Since I see that laparoscopy basically is disappearing of center, the question is, there is is your choice to move all minimal invasive resection to robotic approach, also low complexity and intermediate complexity resection?
Your compliment.
Please, your answer.
Could be. No, we will continue to do laparoscopy. This reflects the learning curve of the youngest. We need to put the simple cases in the robot so the youngest could start. But after we start and we are capable and progressing in robotic, we stop to do that surgeries by robot. I don't perform cysts on robot. I perform two in the beginning, and after that only is by laparoscopy. And if the robot is occupied, we maintain the indication for a minimal invasive surgery, but we do laparoscopy. It hurts.
No, just to say,
Hugo and then Daniel.
sorry, just to complement this, we have to also to think this is an evolution of laparoscopy. It's like an enhanced model, so to say. But this is more expensive also. This is not justified for all patients. We will have to do laparoscopy for simple operations like left lobectomy, for example, because we cannot support this for all patients.
Daniel?
I started laparoscopy, liver resection, in 1996, which is almost 30 years ago. So what I'm seeing now is that this technique that used to be sexy is just disappearing with my white hair. And we have to accept that. But however, I think there's a confusion in general. Robotic allows to increase the access to minimal invasive surgery to patients that were not accessible by laparoscopy for reconstruction, perihilar angio, etc. For formal hepatectomy without reconstruction, there's no proven advantage whatsoever nowadays that it's better. I'm just finishing. I think that when we're talking complex, number one, you have complex. The hilar dissection is perfect by robotic. But when you need to replace the IVC for an advanced intrahepatic cholangiocarcinoma, this is where you must compare with not laparoscopy, but with open surgery.
Exactly.
So at the end of the day, I think that we're mixing everything. Now we're in the Andy Warhol period of laparoscopy, of robotic. Everybody wants to do robotic. Because you have the robot, you want to increase your experience and your exposure, so you do everything. Here you have 5 cases. You say you do laparoscopy, but only 5 cases in 2024. So I think that laparoscopy probably is dead. But no, because the problem is losing the experience and losing the expertise. So we should be careful that we don't lose the expertise with laparoscopy, because in the end of the day, the robotic will not be available for everything. So the comparison for the future is open versus robotic, not laparoscopic robotic.
Vincenzo, please.
No, just a short note. If we do robotic transplant, the patient is not going home the day after that. So you have the complication, the stenosis of the vessels, we have a biliary leak and all the other complications, exactly like you have in the other open surgery. So what I mean, I'm in favor of robotics, of course, but what I'm trying to temper the enthusiasm in case of patients with, difficult cases, in which more or less the result in terms of hospital stay and let's say general cost for the patient and for us is more or less the same. That's it.
Thank you, Gina.
I fully agree with what everybody has said, and I completely agree that this is a learning curve, and we're going to see more and more robotic surgery. But while we are doing this, you have to face that at the same time, and that's happening already. You will have the fully automated robotic system, okay, where the human being behind is no longer there. You have to imagine it; it's already there. So my question, and I think that we have to keep that in mind because we shouldn't lose the expertise, okay? And some countries will have that, other countries won't have this. So what is the place of the surgeon? So that's what I want this to keep in mind while we're doing the transplant via robotic, while we're doing so many cases via robotic, where is the expertise going to be left for the young generation coming up? So this
Thank
is
you,
my
Gina.
conclusion
Short
about
answer, Silvia, and then Hugo.
We will always be needed. A machine can replace our hands, but will never replace our head. So I think that we will always have surgeons. Um, uh, and actually, these curves represent the teaching the youngest. We only have five laparoscopy cases because because a lot of surgeons are now starting the robotic program. So in the last year, we put almost all the cases to the robotic and teach exactly. So we need to teach the three approaches. We will need to have laparoscopic surgery, and we will need to have open surgery. But that was the biggest question with cholecystectomy, with laparoscopic cholecystectomy. Nowadays, our residents starts with laparoscopy, and it's very rare to have an open cholecystectomy.
Hugo. Hugo, please.
Yes, very quickly, just to answer to Danielle, one thing. There is some evidence, I know it's not the right comparison, laparoscopy and robotics, but there is some evidence that at least for conversion, the numbers are different. I personally think, I think we're going to prove that for management of intraoperative complications, the robot is better. Management of intraoperative complications than laparoscopy. But in the same questions, but let's think about Gina's comments. I think what we are dealing with now is enhancing the surgeon with robotics, not replacing the surgeon with a machine. This is going to take more time.
Great. Last remark, Jan, please.
Really too early to do the comparison. It's too early. You know, open surgery, we have 4 decades of yeah. For laparoscopy, a little less than 2 decades. And for robotic, it's 5 years. We must give time.
Jan?
I think we discussed a lot about the methods to use to do surgery, but it is an option, and the decision maker will not be we, the doctors or the surgeons, it's the patients. And what happens in Asia now already every day, the patients go on the website, look where is a good surgeon who does good robotic surgery, and they refuse open surgery and they refuse laparoscopic surgery. The economic impact is not a discussion point. When I started, they said to me, we were even not allowed to laparoscopic hernia surgery because it was too expensive. There are in China at least 15 companies who make robotics, and the prices go down. And robotic, the last argument is the best way to learn surgery, especially liver surgery. Because when you assist a resident, you are obliged to be concentrated 200% in the scope, because otherwise you cannot help the surgeon. So robotic for me, we should not discuss anymore. It is discussed, it's done. Everything will be robotics within 5 years from now, believe me. I went on many places in the world since I'm out of clinical practice. There are centers where open and laparoscopy even does not exist anymore at all.
Okay, thank you very much. Maybe. No, Laurence? Well, extremely short.
Yeah, shortly, I want to support what said Professor Mazzaferro, because uh, uh, we are not with dogma. We can't say that everything will be robotic. Surgery can be difficult, and we see all this. What is really surprising is she showed that if somebody asked me what is the most difficult surgery in plastic surgery, probably I would say flat skin tumor. And you have the most important number of your robotic hepatectomy are clad skin tumor, and you are talking about learning curve. This is the most difficult operation for me. And we see a lot of beautiful films, okay, but with the normal liver. But I remember I have to deal with cholestatic liver, with multiple drainage, with and so still there is very difficult. So of course robotic will be wonderful, but still it remains very, very difficult cases, and open surgery is not dead.
Thank you very much. And what's also interesting, we see also very nice ones. We also see the disasters which can be, could be nice for next year. Just some videos from disasters which happened. And that's also very good. Daniel, we'll start. We'll go on.
Oh, thank you. This is a short story. When I came to Bruce in 2013, I brought laparoscopic tumor surgery. Everybody was excited. And last year, we bought the robot. Actually, I found the money, but we have the man here, Antonio Sacuna, who is doing the robotic liver resections, and the robotic liver resection goes down. So all I do now is complex open surgery. And for the moment, still the living donor hepatectomy, but of course the robotic will take. So now I'm just interested in open surgery. I agree that flat skin is the most difficult, but these kinds, what I'm going to show you here, is also some part of the more difficult operation. So I'm going to talk now. I showed you 2 videos yesterday, and I'm going to talk now about extended liver resections for locally advanced intrahepatic cholangiocarcinoma. And Eduardo Mutillo is one of our fellows who worked with me on this, collecting and analyzing the data. So I'm not going to go back on that, but it's the incidence is rising, and the prognosis of intrahepatic, here is the red, the worst of the cholangiomas. So basically, there's no terminology for locally advanced. So this is my classification of locally advanced hepatocellular carcinoma, intrahepatic cholangiocarcinoma. There are mass-forming operations, and histologically, there are small duct, the classification of small ducts. So you have those with hepatic vein and or inferior vena cava invasion, which is the top line over there. Then you have those with a hilar invasion, which pose different difficulties. And you have those with both the hilar and the hepatic vein. So this is a single center series on over 10 years, 39 patients, mostly females, 5 segments or more. So these patients are not amenable to parenchymal preserving operation, which should be probably the definition for locally advanced. And with or without biliary reconstruction, with or without vascular reconstruction. So a large tumor, 7 centimeters median, macrovascular invasion in 60%, the IVC or hepatic veins in 67%, the portal bifurcation 19%, and both in 13%. Biliary invasion in 20, including patients with jaundice who required preoperative biliary drainage in 13%. Neoadjuvant treatment, 56% of the patient received. This is evolution with the literature and knowledge. Gemcitabine cisplatin was the most common one, with durvalumab in recent years because of the TOPAZ study. Gemox before, and some FOLFIRINOX, FOLFOX. We also use local regional therapies. Some patients came with taste. We don't do taste, but they came with the taste. And some had 190, but in the limited numbers for the reasons we alluded to earlier. 60% of the patient have response. So this is something that has to be taken in consideration. or stability, that means no progression. And we decided to operate despite progression in 2 patients only. We had to prepare the patients with portal vein embolization in 38%. The future liver remnant was 0.8% of body weight, which is, and we look for over 0.5%, forward biliary drainage, and we have used exploratory laparoscopy in 4. So the side of the procedure is right or left, depending on the tumor, but it's about 50-50. 6 segments in the majority, which is extended right to segment 1 or extended left to segments 5 and 8, and 5 segments alone, extend right or left hepatectomy in the rest of the patients. We had to use total vascular exclusion of the liver in 35%, vascular resection in 43%. Of these 17, most was IVC resection, 65% of the vascular resections, including venous bypass in 8 cases, no venous bypass in 3, hepatic vein reconstruction in 7, without IVC reconstruction, portal vein resection, or hepatic artery reconstruction in 1 that I showed you yesterday, and biliary reconstruction in 26% of the cases with Roux-en-Y or duct-to-duct in selected cases. The operating time was 420 minutes, blood loss 500. 30% of the patients received transfusion, so it's not 0% like your series, but it's more complex cases. And the units transfused, the median transfusion was 0, but some patients required more transfusion. Morbidity was 56%, and postoperative liver failure, which is the main feared complication, was in 17%, with 10% with the clinical impact. Clavie and Dindo, 3 to 4, 11%, and 2 patients died postoperatively. Portal vein thrombosis is 1, and postoperative liver failure insufficiency. It's a 5% mortality. Reoperation in 5, percutaneous drainage of collections in 4, and hospital stay 14 days in median. So long hospital stay. In terms of classification, most of the patients are T3 or T4, but you had less than T3 as well. N plus and nodal positive patients were 31%, and 0, 69%, and 54% were R1 resection by necessity. And finally, we looked at the recovery of lymph nodes. This depends on the dedication of the pathologist, by the way. This is something because we do the same lymphadenectomy. Anyway, 64% had the required number of lymph nodes resected. We use adjuvant chemotherapy. This is retrospective, so this is just data like that. And in 61% of the patient, we had to use the BILCAP study, but mostly when we have bad prognosis and lymph node invasion, we use GEMOX or GEMSIS, and more recently with the use of durvalumab in this. These are the results in terms of median follow-up of the patient is 30 months, and the overall survival, I'm missing 3 years here, but 89% at 1 year and 64% at 5 years. Overall disease-free goes here. I'm sorry, for some reason the disease-free 70% at 1 year, 36% at 5 years, with a median overall survival of 58 months for overall, the median disease-free survival of 23 months. In terms of recurrence, presently out of this series, 56% of the patients are alive, mostly patients disease-free, but also patients with disease, because we can treat the recurrence, and this is very important. The futility defined by 90-day mortality with less than 6 months was calculated at 15%, 6 cases. The recurrence, 51%, as I said before, and the chemotherapy, the treatment, chemotherapy, surgery, we reoperated in patients, combined surgery and chemotherapy in 3. So it's 5 patients with reoperation, and we transplanted 1 patient for limited recurrence in the series. Now, if we look at survival according to margin status, you see that R1 or R0 resections in terms of overall and disease-free survival are strictly the same. So the R status in this study, with its limitation, the retrospective, etc., is only, it doesn't make a difference, R0 or R1. Nodal status makes the difference, N0, N0, N plus, N0, N plus here, and all patients with disease, with a lymph node invasion recur within 2 years, all. Now, if we put together nodal margin status, you see that R0 in the N0 patients, R0, N0, R0, R1 is the same. Same for disease-free survival. And when you are N plus, the R status doesn't make a difference because it's the same. So the prognosis is clearly driven by the nodal status, not the margin status. So I need to just show a couple of examples so we know what we're talking about. This is a patient I showed you the video yesterday, 1, 2, 3, 4, 5, 8 plus IVC, and she was PT3 and 0 R1. She had a reconstruction of the IVC and the hepatic veins, and she's alive 9 years after surgery without disease, considered non-resectable. This is the other patient I showed you yesterday. It's another extended left hepatectomy with hepatic artery reconstruction and biliary reconstruction. She had this operation. In this case, the IVC was not involved, but she was PT2 N1 R1. She had 2 out of 9 positive lymph nodes. And as all these patients, she recurred. She recurred in the form of a tumor in the liver that we resected, I showed you yesterday, but she recurred also with a lymph node that you can see here on the PET scan. And of course, this is where the molecular screening plays a role. You have 2 mutations of interest in cholangiocarcinoma, IDH1 and FGFR2 remodeling. And she had the IDH1, so she was put on ivosidenib, which is the drug, the targeted drug, and she's alive now 7 years after initial surgery without evident disease because this disappeared on the PET scan after the treatment. And this is interesting because these are all the mass forming, these are not small tumors like that, but they are those where the frequent genetic alterations, which are of interest for targeted therapy, occur. So we have to keep this in mind. By the way, this is never a first-line therapy. This is a second-line therapy after recurrence. And finally, this is a patient who had this is the one right hepatectomy, R1 N0. She had recurrence at 1 year, reoperation, second recurrence at 2 years, no extrahepatic disease. We transplanted her, and she's alive 5 years after the initial operation. However, she has a couple of pulmonary metastases. Resembles very much of the patient who had transplantation for colorectal metastases. So in conclusion, I would like to say that locally advanced mass-forming ICC require complex major liver resections. Excellent overall survival may be achieved and justify major procedure, provided minimal mortality is achieved. R1 by necessity is often unavoidable, and does not affect prognosis, so it should not be considered a contraindication. N plus status drives prognosis with 100% recurrence. Neoadjuvant and adjuvant therapy paramount for N1 patient, and this is where probably, as mentioned earlier, you should look for lymph nodes preoperatively to give the appropriate neoadjuvant therapy more than we do now. And there are promising results from targeted therapy. Thank you very much.
Yes, thank you for the opportunity. Very elegant presentation. From this morning, I think surgery is slowly becoming one of systemic treatments. What were your criteria for only a little over 1/2 of the patients were upfront systemic treatment, from what I understood?
Yeah. So what was the indication for
Yes. What were your criteria for neoadjuvant chemo?
So there are 2 types of patients: patients whom we had upfront, and patients that were secondarily. Most of these patients were considered non-resectable. And so most of these patients came from another institution where they were unresectable and already on chemotherapy. Those that we see up front, and we select them with neoadjuvant chemotherapy, with nowadays it will be Gemcis Durva. And we will operate on patients who respond, it's only 25% of those who respond, but it's a good thing. And also those who are considered stabilized without progression. So this is the way we go, even if they're considered operable upfront. However, coming to your first comment, I don't think here surgery is adjuvant at all.
Actually, I think it is.
Okay.
Yeah. Okay.
No,
If you receive a non-resectable patient under chemo, that's not neoadjuvant. Neoadjuvant is when you try
No,
to control the
because
disease in order to operate the patient.
Non-resectability.
And, I'm sorry, and I remember something that recently passed away, Alex Rhodes-Murgy from Miami. He used to say that R1 resections are like kissing your sister. Apparently not. I believe these may be R1 vascular resections.
This is more complex than that, because it's not only R1 vascular. What I'm showing you here is that when you see a CT scan and you know that you cannot do anything else but an R1 resection, this should not be a contraindication, because patients can live 5, 6, 7 years, especially if they are N0. So don't give up on the patients just because you can see that the tumor is too big. Number two, adjuvant, the term adjuvant refers to chemotherapy or anything else after a complete operation.
Yes.
So if you talk about adjuvant surgery, that means it should be resection of a completely cured, a complete response tumor. This is not the case. So I think in the future, semantically, we'll go for the definition of adjuvant surgery.
Yes.
But I think here,
You know what I mean.
Absolutely. So basically, the indication is now when we at the tumor board, we have a patient with a large cholangiocarcinoma. First of all, we do a PET scan to check for lymph nodes. If there are lymph nodes, definitely it depends on location, size, and it's definitely the case for neoadjuvant treatment. We don't do laparoscopy, I mean, exploratory laparoscopy or endoscopic ultrasound biopsy of the lymph nodes, but maybe this would be the way to go in the future to improve the selection of the patient. Not only selection, that's what you do. For the other patients who are N0 on imaging, when it's a big tumor, we tend our oncologists that the tumor board pushes to for neoadjuvant treatment. Maybe you want to comment on that.
No, I totally agree. These tumors, when the patient has N plus tumor, in this case, chemotherapy is.
What are your criteria for N plus?
N plus. PET CT or biopsy. By
very rarely.
By endoscopy. It's possible to have a biopsy by endoscopy when you have a node suspected node.
Okay.
For patients without N plus lesion, clearly it's possible to perform upfront surgery, but the oncologist now push us to perform chemotherapy before.
Wait.
In this case,
We have a lunch and we have already a line. It's Dr. Ron, and then it's Dr. Hugo, and then it's Pietro, and then we have lunch also. So that's already the line to go. Dr. Ron.
All right. So Daniel,
I have also the previous talks. Dr. Surendra Mathur on Zoom asked, what do you do, or what the surgeons would do for a 2.5 centimeter mass-forming cholangiocellular carcinoma today? Chemotherapy, neoadjuvant, or resect up front? 2.5.
Location.
No,
Without positive.
Huh?
Without positive.
Great. I know his answer. He's had.
I have the
that's my. No, 80% control, 80% control, and 20 probably less than 20% compression, and so probably we move to that. I would, yes.
Yes. So Daniel, remarkable series. Congratulations. I'm interested in knowing, because I agree with you, R1 margin doesn't really matter, but.
Oh, no, I wanted the answer. I have.
Resection.
Who is for resection, upfront resection, 5 centimeters?
It's not enough.
Vast majority.
Resection wins.
From what
Sorry.
I'm
Now
Eric. Now I have a question for you.
You're cutting in line, Pietro. Okay, I really liked what you had to say. Here's the question for you. Did you examine margin status on the basis of whether or not they received neoadjuvant therapy? Because there are some series out there that suggest that with neoadjuvant therapy, you can sterilize the margin in a sense, and the R1 margin in that situation is not the same as an R1 margin with upfront. So I just want to know if you.
This is a work in progress. We're working on predictors, C99, etc. So, and I will take your comment into, because I'm not sure we have this question. We're going to look at it.
Go first. He was the first in line. Sorry, here.
Sorry. Just to, first of all, to compliment for your results, this selected group of patients with high risk features clearly, and you have an excellent survival. We noticed in our series two things. First of all, we analyzed the lymph node ratio and the patients that were submitted to extended lymph node clearance, and we noticed a gain in survival. On the other hand, we didn't notice any impact on survival on the ones that had vascular invasion. Did you notice the same thing?
Probably, no, the reason the answer is we haven't, because we're talking here about the majority of patients with vascular invasion, with vascular resections, with vascular reconstructions and everything, and we have a 60%.
So you also don't have a real impact in survival because of vascular invasions.
This is a series of patients mostly with vascular invasion. So this should be, I don't have the whole series of cholangiocarcinoma. This should be looked at the whole series of intrahepatic. This is just only the local. So I cannot.
Thank you. Next in line is Pietro, to be honest.
My question is on lymph nodes. So lymph nodes, positive lymph nodes today, from what I understand, they get excellent overall survival despite the positive lymph nodes and despite the recurrence. So you don't complain.
We have shown you the results, 100% recurrence rate in N plus patients, but we treat them and they live long, but they're not cured.
Yeah.
The R1 or 0 N plus, some of them are cured. And
Right.
N 0, I'm sorry.
Yes, of course, but
So there's no cure in N plus, except maybe with the new targeted.
but you still operate on them.
Yes, because
Plus.
what the patient wants to know is overall survival mostly.
Exactly. That's it.
Okay.
But lymph nodes in the celiac lymph nodes, and nodules elsewhere in the liver. There was a paper in hepatology with nodules elsewhere in the liver, contraindication.
If it's satellite to the main nodule, we would do it, but it's clearly the patient that I showed you here, a single tumor. This is a selected group of mass forming small cell, small duct, carcinomas, which are special. It's a special problem.
Thank you, Dr. Platter.
So Daniel, there is a large series of aggressive resection by Nagino clearly showing R0 superiority compared to R1s. And I do agree though, and sort of intuitively also from my experience, some of those the cases that you show, something like vena cava or hepatic vein area, the positivity. But hilar side, if the bile duct margin is not negative, it's a positive bile duct margin, I don't see that patient would do well. So I just want to make sure not to, confuse the message here. So you're just saying that R1, maybe the hepatic vein margin is not as much as important. But I think still the resection margin on a bile duct is just as important as in any other surgery. Am I correct?
I totally agree with your comment, which is a very sensible comment. However, talking about Nagino, it's all about perihilar cholangiocarcinoma. Yeah. So hilar cholangiocarcinoma, not intrahepatic. It's very different. In the hilar cholangiocarcinoma, Klatskin tumor, of course, the bile duct margin is paramount. Here, it's different. It's just because the tumor is close to the bile duct that you have to do a biliary reconstruction. This is not a Klatskin tumor, and I'm going to look again, but I don't think we have any biliary positive margin. The margins that we have positive are either parenchymal or vascular. By the way, difficult to know when it's vascular. What the pathology sees is just a raw margin, doesn't know what's on the other side. So it's all based on the quality of the operative report. You must describe exactly in the operative report when you expose the tumor, whether it's in contact with the vessel, to detach the vessel.
Okay, last question.
Daniel, precisely there. You say mass forming. Mass forming plus 1 or 2 nodules.
That's what yeah.
The same? You were sick. My experience, recurrence, always.
Yeah, but here, this is, we selected this group because they received extended hepatectomy, major hepatectomy with extension, 5 or 6 segments, because parenchymal preservation was not possible. Even the right hepatectomy was not here. So it's a subgroup of patients, and the vast majority had a single tumor.
No, my question was not of this theory, but what to do today if you have mass forming, small nodule.
I don't resist to operate.
For every, we'll go on around 2 o'clock here so that we can start at 10 minutes past.
Ah, ouais.
Mas já apresentou onde?
Não. Everyone can see whatever they want.
It's a different. Basketball.
I was a PhD student of mine, and I was in the car.
One was completely pedunculated. I resected the bile ducts, did lymphadenectomy, didn't know what to do with the liver, and I did a 4-5. One of them never recurred, Duncan. It was like a grape almost. The sessile one, 18 months later, had widely metastatic. And I guess the question is, morphologically, do you think there's a difference between those lesions that we see pedunculated versus this sessile one and like the sessile one? I'm saying in an idea, preoperatively, can we plan another procedure? And thank you for the talk.
Thank you very much. This is the key question for me. This is absolutely a quick key question. And I don't know if we can, based on the morphological aspect only, maybe it could be interesting to look at much deeper analysis on the mutation. Eventually, there are some reports of TP53, KRAS mutation inside. But actually, the literature is very complex to interpret it because actually it's only mainly case reports. Honestly, I don't have any clear answer to your question, but this is key. This is a key point. Key point.
Yes, I have a microphone.
Michael, this is very interesting. I think we have some cases of IPMB, and they are multifocal, but usually the most frequent multifocal site is the gallbladder. So this type of multifocal variant is very unusual, I think. Well, I wanted to ask you, what do you think is the significance of the built-in positive that you had with low-grade dysplasia? Because I've been speaking to in a very recent case with a pathologist, and they say that this is almost something they shouldn't even report. But to me, it's not so clear that they shouldn't report, because, and on the other hand, one thing is if you have a built-in with low-grade dysplasia that you resect it. If you have a positive margin for a built-in, this means that you have part of the built-in on the other side. What is the value of this in terms of oncology? It's a very, very important question. Actually, the recurrence that you observed was really far away from the sections, from the biliary transection. So this is not a local recurrence. But, and I found there are some series, Chinese series of cholangiocarcinoma, they investigated the value of bilin positive margin, bilin positive margin in perihilar cholangiocarcinoma, and they show that there was no difference in patient with bilin compared to patient without bilin in the transection margin. So the point is that when you have bilin, it means that probably you have bilin in other part of the liver. Maybe it's a disease we don't understand yet. I don't have also clear explanation, but this is a very important point. And retrospectively, when I come back to this presentation, I told myself, maybe with the bilin, we should have been more aggressive or more cautious. Maybe it could be a message. If there is bilin, be very more cautious. My feeling when I retrospectively analyze this story is that when she started to have the small hyperdiffusion lesions on the remnant liver, we should have been at that time much more aggressive and much more cautious. We were told
Did you embed totally the specimen? It was like 2.5 cm. Did you have thin cuts on your specimens? I think it would be interesting to do this, totally embedded the specimen, because you have, you have a sample, maybe if you look at the pattern.
Yes, yeah. Make it smaller, like for neural.
I think would learn something about this. You can learn from this case.
Absolutely.
Thank you. I just want to congratulate you to raise this case. Actually, you have historical cases because in the 90s, all this was called papillomatosis of the liver. And it is true, more predominant in the Eastern countries, Chinese series, Japanese series, because they have hepatolithiasis. So the papilloma, it's very rare that you have one single. As soon as you may be sure that you have very small inside the bile duct, inside the liver, and then they grow. It's a pre-malignant lesion for sure. You don't have yet a good marker to decide if this is going to be aggressive or not. You know, however, that if the mucin level is very high, there is a potential that is going to invade the whole liver. So it's inside the liver, and they consider that possibly you think about transplant before. The question that I want to ask you is, what was the biopsy of the liver, the parenchyma? Because very often you have a degree of fibrosis, you have lesion very, very similar of primary sclerosing cholangitis that you look for inside the liver. But papillomatosis, now that we call IPNB, you consider as a possible transplant for sure, be aggressive. Sometimes you have localized in one side, then you can do a hepatectomy, but already, as you said, strong follow-up and possibly transplant before. But I
No,
congratulate
short-
you for that.
short Short answer, please.
the
Short
non-
questions.
Non-tumoral liver was no.
I propose, this rare case, I propose you collect the case, several report here, and to do publication associated all the patients. I have a case in Paul Bush. It was a large at the conference giving a jaundice, and the patient was sent to me with a bile drain, and the drain was producing a lot of liquid white, which was missing. And we did the diagnosis before knowing the tumor. I resect the tumor, only the tumor, which was at the conference. And as she was 80, she died at 90 without recurrent. It was a benign tumor. I think that when you collect the case, you will find what is called papilloma and papillomatosis, which could be different. But I think it is good to collect the case and to find the different aspects of this rare tumor.
Probably we will discuss that with Marcello later, because it's the same topic. Just one question. Is it IPNM of the exactly like the pancreas? IPNM and IPND is the same story. Don't you think so?
I'm not sure because of it is my feeling is that in the series of pancreatic resection performed 10 years ago, there is not so many invasive carcinoma, and it's relatively uncommon when you resect a benign IPNM of the pancreas that you have a recurrence 3 years after, very aggressive in a patient. So it's my feeling is that we have overtreated during a long time IPNM, but I would not say that we overtreat this patient. It's not only based on this story.
It's much rarer.
Much rarer,
Okay.
absolutely.
Jean? It's Maxime?
Yeah, I want to. Yeah, you've shown that. Okay, yes, sorry. So you've shown that almost half of patients have invasive carcinoma if you resect them. You should, or you're tempted to do a local resection, but should we operate this as periohyalocholangiocarcinoma? So with major hepatectomy with segment 1, because I think you left segment 1 in this.
Yes, absolutely. Our policy was to treat it exactly like a periohyalocholangiocarcinoma, because even if you have a biopsy showing that it's low grade, nothing tells you that a bit in another part of the tumor you have invasive. So the policy was to treat it like periohyalocholangiocarcinoma. This is my recommendation for segment 1. There was a discussion. It's true. We may have, strictly speaking, we should have resect segment 1 too. I agree.
Thank you very much.
We're now going to go to our second presentation of the day, and we will have Guilherme Tralhão. And the title of the presentation is Impact of ERA's Programs in Liver Surgery.
So thank you for this opportunity to talk about our program and the impact of our program and the ERA's program in liver surgery. So you know the advantage with the ERAS program. So to the patient, improve well pain, reduce the post-operative pain, faster initial transit recovery, patient short hospitalization time, lower complication rate, more patients treated, reduce patient costs, and to the society, short period of absence, fastest return to everyday life, and faster return to work. So in our program, we were now our
multidisciplinary meeting, you have a diagnosed, and if you have indicated to surgery, we refer the patients to the areas appointment. So in the areas appointment, you have anesthesiologist, physiatrist, nurse, social worker, nutritionist, and after that, you define the defined areas prescriptions, surgery day, standardized techniques, and discharge at you work at sea or post-operative site. And the areas nurse call the patients 48 hours after discharge and 30 days after discharge to the hospital. So we start from areas in the colorectal surgery. So in the 2019, with 1,060 till now 612 patients, and we start liver surgery, areas program to liver surgery at the end of the 2023. So you have 244 patients introduced in this program, and this year you start with pancreatic and biliary surgery, and I hope in next year we can do that in liver transplant unit. So you compare our results in the our results with 244 patients with the patient 53 patients in pre-errors interventions. So 2021, and our results are 2023 to 2024. No difference in the male and female patients. In the errors period, you have all these patients. If you compare in the pre-errors periods, the patients, the liver colorectal metastasis and primary liver tumor are the more indications to this kind of patients we have in our department. And you know the first results, pre-errors median length stay in hospital, 6 days, median now it's 4 days. When you compare the serious complications, it's a big lower if you compare the pre-error series with the errors series. The mortality, the reoperations is lower if you compare pre-errors and the errors periods, and to patients with the hemorrhagic shock and eviscerations in our series. If you compare the readmissions in our hospital, is the same if you compare all the lower in the errors period, but if you know, we show the last period of the year, the 2024, is 6.6%. I think it's a good result. The mortality is till now is not different if you compare the two periods, but we have all these populations in errors period. But the mobilization of patients, if 46% of patients are mobilized in the day of the surgery, and 71% of patients at 1 day of surgery come out the bed, so are mobilizations. And the oral supplements starts if you compare so if oral supplements is start gut functions is early in the error period. The day life activities is better at error period, and if you compare the period of line, and now you are the objective circle, but now you are a circle. I hope you can do that in in the next future. But we don't know the impact, oncologic impact of the program. So in conclusion, it's 5 minutes, it's a dispute. You can improve the well-being, reduce postoperative pain, faster intestinal transit recovery. Patient patients is very important. Short hospitalization time, lower complication rate if you compare the pre-ERAS program, reduce patients' costs, short period of stance, faster return to everyday life, and faster return to work. And this is very important to minimization the health care the patients submitted to the surgery. But till now, we can talk about long-term outcomes of this program. Thank you. Next year to come to 2026, you can organize just research network annual meeting. Thank you.
Yeah, thank you very much for your presentation. Nice presentation. ERA's already going on for 25 years, started 25 years ago. No, it is. But it's going slowly, it's going in. A few questions. We are now at the moment, patients don't come in the day before. They come in the day of the operating room, even at extensive hepatectomies, and they walk to the operating room. So they don't. They walk into the OR, and they step on the table in the OR to make sure that the time that they don't move is as short as possible. Do you do that also? That's the new ERAS. And secondly, what do you do to get them out of bed? But good, if you give an epidural, that's mostly the problem. How do you do the pain after the operation? Epidural catheter, most often with a urinary catheter, prevents that they move.
Yeah.
Can you comment on that?
So the first part of your question, you try to if the patient is operating in the afternoon, he arrive in the morning. If he are operating in the morning, if come in the day before. The second question, the
pain. Because do you use epidural?
Yeah, yes.
But if you use, do you also use urinary catheters?
In pancreatic surgery, yes, but in the liver surgery, you don't use the.
Yeah,
it's
that was what coming.
Intake with the.
Yeah, because that was a problem in the beginning with the ERAS, that the pain with all the catheters, they didn't
But not with the catheter.
But yeah, and the last, do you have a, because pre-operative, we have physiotherapists, et cetera, but what we also saw that if you cover the patients in the ward with a specific nurse, guarding, walking, did you eat, did you walk, did you do that, have you problems? So we had a nurse covering everything, then it went, and then there was no money anymore for the nurse, and then it went down a little bit, and the hospitalization days went up, and we got a new life, and it went down. Do you have a 100% nurse being on the ward next to the patient every time?
You have a nurse working the appointment, the consultations, and it's the same nurse working our unity, HPB unity. So it's Susanna, it's Susanna, and you work with the patients and take to do that. But it's the same nurse do the consultations and wait and stay with the patients in postoperative time. It's very important, this aspect.
Yes, I think it's a key point, the nurses, and we in France implemented the ERAS program several years ago, and I think that what you didn't mention a lot is the satisfaction of the patient. It's very, very different with the nurses calling them, seeing them before, giving information you don't do, and doing that education, satisfaction. And this is very important to have those the team effort around the patient in that program, and it improved also the management of all the patient, even the non-ERAS patient, because we take care a lot about the pain, as you say. It's fundamental. It's not ambulatory. so it's not outpatient, it's inpatient. And you compare 53 patients. Why why not more to have a better difference? Because you have 244 in one arm and 53 before.
Yes, because it's the error society decide.
It's the
It's aleatory.
I remember
It's
that.
aleatory selections of the patients before
Okay.
it's not me to do the selections of the patients. It's the aleatory selections of the patients before I think it's 2021. They select 53 patients.
Any other question? Yes, one.
Great presentation. Do you have data on whether you use multimodal pain regimen to minimize narcotics? My colleague at Anderson, Dr. Zhang, has initiated this multimodal pain regimen approach where more than half of patients, even after Whipple or major open liver surgery, can be discharged without any narcotics at all. So to what extent do you use muscle relaxant, anti-inflammatory, or Tylenol?
We have that approach too. We have this anesthesiologist that is it's part of the program, and she visits every patient every day. So we use the intrathecal morphine start, and then they use that multimodal approach, and none of the patient does. Ideally, don't do the narcotic drugs.
Yeah, just want to echo or just that of MD Anderson. We gave up using epidural, I don't know, 15 years ago. So I haven't had one patient on epidural anesthetic in a very long time. We use multimodality protocol with using muscle relaxant and liquid Tylenol, Toradol, and similar. And a lot of patients are discharged without narcotics. It's very rapid recovery after robotic Whipple and often after open Whipple if it's really like some super complicated thing, which is rare these days. The nasogastric tube comes out the next day. We feed them almost instantly, and it really shortens the whole circuit. On wounds, if it's robotic or laparoscopic surgery, we use long-acting local anesthetic type of similar or combination of steroids with local anesthetic. And on open incisions, we use intramuscular block performed by anesthesiologists. And that really makes a difference because they're breathing better. We get the patients out of bed same day, the latest, the next morning. Incentive spirometry is used instantly in the recovery room. And of course, we always bring the patients the day of surgery, regardless of how early it is. They come on that day, so the cycle is very short. And I really think that in the days of robotic and laparoscopic liver surgery, even major hepatectomy can be sort of considered an outpatient procedure because a lot of these patients are ready to go 23 hours later. The hospital makes us keep it because they get reimbursed in different scenarios. So we kind of keep them at least one day, but a lot of these patients are ready to go right away with this protocol.
Thank you. Another comment.
You have to be careful because also the original, when we started with Gilead, with the ERAS, we had a one-day hospitalization for the colons, but we had a readmission rate of 27%. So there is a board of patients, they have to get used to it. They are very satisfied, but we also have to watch. You cannot go after a big hepatectomy with a drain or without drain at day one. I think that's a little bit too positive. They have to.
It's very selective. No,
Okay.
You know, I'm not saying that every patient goes. No,
We tried on
the surgeon can go home on day one.
We have to differentiate also the hepatic surgery and the pancreatic surgery.
Yes.
Because the length of hospitalization is due to morbidity and not to ARS management.
Right,
Thank you
please,
very much.
Thank you.
Next presenter will be Marcelo Linares with the a presentation of intraductal papillary and mucinous tumors of the bile ducts.
Good afternoon. I will present, I will talk a little bit about the intraductal papillary neoplasm of bile duct, IPNP. We have a definition of, it's a relatively new disease. First, it was described in 2001, and it is conceived by World Health Organization as a rare epithelial tumor with papillary and villous intraductal growth and mucin production. And it has the potential, as we have seen, the potential of malignant transformation, and is recognized as a cholangiocarcinoma risk of cholangiocarcinoma risk. We have 4 kinds of histological subtypes: the gastric, intestinal, pancreatobiliary, and oncocytic. But the intestinal and pancreatobiliary are more associated with dysplasia and cholangiocarcinoma. We have 2 classifications. The last classification for Health Organization, World Health Organization, 2019. The non-invasive cases as low-grade dysplasia and high-grade dysplasia with marked atypia, and the type 1 and type 2, like the pancreatic disease. The type 1 is more intrapancreatic, like here, is simpler and better in comparison. This one, that is type 2, that are more extrahepatic. They are more complex. And, there is more infiltrated, more associated with cholangiocarcinoma, and has the worst prognosis. And in Asia, we have risk factors for IPNB, is a patholithiasis, as we have seen before, with intrahepatic bile duct stone, liver infections, is chronic infestation or noccinate obstructions, liverini, and primary sclerosis cholangitis, as you have seen before, and congenital biliary malformation, and occupational exposure to chlorinated organic solvents. So you have image patterns. The most important finds of image patterns are enhanced papillary mass with bile duct dilatation, and is in magnetic resonance, MRI, due to hyperintense mass and to one hypo or iso-intense mass intrahepatic. So the goal of this presentation is synthesize clinical, radiological, pathology data regarding IPNB. And answer this question: is it possible of IPNB in Western country be different from the IPNB in Eastern country? So we performed electronic data search for IPNB with no time or language restriction, no restriction of time of report. And we will present the entire cohort and the comparison between Eastern and Western country. Only studies that reported that data were included. And he used artificial intelligence, ChatGPT, to help synthesize the spreadsheet. And then we double check all the information. So we studied by ask the ChatGPT, open evidence and close, and then use notebook LM to build this we studied the clinical data, age of patients, sex, clinical manifestation, abdominal pain, jaundice, cholangitis, weight loss, the data about the imaging findings, location of the lesion, intrahepatic, extrahepatic, extrahepatic, and the procedure performed, major hepatectomy, minor, extrahepatic bioduct resection, presence of lymph node dissection, pancreatic duodenectomy, hepatopancreatic duodenectomy, and we studied also the rate of high grade dysplasia, carcinoma in situ, and the invasive carcinoma rate. And also the long-term outcome, 1, 3, and 5 years overall survival and disease-free survival. So we have the PRISMA, we studied the PRISMA, 118 screened article, and then we excluded 54 because of they were not related to the team, or they did not have own casuist. And we remove article that did not include IPNB. So we had 52 eligible article with 2,140 cases. As in comparison, we have 15 studies in Western population with 127 cases, and 37 studies in Eastern population with 2,013 patients. The first demographic data we have seen is we had more male in the population, 60% in the total cohorts, and there is a prevalence of male in the Eastern population. And we have a slight older patient in the Eastern cohorts. When we see the world distribution of this case, those cases, we can see a concentration of this disease in the Asia, more in the 5 countries more, in South Korea, China, Japan, Thailand, and Taiwan. And the Western countries, we have a very low cases, very few cases. The publication are very small. The case report or the simple series of cases. In comparison, the multi-center studies in the Eastern countries. You can see here the 15-fold increase of this disease in the Asia in comparison to the all other countries of the Western. And about the symptoms of this patient, we can see that we have the double of symptoms, abdominal pain, jaundice, and cholangitis in the Western country in comparison the Eastern country. So we think, interpreted this data, that we are operating the patient later than the Eastern countries. They are operating the case initial evolution of cases. Ultrasound finds general, they see cystic lesions, bioduct dilatation, and more specifically, we can see in CT and MRI, cystic lesion with mural nodules, but more specifically, most frequent findings in this disease are biliary tract dilatation with nodules, intrahepatic nodules, or intraductal projection. So when you have this finds, it's very important to operate this patient before it have symptoms. So it's a case with the dilated bile ducts with intraductal projections. And we can see the communication, the finds of communication with bile duct is by concept. This disease has communication with bile duct, but we can see just in 10% of those patients have this finding in the CT, MR, and MRI. About the anatomic location, we have a strange find. Intrahepatic disease is more frequent in the Western and Eastern population, but extrahepatic disease is more frequent in Western countries than Eastern countries. This is strange, but is what we have found here. And about the treatment performed procedure is in Western country, they have more major and minor resection, but in Western country, we have more extrahepatic resection and resection of caudate lobe. And Eastern country have more pancreatic duodenectomy associated and had just one liver transplant. I will show one case. We have 3 cases, but we did not have any one cholangiocarcinoma, neither a high degree dysplasia. You can see in the segment between the section anterior and posterior of the liver of communication with bile duct. And we performed the laparoscopic resection of this disease. Perform the Pringle maneuver. Have this section of anterior and posterior section biliary ducts, but it was necessary. And then we demarcate the limit of the dissection with ultrasound also. We stapled the glycerin and pedicle segment 5 and 8. Then we remove the anterior section with the limit of the right hepatic vein. We can see, to answer the mark between question, rate of high-grade dysplasia, carcinoma in situ, and carcinoma, invasive carcinoma. We have 80%, 82% of this carcinoma and high-grade dysplasia, but in Eastern, it was more prevalent with 84% in comparison, just 50% in Western countries. And the overall survival was the same, almost the same in 1, 3, and 5 years. And it was insufficient data in Western country to show the disease-free survival, but in the Eastern country, it was 53%, even if the disease is more less invasive and less cholangiocarcinoma. So in conclusion, we have five of cyst lesions, intrapapillary projection, dilated bioduct, and communication with bioduct. It's more common finds in the images. And Eastern studies of IPM found more intrahepatic disease. There's fewer rates of report symptoms. They probably operate the patient early, major hepatectomy, and high-grade dysplasia, carcinoma in situ, and invasive disease. And the end-to-end, we have epidemiological, clinical, anatomical, and pathological features of IPNB differ significantly between Western and Eastern cohorts. Can it truly be considered the same disease across region? Or we have some environment that I already described previously that increase the frequency of this disease in the Eastern country. If IPNB is categorized as a single disease entity, should it be managed uniformly across Western and Eastern population? This is my question to discuss with you. Thank you.
Now we will have Manuel Jackley.
Thank you very much, Mr. Schweigert. Congratulations for your demographic presentation. IPMB is a bit of a gray area. All of us all have this. And rather of getting easier at the moment, we're subclassifying even more. So there has been, nowadays we talk about two different entities. One's small duct IPMB type 1 and big duct IPMB. And what studies have shown, the big that we know about it, is that type 2, that's the extra hepatic, does not behave like an IPMB. We associate the behavior of IPMB like an IPMBN from the pancreas. So this mucin production is more intra. No guidance, we know guidelines for this, but my question to you is, should we treat this? This is not a lesion with a risk factor of being malignant. This is a pre-malignant lesion that will, the natural cause will be cholangiocarcinoma, high, low, high. And so should we treat this as a cholangiocarcinoma once we detect it from a surgical point of view?
Depending information. For instance, like you told previously, if you had the type 2, that is extrahepatic disease with complex papillomatous finds, it's important to treat as a cholangiocarcinoma because there is high risk of high dysplasia, infiltrated cholangiocarcinoma, and be treated along with the duodenopancreatectomy. About the disease intrahepatic, even if it is considered less invasive, less risk of malignancy, we should treat it like Mark presented. We should worry about that, about the presence of mass, the presence of complex villoso papillomatous disease. We should treat thinking about the diagnosis of cholangiocarcinoma.
Questions?
In your study, did you find or did you confirm risk factors for all the cases in the Western world, liver flukes or something?
Theoretical finds. This is not. It was not possible with artificial intelligence to detect this case because you have not access to the histological presentation of this patient, those patients.
Question? Don't you think that the reports are the rate of reports are very low because it's quite not a new entity, but I think that a lot of those patients was misdiagnosed before with cyst or mucinous cyst or papillomatosis, which is one type. And maybe in the case report, we missed that.
Yes, I totally agree with you, mainly in the Western country, because over there, they have a high prevalence. I think they are diagnosing very early, much more the patient than us. So when they notice that we have a bile duct dilated, they operate the patient very early in comparison. That's our, yes.
Thank you.
Professor Laurent, with her presentation of liver resections due to iatrogenic bile duct injury.
Okay, thank you for the opportunity of discussing with you about really big problem, and I'm sure you will all agree that bile duct injury is a concern and a persisting tragedy. Even after the settlement of the laparoscopic cholecystectomy in 1987, it's now a gold standard. It's no more learning curve. As you see, I just typewrite bile duct injury and cholecystectomy today, and as you see, there's a lot of publication on the subject. I don't know what. I don't know why. Okay. It's not, I'm sorry for that. There is a lot to discuss about this bile duct injury, which is now around 0.2% of the cases, about classification, time to repair, long-term, term, quality of life. Everything has been discussed, and particularly the type of repair, which can be endoscopic, radiologist, and the surgical approach. And this is exactly what we are talking about here. It's about hepatectomy. So what are the data today? We have a relatively recent article about the hepatectomies after those type of injuries, and it collected 84 patients from 8 cohorts from all over the world. There are all small series from 3 patients to 18. The mortality was, around 0 to 18%. Short-term results are really not easy to analyze. And the long-term result unknown with biliary symptom, as you see, from 9 to 50%. So we definitely need a larger cohort to better understand the specificity of these hepatectomy. So our main objective was to assess the outcome of the hepatectomy performed for this indication on the short and long-term morbidity. And the second objective was to provide comprehensive overview, specificity of the indication for hepatectomy in this indication, and identify the prognostic factors associated with the severe morbidity. So we conducted a retrospective multicentric study, and we called the 13 tertiary French centers expert in hepatobiliary surgery. And we included for quite a long period of inclusion to have the follow-up from 1995 to 24. And all the patients with bile duct injury for cholecystectomy for litiges treated by hepatectomy. And we excluded the partial hepatectomies of segment 4 just to do the hepatogenostomy. So these are the results. We collected 90 patients 56 women, median age, as you see, from 17 to 83 year, so around 60 year. And the major procedure was a right hepatectomy, as you see here, 67.8%, right lobectomy in 6 patients. And as you see also, the episiotomy was associated in 2/3 of the patients. So another point is the median delay to perform hepatectomy from the bile duct injury was 21 months, a very large range from 0 to 500 months. And we divided into the early hepatectomy, 22, and the delayed one. So the overall morbidity was 73%. And if you focus on the severe morbidity, it's quite high, 39%. The mortality was 5.6%, 3 for liver failure, including 1 after an emergency liver transplantation, and 2 septic shock. So the length of stay was 12 days. Readmission was quite high, 17%. The long-term outcomes with a long follow-up, 30 months, was quite good, since 78 patient, that means more than 90% of the patient had very good or good result after the hepatectomy. Concerning the indication of the initial cholecystectomy, it was, as you see, half acute, half non-acute elective cholecystectomy, and biliary injury was diagnosed intraoperatively in 40% of the patients, and 40% of the patient had a previous attempt to repair, and more than half of the patient had a previous endoscopy or radiological drainage. Concerning the bile duct injury, as you see, it was in the majority of the cases a very important injury. In 6.8%, it was E4. The injury of the posterior branch was present is nearly 20% of the cases. We had an injury of the right hepatic duct in 11%, and which is quite important. The vascular injuries was in this indication very frequent. As you see, 45% of the patient has arterial injury or both arterial and portal injuries. If we classified the indication, I think we have 3 major classification after seeing all those cases. The first one is the liver necrosis, and it is mostly with vascular injuries, as you see here, massive necrosis of normally the right liver. The second indication is the sepsis, either acute or recurrent, and mostly there is a liver abscesses in 11% of the cases, and sometimes intrahepatic lithosis, like you see here in this photo. The third great indication is the impossibility to repair, like here, that you have exactly like a Klatskin tumor. You can't anastomosis a lot of bile ducts, so you are doing one anastomosis in one big duct. And we have, well, 5% of other indication, which was a chronic fistula or pain related to the bile duct dilatation, or maybe hidden angiocholitis. So we classified according to the delay. We have 20% of emergency hepatectomy performed in median in 2 months after the bile duct, and we have here very serious patient with liver abscesses, biliary convergence injuries, arterial injuries, and as you see in that population, mortality rate is quite high, compared to the other group, which was elective hepatectomy. This is the main indication, with a higher rate of recurrent biliary sepsis, intrahepatic lithiasis, and here previous attempt to surgical repair in half of the patient. So we have this is quite interesting because I expect different results. We have the same overall and severe morbidity, not the same mortality, but the same morbidity and the same long-term result according to Terre Blanche classification. We try to find the prognostic factor of severe morbidity with multivariate logistic regression analysis. And as you see, we individualized 3 factors associated with the very bad result, which was liver abscesses, the association with an hepatic angiostomy and blood transfusion. On the contrary, left hepatectomy was associated with better outcome. So this is my knowledge is the largest series with, of course, the classical DS of a multicentric and retrospective study. We have here a non-negligible mortality, more than 5%, and very high morbidity, 73%. It's higher than previously described, and the mortality rate is quite high, to my opinion. It's because it's a benign disease, and notably, remember, more than 15% of mortality for salvage hepatectomy. And hepatectomy can be classified according, finally, 3 major indications: sepsis, necrosis, impossibility to repair, and 2 situation, emergency and elective. So in conclusion, hepatectomy for bile duct injury are, of course, a rare option because we only collected in 30 years in tertiary centers in France, only 19. Maybe I have to analyze again 20 patients, but it's preliminary report, so not more than 100, which is quite low, but it's a registry, so we probably missed some bad cases. Usually performed after previous attempt to repair or non-surgical procedure, a lot of endoscopic, radiologic. Those patients had drains, have sepsis, and of course that explains the short-term outcome. And it should remain, of course, the last option and should sometimes be discussed earlier, to my opinion, before abscesses, multiple drainage. Of course, sometimes we have salvage hepatectomy and we have not the choice. So respecting the indication, this should be done in high volume HPB center. And if the price, of course, is high, long-term result in HPB centers is very good because we have more than 90% of good result. Thank you for your attention.
Thank you. Now we have Christophe Sinevics as discussant.
Thank you. First of all, I would like to thank you for the opportunity to comment this brilliant presentation. Like always, congratulations, Laurence. That was my pleasure to look at this topic, which I absolutely share your opinion. It's a tragedy, both for the patient and as well for the service. I mean, the biliary tract injury. All of us know that those patients are very difficult one, and the strategy is very important. You presented the data from 13 French centers with the numbers who are much, much better than published previously. You showed the almost 18% of mortality in this group of patients. And as far as I remember, the percentage of bile duct injuries reach to even to 1%, not 0.2, 0.3 like in your series. I have 2 questions. The first question is about the primary operation, whether it was laparoscopic, open, or robotic, because robotic surgery also is introduced to this group of patients, I mean, for follicular cystectomy. And additional, the percentage of bile duct injury in robotic surgery is almost doubled when compared to laparoscopic. That's strange, but these are data from the literature. And my second questions is about the liver transplant in those group of patients. In our cohort, more than 3,000 patients transplanted in our center. We have two cases that we are obliged perform a salvage transplantation within hours after the injury with a severe bile duct and vascular injury. Those are my questions. Thank you and congratulations again.
Thank you for your question. This is the period of inclusion is 90 and today, so it is 95% of laparoscopic cholecystectomy. But within those cholecystectomy, there are conversion, because now it's not. I think we have to discuss the learning curve of laparotomic cholecystectomy. So we have this is very important, because the recommendation change, and we have a lot of conversion in those biliary injuries, because they try to correct and it is a disaster. So now the recommendation is, if you recognize a bile duct injury, do not convert, drain, and transfer. And I think that this in all this patient was not exactly the rule at the beginning. Now, I think that this message is going on. The second point, I reported the French experience of liver transplantation. This is a large series of 30%, 30 liver transplanted for in that indication. Of course, it's 0.002% of the liver transplantation, but it remains a real issue too, because we have, this is the climbing the terrible from the epigenostomy, epitectomy, and liver transplantation. We have in that only one that failed, and access to liver transplantation in this series.
Laurence, I thank you for this series. I think it was very important to publish on this. This is a very debatable point. For me, I am very concerned by liver resection for biliary trauma. I think it is a big failure of the repair. Of course, in some cases, you can avoid that when there is vascular lesion associated, like throat tissue. You cannot avoid it. It's not only biliary trauma, it is more than the biliary trauma. But you have 70 cases, you said 70%, where it was difficulty of repair. And this must be discussed really. I heard one time in a French Congress, somebody said, it is easier to do a right liver resection than the biliary repair. It's terrible to say that. But this is true.
It is.
It's easier to do right liver resection.
It is. It's not only, no, it's not only easier. I think that the results are better, because if you have an anastomosis, even with a very good surgeon, with 2 or 3 thin bile duct, not well vascularized, it's better to do a right hepatectomy than try to do this repair, which is not satisfying for us. Or, even if you are a very good surgeon, you have a very bad tissue.
Laurent, we have before that why you are in the situation to have 2 or 3 small bile ducts. You have to wait, they become large.
Not always, because, you know, you have other concerns like sepsis, abscesses, pruritus, grains. So it's not easy to say they're always gonna delight. But additionally, somebody, I think it's you, said that for benign tumor, sometimes you wait for a dilatation that never happens. Right?
Waiting for.
But no, but I think you are right, but it is terrible to think that it is better to do right hepatectomy than to do a repair. It is like you go to for your car, we have damage in the car, and the garage say is
Change
easier
your car,
and
change your car.
easier to change the engine than to repair.
Thank you very much. My question, there are some hepatectomies that you do because the liver on one side is completely atrophic. And in fact, that's taking away that left liver, for instance, which has shrunk to a very small atrophic nothing, is not to be considered in the bunch of the hepatectomies that you think, that you presented.
I presented one. Yeah.
Yeah, and I think these are a different category. of hepatitis.
I understand that. In fact, sometimes you have atrophy of the liver concerned by the bile duct stricture. It's quite frequent for a posterior sector. It can atrophy, and if nothing happens, it's no need to do an hepatectomy. You can, well, let the atrophy. In those patients, they have sepsis. Even if that is quite funny, because even if the liver is atrophic, you can have intrahepatic biliary lithiasis, and you can have most of the time sepsis, recurrent endocarditis, and sometimes, I don't know why, but pain. You know, pain, the chronic pain, and sometimes, well, left hepatectomy like that, it's rare because the bile duct on the left bile duct is quite far from the gallbladder, but they have 3 or 4 patients like that, but all were symptomatic. So the message also is no need to do an hepatectomy just to cure a CT scan. So to cure a patient.
Yes, thank you very much for your presentation. My question is, when we consider right hepatectomy, very often the problem is the volume of the future remnant liver, because we want to have enough volume, and usually after bile duct injury, there is cholestasis, cholangitis, and usually, so you want to do a portal vein embolization, but this is not possible because there is a right artery damage. So my question is, what is your advice, your recommendation when you have a small liver remnant volume, no possibility to do portal vein embolization due to concomitant arterial lesion? Do you perform hepatic vein embolization? What's your opinion about that? Because sometimes we are a bit reluctant because of the risk of liver failure.
Yeah, the point is that if you intend to do an hepatectomy for bile duct injury, you have to be particularly safe. So agreed, we have to check everything, and particularly the volume. But most of the time, this is not an issue because there is atrophy of the liver on the side of bile duct. Most of them you see is the posterior sector of the liver, so no problem. For right hepatectomy, we need here only 3 patients for a portal embolization. And you said You can't do a portal embolization because of the injury of the right hepatic artery. Well, you know that after a right hepatic artery injury, you have communication and the liver is still vascularized, so you can do. It's not for me a contraindication of portal embolization because I never saw a necrosis of the liver because of that. And even if you have, well, you do the operation a little earlier. That's all.
Alessandro.
Thank you. Thank you, Madame Chiche. You have shown a higher morbidity for this kind of hepatectomies, and rehabilitation have an impact on postoperative morbidity, especially I think in this kind of patient that have impaired nutritional status due to inflammatory status and external drains. So did any of these patients receive this kind of preparation to surgery, and what's your opinion about?
I didn't check on those, you know, it is a retrospective, multicentric, so I didn't have that information about rehabilitation. But in fact, that is the point. We have three indication. In the first one, well, no rehabilitation, it's emergency, you know, in 20% of the cases. For sepsis, it's very difficult to rehabilitate somebody who had sepsis because it's difficult to have nutrition. So you have to do preparation, but not rehabilitation. And for the rest, which are impossibility to repair, I'm sorry. Well, those patients, of course, should be prepared to surgery, and everything should be checked up because the morbidity should be less than that. But the morbidity I show is particularly bile leak, sepsis, pulmonary embolism. So it's high level morbidity because the patient, as a matter of fact, were septic before the operation.
There. I have a question. You have a patient comes to you just after the injury. It's a completely occluded right hepatic duct and a replacement hepatic duct. Bismuth 5. Do you try to repair the duct or you do a hepatectomy in a healthy liver?
In a healthy? If I think that my repair will be a good quality repair, of course.
So you wouldn't do a hepatectomy?
No, hepatectomy should be the last option, of course. Otherwise, Mr. Smith will yell at me. Okay.
Thank you.
That's one. Next session.
Maxime de Wolf, could you?
Yes, of course.
Okay.
Thank you. So thank you very much for the opportunity to present here. To take you through an evaluation that we did on surgery for perihilar carcinoma without preoperative drainage. And of course, this is a probably controversial topic, but I hope we can discuss just for a minute. Point out this paper from 25 years ago, in which he reported outcomes after major hepatectomy in jaundice patients, and where already biliary drainage was questioned. So they saw no significant difference in post-hepatectomy liver failure nor in mortality. And actually, in this paper from 2008, some clear criteria were proposed already in which patient population probably this type of surgery is or should be safe. These are some nationwide analysis from the Netherlands, in which we actually saw some very surprising results regarding where the patient was diagnosed. So you see clearly the people or the patients who got resection did way better than patients who received palliative treatment. But depending on the hospital where they were diagnosed, their outcomes were highly influenced. And if you look at these data a little bit more into detail, see that probably the resection rate is responsible for this differences in outcome. So if you look at academic hospitals that perform this type of surgery, chance of getting resected is 32% diagnosed in that hospital. Diagnosed in a referring hospital, this was only 13%. This is different from systemic treatment, which was quite comparable between both groups. We've also seen, again, a nationwide analysis on biliary drainage patients with malignant hilar obstruction, that this success rate of this initial drainage is very low. It's around 20% for ERC, 30% for cutaneous drainage. And there has been an analysis from Professor Giulianti, where they've seen an centric Italian study that the success rate of initial drainage predicts your overall survival and resection rate in right-sided resection. So just to conclude our introduction, what we see in literature from perihylar cholangiocarcinoma is not what we get in real life. We have surgical sequence. A large minority of patients, but we have very few data on why these patients don't get to surgery, which actually is 85% of our patients. Furthermore, we have made few improvements in overall survival in perihylar cholangiocarcinoma, and probably making more patients resectable will have the highest impact on, and at least to some extent, biliary drainage renders some patients inoperable. And actually, maybe that is the main message of the drainage trial that has been stopped prematurely. So do we always need biliary drainage? It appears to be a difficult question to answer. We did an attempt using a multi-center database, including data from quite a few European centers, some from United States. And after excluding patients who did not undergo major hepatectomy or had a pathology other than perihylar cholangiocarcinoma, we collected data of 2,067 patients, of which 350 underwent surgery without preoperative biliary drainage. Probably this is the most important slides of my presentation. Of course, these patients are not comparable. We all know this. Patients who had preoperative biliary drainage probably had more advanced disease. At least they underwent more extensive surgery, more right-sided sections, more PVE and so on, and they had higher comorbidity. So in an attempt to correct for that, so if you look at the variables that we've seen in our database prior to propensity score weighting, which I will come to just in a second, these groups are non-comparable, and this makes interpretation of these data maybe impossible or at least somewhat difficult. As an alternative to propensity score matching, where you lose a lot of data and introduce selection bias by excluding these patients, we went for propensity score weighting, in which to make groups comparable, you weigh certain cases more to make them comparable. So after this weighting, we were able to have somewhat comparable groups. These are our main outcomes. I will come to the first three just within the next slides. But regarding bile leak, regarding overall survival, regarding blood loss, this made these groups comparable. Operative time was slightly higher, although the clinical significance can be questioned. And if we look at data that really interested us within this analysis, we've seen that prior to weighting, the 90-day mortality rate was higher in the patients who had preoperative biliary drainage, which is logical. After applying weighting, this was no longer significant. So there was a trend regarding or a higher 90-day mortality rate after biliary drainage, although this is not statistically significant anymore. So regarding major complications, a little bit the same story here. So prior to weighting, there was significantly higher rate of complications. This was still significant after propensity score weighting, but we performed a multivariate analysis on the weighted cohort to correct or control for our analysis. And there we've seen that this is no longer statistically significant either. And this was different for post-operative liver failure. So this is grade B/C liver failure, where we've seen higher rates in the group who underwent biliary drainage. This was still significant after weighting. And in a multivariate analysis on the weighted cohorts, this was still statistically significant. Limitations, certainly we have to discuss this in this type of analysis. This is a multi-center design. This is retrospective. So there's heterogeneity in biliary drainage, use of PVE, operative strategies, and so on. Once more, this is again surgical data, so no data on the majority for patients. And we did not have reliable data on FLR volume to correct. So despite all the statistics that I tried to explain, propensity score weighting, imputation, these are still groups that differ significantly in their baseline characteristics. So this makes interpretation of this data difficult. I tried to conclude in a cautious way. I think this analysis shows us that a period of the biliary drainage did not make 90-day mortality or major complications better. There was a higher likelihood in patients who had preoperative biliary drainage. And if it does something, in my opinion, this analysis adds some data to challenge routine biliary drainage in this type of patients. And maybe there is a room for randomized studies. We highly select these type of patients. And of course, these inclusion criteria, as I could call them, have been by Professor Shekli already 20 years ago. Just as a last slide, I would just like to show you this. This slide is of some preliminary data on a study that we did on MDT assessment of patients with perihylar cholangiocarcinoma. What we basically did is send 20 of our cases to MDT panels across Europe, and some of you have participated in the study. So what you see here, so each line is one patient. And if the line goes up, this is an MDT who wants to treat this patient in a curative way. If the line goes down, this is an MDT who says this is a palliative case. And you see for the majority of patients, this crosses the line. So this shows that MDT is very important in determining the treatment of a patient with perihylar cholangiocarcinoma. Thanks very much.
Now we will have Gina Grisa as discussant.
Thank you for your talk. I totally agree with your first slide with the hamburgers, because it's true. You have tons of publication, but you don't get what you're dreaming of. The question that you've asked in your title is, first of all, do we need to do routine preoperative biliary drainage for all the jaundiced patient with Klatskin tumor? The question is, do we have to? Is it a patient because he's yellow? If he doesn't have sepsis, if he has enough volume, you don't need to drain systematically. This is the first comment. The second comment is, why do you have to do that? Some teams need to do that as a surgical strategy with portal vein embolization because you don't have enough remnant liver. There's a question of IPSI or contralateral drainage. And the third thing is what type of drainage? And you've said it, and I agree that in your country, you've done the vast majority of the control trial. However, there is a limit of this trial. I'm not sure that we can do any more randomized control trial because of the dropout, people dying, and you had to stop the trial. And as long as you don't answer the correct question, why do you need to drain? That's the reason. And what type of drainage? Because there is also the risk of endoscopic versus percutaneous, metastatic on the tract or not. So these are the questions that you have to keep into mind. And what I want to know, because you did that study, and also I love statistics with propensity score weighting, as you said, what did you want to show with this statistic? And what is really the message that you want to leave us with for drainage in patient with, obviously, we're talking about the type 3, probably 4 Klatskin tumor. What is your message for that? And second, by looking in your data, why you didn't exclude the PSC? Because I've seen patients with primary sclerosing cholangitis, they shouldn't belong to the group with Klatskin tumor. Thank you very much.
Thank you. So actually, this analysis is, for me, part of my crusade to avoid gastroenterologists or interventional radiologists to drain any patient with a bile duct dilation. And all the data that I can gather from the data that is there, I want to use to say, stop doing that, send it to an expert center, and then we will have to judge first what is the correct diagnosis. Second, should we drain the patient? And third, how should we drain the patient? And I fully agree, probably this is a patient population where you cannot do any RCT. We tried 2 times, and it was somewhat different from this analysis. But I think this will be a patient-tailored surgery from diagnosis until treatment forever. And then the only data that we have are retrospective. Regarding your question on PSC, it's a very marginal. It's a very.
Yeah. Can you go on the slide before last on, apart from that was very funny, but the unpublished study. This was different MDMs, right? That's very worrying in a way, because it's not just the surgery. In your conclusion, you said that MDM is important, but in fact, from your slide, is that we should sort of either raise or equalize the level of MDMs, because even MDM is not a guarantee that the patient gets treated in the same way, which it should be.
Yeah, of course, this is preliminary data. This is only the primary outcome. We will have some more data on undrained patients or how these patients are treated or assessed, depending on the case that we presented. And this is only data from 9 centers. So we will have more, and we'll have some Eastern centers as well, which will give us more information. But the real goal of this analysis will be to identify fields within diagnosis or maybe treatment where we can make some progress. That is actually the goal of this study. But this is highly worrying. Depending on which NDT you refer to, you get a totally different treatment.
Daniel, please.
Thank you for mentioning my paper from 25 years ago. This is a paper that put me in trouble because I was excommunicated from Japan. And so basically in these days, biliary drainage was not what it is today. And patients were having recurrent sepsis, dislodgements of percutaneous drains, percutitis, which is still the case of pancreatitis. And many patients dropped out from surgery, perfectly operable patient dropped out from surgery just because of complications of biliary drainage. And basically you have a patient, a fresh patient that comes jaundiced, and then you have a patient with sepsis. So this is where, and so when I was seeing a patient, so I was frustrated with that. First, I had a few patients who had percutaneous seeding that I found for that. So in these days, which is a long time, the paper is from 25 years ago, but the patients are before that, obviously. So when this happened, when I had a fresh patient with left side, it was always without drainage because we need a smaller hepatectomy as compared to right side. And we had a good patient with good liver volume on the right side. And as you mentioned in the paper, it has to be early jaundiced and a bilirubin, which is less than 200 micromoles per liter, which is even high, probably 150. So in this paper is true. The results were okay. And the patients were brought to the operating room the following week, or the following day sometime. This is not practical anymore. And now for the patients that, so on the left side, when we have a patient who is fit we go directly for surgery as every time. Also, you need to operate quick, which is not very easy but on the right side, it's finished. It's drainage, endoscopic, part of it on the future liver remnant, which is of course, because sometimes on the wrong side, and of course with portal embolization. So I think that it was just a provocative paper, but thank you for mentioning it.
Yeah.
But for the right side,
No,
nobody would recommend that.
I just added our flow charts that we use in our hospital. And if we indeed have a patient and we took it down to 150, and indeed fast surgery within was taken into our flow charts. And regarding your remark on indications for drainage, in my opinion, this is jaundice or rarely cholangitis. I just brought this data from Rotterdam, who did a Tesla trial or doing a Tesla trial in palliative setting, and they have cultured every bile duct that they punctured. And what you see here, that in 95% of their cultures, there was no bacteria. So the drainage causes the cholangitis. It's not the obstructive.
Yeah, I think you, with your last slide, I think you're raising a very, very important point about the MDT. I think at our institution, we've done a prospective study, and I think in 30% of the patient, there's a change in management. Because we ask people, how would you manage, so there's a change in management. But to ensure the quality, I think, of the MDT, the consensus is just going to be as good as the participants. So I think there are two very important things here. Is you have to have surgeons, a certain number of surgeons. Number one, a critical number, because you may have surgeons who don't operate, and then it's considered as a surgeon being there at the table, but you're not going to have the good opinion. So then not extend the MDT. You have MDTs that last for 3 hours. It's impossible for surgeons to be there. And then another point is to have a surgeon in charge of the MDT. We found at our institution, we're doing this, we sort of concurring we have several MDTs. We have pancreas, we have liver, we have neuroendocrine tumors. Now we just had another victory because the neuroendocrine tumor MDT is going to be led by a surgeon. So when you have a chance, when the seat is vacant, just jump on.
Yeah, I fully agree. We try to select centers that have really dedicated MDTs and have sufficient experience to give a good opinion. Of course, this has drawbacks because your decision on what you say you will do doesn't have any implications. I fully agree. And I think the real goal is to identify areas where we can improve.
Yes, maybe a little comment on the MDTs. We did a study in Germany where we looked at all the big liver centers, and we took all those patients and we went a new MDT with only liver surgeons performing more than 150 or 200 livers, and 34% of the decisions of the liver MDT was changed in resectable instead of non-resectable. So that supports your data. As you have a real good MDT with real good surgeons who are really can resect portal veins, can resect arteries, thinking about the morbidity of the patient, because that's what we haven't heard so much today. It's always about the quality of life of the patient afterwards. That's always the question. But I think a good MDT would be nice with centralization.
Yes. Thank you for doing all this work. I have to say, and maybe I don't keep up, I don't read enough papers, but this talk is really surprising to me. Perhaps I had a lot of understanding that cholestasis is harmful for liver regeneration. And, and maybe my cases are more complicated, so I never noticed there was an advantage to avoiding the drainage. But, there's a couple undertones here, one of which is to be very critical of our colleagues in other specialties. And maybe that's appropriate, but I think it's optimal to create a team culture where every member of the team, including advanced GI or IR, are at the top of their game, just as the surgeons are at the top of the game. Because if this message is because people are doing a bad job with interventional procedures, then that's really sad. You know, the question is, what's the biology here? And for me, the biology is about cholestasis and regeneration. So perhaps with these right lobe remnants, regeneration is not so important and doesn't affect the outcome. But I'm just worried that the wrong message might come out of this thing. Have you written this yet? Perhaps your discussion could be very prudent about the biology.
Yeah, I fully agree. And there, you could read this as don't drain these patients and go for undrained resection and don't touch our patients and we know it better. I know what I know what you say, but actually there is some frustration on how these patients get referred. I have one case that I brought. This is really the disaster that you see if the initial drainage goes wrong. And that's not to criticize one, but sometimes I think there's an underestimation on the complexity of biliary drainage in these type of patients.
Can I say something? That cholangiogram is a perfect example of the big mistake that the puncture is too medial, too close to the hilum. So those are presumably coils in injured arteries, is that right?
No, this is PVE. So this is really a disastrous case. You have on day 0 PRCP with 2 plastic stents, which is considered the golden standard, and then was referred to our center and really got into big trouble and eventually ended up as.
So it's clear people screw things up, and it's very sad because nowhere in the world do we have a fully managed healthcare system. But it's a shame that that causes us to change our strategy.
Good word for the end of this session. Thank you very much.
Daniel hoje saiu da minha pequena na meta.
I get it. So you think that should be trained. But also, one more thing is what training. The training, you can't see they don't do a proper CT MRI. They just train. Okay, why? They have a they don't they when you look at the pictures, they do an MRI and then they borrow drain the left. You tell them what to do. Yeah. Yeah. You know, where do you just you know, it's a thought that you don't, yeah. I get what you're saying.
Session séparée. On voit entièrement que les boulanges.
Bye. Ciao.
Pas grave. Alors, c'est donc leur date. C'est collé au. Ça, il y a juste un couloir. Non, c'est deux bâtiments collés. Non, pas vraiment. C'est juste l'explore. Mais vraiment, c'est vrai. C'est collaboratif. On récupère la blague. Donc, avec ça marche. Et quand on publie, on publie ensemble. Et bien sûr, ça devient leur passion, leur système, c'est que elles sont ouais, c'est ça, c'est ça. Mais sinon, un protocole. Au dehors, c'est le même chose. Ah, protocole aussi avec. C'est ça. Souvent, un programme qui sont très. C'est un grand centre, ils font. L'année dernière, c'était le deuxième, premier ou le deuxième plus. To be sure.
Ah, comme de Nord, peut-être. Nova, no, no, Nova. I know.
I didn't know exactly, how was the program.
They did bring my son to swim competition and I cannot miss.
Not Turkey excuse.
I will be embarrassed. Thank you.
It's about protection. It's just for protection because we have some patient coming with a very huge disaster, a biliary disaster with the artery, with water. It's a necrosis, and you have to do that in emergency. You can't choose your moment. And that and this is emergency hepatectomy for necrosis or says, you know, you can't train, it's impossible, the patient is septic, so you have to do the hepatectomy immediately. This is 20% of the cases, but you have most of the time it's a patient you can't come to your consultation because he has 300 varieties or he has pain, etc. This is elective. So this is different. Okay, so in my opinion, it depends. Sometimes, you know, depends on the type of the injury and when you see the patient and if the cholecystitis or there is, for example, or a collaborationism. It depends if it's easy and it's the condition are well, you have to prepare immediately. But if you have this patient 1 week after with a really high hepatitis, don't, never. You have to wait. So usually, the more you wait, better it is.
Ok, grazie. Coffee is needed to stay awake.
C'est oui, c'est bien formé, bien
The next speaker is Dr.
Okay, so today I talk about preoperative thrombosis following right-sided hepatectomy for periharap. Although after
by
Our implementation for periharap conjugation is difficult to achieve, and the possibility rates are high. Especially for the vein thrombosis, following right-sided hepatectomy for periharap cholangiocarcinoma is a potentially lethal component. However, to date, preoperative prediction for the vein thrombosis or right-sided hepatectomy for periharap cholangiocarcinoma. Three reports regarding the portal vein thrombosis following major hepatectomy for periharap cholangiocarcinoma have been published. First reports from Japan, just on the operative portal vein diameter ratio and angle, and reported the post-operative portal vein diameter ratio of less than post-operative portal vein angle less than 90 degrees. There was a risk factor for vein thrombosis. Similarly, second report from Japan reported that operative portal vein angle and the diameter was risk factors of portal vein thrombosis. Although Paul Buss reported on this issue, they failed to identify any modifiable risk factor. This study thus aimed to analyze the predictive factor of portal vein thrombosis following right-sided hepatectomy for periharap. In this study, consecutive patients with periharap cholangiocarcinoma who underwent right-sided hepatectomy between March 2010 and October 2023 were as a patients who developed portal vein thrombosis and who did not develop portal vein thrombosis were compared. Additionally, factors predicting portal vein thrombosis following right-sided hepatectomy for periharap cholangiocarcinoma were identified using univariate and multivariate analysis. At our institute, portal vein rejection was indicated solely in cases in which the portal vein adhered to and could not detach from the tumor during the process of skeletonizing the hepatoduodenal ligament. And measurement of portal vein angle and diameter in preoperative CT were performed using Synapse Vincent as previously reported. 88 patients eligible for this study, and 6 patients developed portal vein thrombosis, and the remaining 82 patients did not. When analyzing the predictor of portal vein thrombosis in this global cohort, no predictors were identified. Since none of the 24 patients who underwent portal vein resection developed portal vein thrombosis. Subgroup analysis of the patient undergo portal vein resection were performed. Univariate and multivariate analysis were performed in the non. As a result, a portal vein angle on preoperative CT below 5.2 degrees were identified as an independent predictor of portal vein thrombosis in the non-PVR. The area that have for a portal vein angle below 85.2 degrees was 0.82. This is a scheme of our surgical techniques of portal vein resection and reconstruction. The anterior wall of the main portal vein and the left portal vein were marked. And then front lines of the division for the main portal vein and left portal vein were set and marked at the position that will result in anaphylaxis after portal vein reconstruction. At this juncture, the left portal vein, it was typically marked with a diagonal division line, ensuring that the diameters of the left portal vein and the main portal vein match. Patients with a sharp angle between the main portal vein and the left portal vein on preoperative CT might be at risk for portal vein thrombosis if a portal vein resection was not performed. Additionally, portal vein resection and reconstruction, with its emphasis on straightening the portal vein anastomosis and matching with the diameter of the main and left portal veins, has the potential to mitigate the risk of portal vein thrombosis following right-sided hepatectomy for perihelic one. Thank you for your attention.
Hugo? Okay. Valerio is
So thank you very much. Very nice study. I think we come back to the no-touch technique of that was described by Neuhaus, not for oncological reasons, but mostly for technical reasons. So that indeed, when we do resections, right extended resections, we often have this thinking of the vena porta, and so this mitigates this problem of thrombosis. So I probably did you see also the oncologic side? Did you have better oncological results after your systematic resection of not systematic, your resection of vena porta for technical reasons? Did you see if oncologically there were also better results?
Yes. Oncologically, there's a benefit of portal vein resection.
And the patients who had portal vein thrombosis, how were they managed?
Actually, 6 patients developed portal vein thrombosis. 4 patients do reoperation, thrombectomy, and 2 patients do anticoagulation therapy. Yeah.
And so thrombectomy with reconstruction of the vena porta, straightening of the.
Yeah.
I presume.
Usually we do. Yeah. Resect the extra spot of portal vein. Yeah.
Thank you. Maxime?
Hugo wanted to. Do you have anything to add, Valerio?
Oh, it's okay. Thank you.
You finished?
Yes, thank you.
So one question I have, how many portal vein thrombosis you had because of having a long stuff? How many?
6. No?
6. Because there is a meta-analysis showing that portal vein resection and reconstruction has 10 times the risk of thrombosis compared to non-resection. This is a large meta-analysis that has been done. Do you think that the risk of thrombosis of this large loop outweighs the risk of portal vein resection?
Yeah, the point is technique, maybe. If we do straight anastomosis, maybe portal vein resection is not the risk for the portal vein thrombosis. But point is techniques.
Yes, thank you for this very nice presentation. I imagine that when you do the lymphadenectomy and mobilize all the Lisonian tissue around this portal vein, you destabilize it. Is that a reasonable hypothesis? So now it can easily kink, whereas before it could not.
When we have lymphadenectomy and resection, same as one.
Yeah, that destabilizes the vein. So we have had this problem with left lobe liver transplant. And so I never use the left portal vein of the recipient. I always cut the common portal vein and make a straight anastomosis for this reason.
Yes.
Everybody who operates the perianal carcinoma know about the existing at the end. And sometimes we just preemptively do the transection, and sometimes it's not much better after you've maybe I didn't do it well. So and I think your results are paradoxical because the common thing is that the portal vein resection increases the risk, as Ugo said before. So, but this is a very interesting study, and I think that marking, as you showed, is very interesting. My first question is, how do you decide the length you're going to remove?
Length?
No, because, sorry, this is when you have to remove for cancer reasons. But when you reoperate for portal vein thrombosis, then you shorten the portal vein and you do the anastomosis. So how much do you resect?
How much?
What length do you resect?
I will show the video for this.
Good preparation.
In this case, portal vein angle was less than 85.2.
Sense.
So we cut portal vein more than more invasive. Well, we detect more than the more invasion. The diameter was matched, and the anastomosis is right.
The video, I have another question. What's the policy for anticoagulation?
Only for the patient who underwent portal vein resection, we do systematic heparinization.
But
only for the to receive portal vein resection.
Yeah, but intraoperatively or postoperatively?
Yeah.
At curative dose?
Huh?
Curative dose?
Those?
Those and heparin or
Heparin.
or low molecular weight heparin.
No, normal heparin.
Yes, Pietro.
Yeah. Yeah, so I have a different way to do that, and I think, at least for me, it helps better. I put 260 stitches with the same obliquity on the 2 stitches so that you can see also the corners and not just the orientation, if you see what I mean. It helps for the osmosis. And the second thing is to straighten the portal vein, you must cut Arancius ligament, because it is what tethers the portal vein in that awkward position up. To cut the ligament, then it straightens down. I will show you a picture later on how it looks at the end.
But you have to cut anyway if you remove segment 1, Pietro.
Yes, but you do the anastomosis before.
Okay.
When you do the anastomosis before, to simplify the operation, it straightens the portal vein. I will show you a picture.
As you said, we don't describe the technique. You said that. Describe it. What? Sure, yes. Peter knows. Describe the technique. In the second paper, it was around 2000. He published the result of two series. One without portal vein bifurcation removal, and the second one with. And he showed that the results are better if you resect the portal vein, even if there is no invasion. And we spoke together, and he said that but when the tumor is in front of the portal vein bifurcation, even if you may dissect and pass through the tumor and the portal vein, it is better to resect the portal vein. And it showed that in the series, the results are much better when the portal vein was dissected. And if you remove the portal vein bifurcation, of course, you have to do this kind of suture without angle. You agree with that?
Yeah, totally.
Just a question, there's a technical tip. When you do a portal vein resection for or oncologic reason, because there's an invasion of the portal vein bifurcation, and I think that's what I saw here. You should do the resection and reconstruction at the end of hepatectomy, not before hepatectomy. And I think Neuhaus was doing it at the beginning, which was not the best way, because at the end you have all the space, the length to do the reconstruction.
Yes.
So I think there's just a tip that we should do it as the last. This is the last time of that's the sequence of the operation.
So one more question, sorry. So we have around 100 cases of portal vein resection like this, and we usually do not coagulate because it's a high pressure anastomosis, contrary to the IVC. Do you think it's really necessary to anticoagulate those patients?
From the result of this study, we need not to do anticoagulation therapy for the patient who underwent portal vein infection. At first, we are afraid the portal vein thrombosis following resection.
But as long as the hemodynamics works, the drainage is good drainage, you won't need it, I think.
Thank you very much.
Juan Pecol from Argentina, laparoscopic resection of metastases.
Okay, good afternoon. Thank you for allowing me to change my presentation. And also thank you for allowing me to be part of this great family that we spent good time and we learn a lot. I'm working in a reference center of HPB surgery, and we receive some patients with eidatic liver disease, but we have a problem. We are not in an endemic area, so we have a few cysts. We receive the cysts. Many of them are complex or complicated, and also are technically demanding. And some have previous treatment with percutaneous procedure and also with pharmacological treatment. But we insist that the mini-invasive approach is the wonderful indication. I try to show in 3 cases why we are insisting to do this by laparoscopy. We have to remember about the eidatic cysts. They have 3 layers. The first layer is germinative and fibrosis that depend of the parasite. And there is another, the fibrous capsule, that depend of the patient. We have to remove 100% the part of the parasite, and we're going to discuss how much we are leaving of the adventitia of the own patient. There is a consensus about how we have to define many things in Echinococcus disease, but for me the most important is about the surgery, and there are acronyms at work. A is about the approach, we're going to laparoscopy. Opening, if we are opening or not the cyst, this depends on the size and the complication. I'll show some cases that we open and some cases that I'm not opening. The resection are mainly 3 techniques: is to remove cyst, to remove with a part of the liver, or to do liver transplantation. And when you are resecting cyst, it is total resection, subtotal, and partial. And this is the way I try to show you. Because the discussion was during more time in my country, in endemic area, which is the best treatment for eidatic liver cyst. And I think that there are not only one treatment. We know that the cysts have these parts, the parasite. The discussion today is to use a lot of albendazole before surgery. We know that it's eidatic at least 2 weeks before. With this, we are trying to kill the parasite, and then during surgery, we aspirate and remove the membranes. But the discussion is about the residual cavity, because the problem after the surgery is just the disease of the residual cavity. And then they describe the conservative techniques and radical techniques. The conservative technique is to remove part of the cyst. And the radical is when you are removing more than 80% or completely the cyst. This is subtotal and total, and also liver resection and liver transplantation. What is the disease of the residual cavity? If the patient still have symptoms, abdominal pain, fever, have some leakage, some collection, they have to be drained, recurrence of the symptoms. And this is related with 3 important things. First one, if the wall of the cyst is calcified and you are leaving, this cavity is never to be closed. First one. Second one, if the patient have some bile leakage, this is a big problem, and the patient have infection. And obviously, bigger you are leaving the cavity, more probability for have this disease. So the objective in our surgery is to resect as much as possible the cyst wall, identify and close the biliary tree communication. Remember that between 60 and 90% of the eidatic cysts have communication with the biliary tree, completely opposite to the simple cysts. Avoid extended calcification in residual wall, and this is the case that we have to do probably a liver resection. They are not leaving calcifiers. And one important thing is to put the great momentum inside of the cavity. This is our experience. You know, we use more conservative surgery, just open or laparoscopic. I go to show the part of laparoscopic approach. This is a patient that is citizen from PI city, never was in an endemic area, arrived with abdominal pain. We think there was a simple cyst, but when we put this one, we saw the membranes. So it's strange and difficult to understand why these people have eidatic cyst. The first indication is to change the trocars, big trocars, for have a good aspiration. We have to avoid the leakage of the fluid. And here we're going to do just a partial resection, removing all this membrane. You know, this was very close to diaphragm, probably to migrate to the lung. This is one of the complications. What we did here, we only remove all the membranes, we put in a bag, and we put the patient 1 month after surgery on albendazole. Because no idea before they have echinococcus disease. This is the second case. He received albendazole during 3 months in the endemic area and sent us. There was a completely retracted the cyst, but patient had fever. You can see here the additions related to the treatment with the albendazole. And it was this moment, the best way to do is to resect this part of the liver because it's segment 3, peripheral. And with very elemental instruments like electrocautery, suction irrigation device, and some clips, we perform an atypical resection of segment 3 that is enough for this patient. This is, in this case, is a closed technique because we're not opening the cyst. We are not using any kind of fluid to kill the parasite because the patient received previously albendazole, and we're using just electrocautery. It's an elemental robotic instrument, just electrocautery and suction, and it's enough for this kind of resection. So it's very cheap, and in endemic area is good to use because are poor areas. The only important thing is to identify the pedicle of segment 3. We put 4 clips, we cut and remove. This case was resolved in this way. Okay. And this is the last case. This patient arrived with acute abdominal pain, and you can see a huge cyst in the right side. The patient, people said probably need a right liver resection because just is almost done the right liver resection, but the cyst is very close to IVC. I think that this is the dangerous with the big cyst, and you must be very careful. So we put on albendazole 2 weeks, and then we go to surgery. The important things to do here is to prepare a very good devices to suction and irrigation to remove because the patient have a lot of membranes and daughter cyst inside. We isolate using 4x4s. We open, we use 2 aspiration devices, the big one for the membranes and the other for the fluid. You can see more than 2 liters of fluid inside. And using ultracision that is good, we are resecting from 1 centimeter next to the parenchyma, and then we continue aspirating inside. When we are seeing that it's yellow, you have to look for the communication with the biliary tree. We are removing as much as possible the cyst. We have seen that it's yellow. This is the IVC. And we decide to do intraoperative cholangiogram to show where is the leakage of the bile. So we dissect the part of the gallbladder. We look for the cystic duct. And the good thing for intraoperative cholangiogram that you are doing pressure, you are doing an hydraulic test to see where is the leakage. And if we found the leakage, we have to put 1 or 2 stitches and the problem is resolved. You can see here how perfectly is leaking the dye inside of the cavity. There are no membranes inside of the biliary tree. This is important. The evacuation to the duodenum is okay. So we have to try to find, and we put the scope, changing the direction of 45 degrees scope. We found there the hole. We put a stitch with the Prolene 40. A good stitch. Must work very well for not to have by leakage. And then we perform again the cholangiogram, and you can see there are no more leakage. So the last part of this procedure is just to put something inside of this big cavity to avoid that there a lot of fluid. We complete the cholecystectomy, and then we are going to look for the great momentum. We put inside the great momentum that we fix with some. We are trying to control the bleeding and to destroy part of the fibrosa using argon beam coagulator. In this case, we have to open the trocars that we have no hypertension. we remove this, the 4x4s, the membranes. And the last part is to do a flap with the momentum and we put inside to fill all the cavity. This is another case similar. So for just finishing, which is the advantages of min-invasive approach, laparoscopic in this case, there are no or reduced wound complications. In open surgery, we have to do an important incision for this patient, less postoperative pain, shorter hospital stay, quick social and professional reinsertion. This is good because these are people that are working at the farms in the south, they need to work, and also it's cost effective. This was initial algorithm to treat the cysts. If the patient we found asymptomatic and small, they is put on albendazole and no more for to do. If the patient was symptomatic, depending where is the cyst, what are we going to do? For the peripheral and small, we use laparoscopic. For the other, use open surgery. For complicated, we prefer to use open surgery. Today, we think that this situation, we have to start with laparoscopy, and if we have problem, when we convert. So in summary, laparoscopic approach is more frequent in this treatment. Its conservative procedures are done more frequently with good results, and lower morbidity and mortality and recurrence rates are characteristics of this approach. This is Argentina. This is the South, Patagonia, the place where have this disease. But the more important thing is this picture. Remember that 2027, we met all together in Buenos Aires. Thank you very
Juan Juan will discuss presentation.
Yes, I was surprised by your presentation because it's a presentation technique. But I was attentive by the indication for your indication because I read some papers, some teams nowadays have any restriction in our indication. And the second of all is sterilization. You know, in open surgery, we learned by Professor Bismuth, we protect the bench, we protect, we secure the field. Second, we have a trocar, and we evacuate the contents. And after, we have the sterilization with swab, soak with scolicidal agent. In your technique, you only you have a puncture, you have evacuation of the contents, and your sterilization. How do you do? And my question is, how far can we go while remaining safe in the future with your technique of approach, laparoscopic approach?
Okay. Yeah, about we were, when we develop skills and training, we are expanding the indication. Again, we are not trying to do complete resection of the cyst if it's not necessary. So for the reason we expand the indication in complicated cyst and posterior cyst, if we have a place that we can go inside, guided by the ultrasound, we prefer to do laparoscopic approach. But we have cases that we have to do open. The last that I did was a cyst in the left side that was opened in the portal vein, and they have membranes inside the portal vein with portal hypertension. This is not for laparoscopy, this is just for open approach. About the sterilization, we use albendazole that today is shown that with 2 weeks, 1 milligram per kilo per day for the patient is good to kill most of the parasites, and this decrease completely the recurrence of the idatic disease. And this have seen in series from Lebanon, for example, area, that the results of conservative treatment is very good in morbidity and mortality, and also in the rates of recurrence of idatic disease. So for this reason, we are moving because it's completely different what we are doing now, what we were doing 20 years ago. 20 years ago, we used hypertonic solution to put inside in the patient, And we have two patients that have increase of natremia with coma. So for the reason we stop to do any kind of sterilization during the surgery. So for this reason, we are just have good devices for suction irrigation. I use the sometime two suction irrigation, one for the fluid and the other for the membranes. And you have seen they have more 2 liters, and we use 4x4 sponge to protect a little the area. But all these patients have a previous treatment, and some of them, like this one, we prefer to put 1 month more on treatment after surgery.
Well, I agree with you when you said remove the wall of the cyst, the maximum. But sometimes you must be cautious when it is near the main biliary tree. In my experience, the worst situation is when the cysts come on the top of the biliary confluence. It is really forbidden to go in this space. The worst repair I have to do of biliary injury is when the injury is due to the removal of biliary cysts. The reason is that the biliary injury is above the confluence. And I have case where the confluence was 30 milliseconds. I mean, you have a small bile duct. This situation is terrible. So we must, of course, train the people to say, don't go at the level of biliary confluence. It's better to let the wall of the cyst at this level.
I agree completely. In this case, the problem was the IVC, and you have seen that from the inside of the cyst, I'm seeing the protrusion of the IVC. All these cysts, you are going to have problem. There was a technique that was used very often in my country, they call pericystectomy. So it means to go in the plane between the cyst and the tissue of the liver. And this finally was really very, because they have very tiny bile ducts, and you have a great rate of bile leaks. For this reason, I prefer to do a formal liver resection with 1 centimeter of liver around, and it's easier.
Non-experienced surgeon in this kind of surgery forgot that the cyst is not the parasite. The cyst is the reaction of the liver. I mean, it is the liver itself. That means the bile duct, the vessel are inside the cyst. The parasite is the membrane.
Was just aspirated.
And they think that the cyst is a part of the parasite, and this is the mistake.
And it's parenchyma with compressed bile duct that wake up later.
Yeah.
And my question is on your algorithm, asymptomatic conservative treatment. This is, for me, break of the dogma of that every hepatic hydatid cyst should be removed unless dangerous to do so. Can you develop on that?
Yeah, this is a guide of our National Health Institute that I work, especially if it's really asymptomatic. So when there are asymptomatic, it's mainly because are small and in the middle of the liver. But if you have some symptoms, you must be careful. For example, this that you operate in the left side, cyst in the left side, the worst complication is that open directly in the heart. No? And this is tremendous. So you have probably some asymptomatic in this area. You are going to do albendazole and probably going to resolve.
How long for?
If you want to treatment, 1 or 2 months, and you are checking the images, because in the images, you are going to see how it's changing the image of the cyst. When you are killing the cyst that looks like the first one, very clear, appear the membranes and try to be shrunk like I show you. If you have good result in the images, it's okay. I have to operate this one because I have fever and was infected.
Yeah, thank you.
Lawrence?
Thank you very much, because we have a lot less patient like that in our countries. But we have. So I was really impressed by your big one, and I wonder, albendazole is enough to treat even if it's huge? How do you know that it's because, well, it seems to be active for me in that. So what is exactly your contraindication? Is it size first? And the second is if you have a communication with bile duct and you see some, this is complicated, that exists, is it a limit for laparoscopy or not?
Okay, thank you. Yeah, you know, big disease, big problems. For the reason when I discussing with the infectious people, they say, okay, you say 2 weeks. I have problem in the schedule, leave the patient 1 month with albendazole. But also I'm very careful that I have no spillage during the surgery. Nobody can confirm me 100% that there are no scoliosis there. And if it's big, big problem. For the reason I was very careful. And also this patient, the pathology saw there were some scoliosis, so I put the patient on albendazole after surgery. About the bile communication, Pietro said that sometimes you have no bile there, but it's very compressed, and you uncompress and appear the bile. And here is discussion. Is good the ICG, is better intraoperative cholangiogram? I prefer intraoperative cholangiogram because I'm doing pressure. So I have another test, but we have ICG, we can start with the ICG, and I have seen some drops, I know that is there. And I show you, it's big disease, but with the cameras that we use of 45 degrees, you can change the position, and you can put probably an extra trocar to open the cyst, to see where it's leaking, and finally it's just to put one stick. Probably robot is going to do easier, but in endemic area, a robot is so expensive.
This is bile leakage because of the
Yeah.
the close bile duct.
Yeah.
But I'm talking about the real communication with cyst into the bile duct. Is it a contraindication?
If you have, because in this case, we can have membranes inside.
Exactly.
For the reason, for me, the cholangiogram is important not only to test there are some leakage, but that the bile duct is completely clear, that I have no hypertension due to the membranes, because I have the membranes, I have to open the duct and to remove and probably to put a stent through the ampulla to decompress. All this is possible to do by laparoscopy.
Okay.
Yeah.
One more question. So we usually do a period of albendazole before resection or treatment, surgical. What you are saying is that you wait for some kind of neoadjuvant therapy response. You actually see the response of the treatment before doing surgery. Is that it?
Yes. The case that I show you of liver resection, I have no previous CT scans, but was cyst probably 20 centimeters, but was an endemic area. And they take too much time to send the patient from the endemic area to my hospital. It's the reality of the public. So the patient was more than 2 months under albendazole, and this helped a lot because it was finally a small cyst, and I resect by liver resection. So the criteria to decide in asymptomatic cyst is to see how we are changing the EP.
On the last questions I wanted to do. We know that the albendazole is really very effective in type 1 or type 2 cyst, with which the wall is really thin. What do you think about thicker wall? Do you put on albendazole more time? This is one of these the questions about the albendazole, and the other is a remark that when the patient had albendazole preoperatively, the cyst is tender, is not so under pressure, and it facilitates also the. What do you think about that?
Yeah, I agree completely. And albendazole is a useful drug, and we use it routinely. And sometimes we need to have more time for the discussion with the infectologist. It's very important because it's case by case. Yeah.
Thank you.
Thank you. Thank you so much.
Tranquilo.
Thank you. Thank you very much for the opportunity. We have a lot of discussion yesterday. I'd like to show as many video as possible today to show how ex vivo surgery works. So the background is really the tumor involved major vasculature organ are considered unresectable in conventional surgery. Removal of the tumor would cause necrosis of organ. And ex vivo surgery is uses technology of organ transplant, enables surgeons to remove those tumor effectively while protecting the organ from cancer. So that's the main part of the ex vivo. It also allows surgeons to perform precise tumor resection and complex vascular reconstruction in a bloodless back table setting with optimal exposure and lighting. So I think that's another added benefit. It's not really showing what I was supposed to show. Do something different. Wow. Okay, maybe I can. Okay. So we published the paper in Annals of Surgery 20 about many different types of surgery, but not just the ex vivo hepatectomy. And this is that direction. So we can go for that. Okay, that's okay. So, there's a picture of the organ. It's up to the liver only. That's, require ex vivo surgery. But this was again, demonstrated by Danielle Sharkey yesterday. It doesn't have to be ex vivo. It can also be in situ cool perfusion. But I will show you some of the cases may be more suitable for ex vivo than in situ cooling. But if the tumor is below the liver at the hepatorenal ligament involving pancreas head, if you just remove the tumor, liver would necrose. So that type of tumor removal, if the tumor is really large, you can't really do tumor removal and vascular reconstruction very quickly. So then it's actually very big benefit to take the organ out. This is more protecting the liver from ischemic damage. The third type of ex vivo, this is supposed to be a mesenteric root tumor with a pancreas head involvement. So if the tumor is removed, intestine will die. So, again, this is an alternative, like Felipe is doing, mesenteric portal bypass to avoid a congestion, do vascular reconstruction. That's also a possible alternative. If the tumor is really large, though, that's really difficult to do. So I would rather take organ and intestine outside of the body so you don't have to worry about ischemia or congestion of the bowel and put the bowel back in after the tumor. The fourth case is really the most complex case. If the tumor occupies both celiac and SMA, and an aortic tumor or the retroperitoneal tumor, in that scenario, in order to remove the tumor, only way to remove is to take entire abdominal viscera out. So the liver, small bowel, large bowel, pancreas, head, everything goes out. And then we put back the liver and intestine. That's the multivisceral ex vivo idea. So I'm going to show you some of the example. The first, the ex vivo hepatectomy, first of all, was described by Pickelmeyer in 1988. And then second pattern of the ex vivo Whipple procedure and liver auto transplant was developed by our team as the first described in 2015. And the third type of ex vivo surgery, mesenteric root tumor, intestine goes out and come back, was described by Andreas Sazakis in 2000. And the multivisceral ex vivo procedure was also described by us in 2012 to remove that mesenteric gosh. So all the but imagine this is a No, it would work. Oh my. No.
Can you plug it? Try to get the laptop with the HPMI. Laptop.
É, não sei, eu gostaria de se a gente for, então, assim, se a gente perder essas. Se a gente perder os. Então, acho que existe muita gente. Mas ótimo, tem. Ativa, mais da nossa atenção.
Video giapponesi.
Okay, thank you. So, supposed to appear this way, okay? I'm not gonna repeat it, but that's what it means. Do you understand that? I hope you understand. Okay, okay, good. So ex vivo hepatectomy. So ex vivo hepatectomy, again, this is the intrahepatic cholangio involving all hepatic veins and also IVC extensively. So this is probably the case that could have done without taking out the. I think it can be done inside to cooling. It's pretty much the cases that Danielle will do it in inside to. But this case, we did an ex vivo. It is nice back table resection, and then reimplanted the liver left lateral segment. Patient more than 10 years with no disease recurrence in cholangio case. This is another case of example. This is a right-sided tumor, and then you can see the left hepatic vein is truncated in the middle, looks like. We know that to do more effective hepatectomy, you could do this. Again, this can be probably done inside to cooling as well, but to do this patch reconstruction, V2, V3 in this way, and then putting it back, it's nicer doing this way in ex vivo. In a surgical technique in ex vivo, actually, I'm gonna skip this slide. One of the things we can do in ex vivo is once the liver is out, you can put the temporary portal cable shunt and reconstruct it like that. So you don't need a veno-venous bypass while we are doing back table procedure. That makes the patient really stable and easy to do a back table. And in some cases, it's not possible. And I show you a little bit more challenging case. This is the fibromegaly case, and then right hepatic vein and vena cava pretty much intrahepatic, and it's more challenging to do, probably in situ case. It could probably be done, but if you see the vein was cut more in a peripherally, and in this particular case, we could have done like Danielle did yesterday, but I put this patch of the jugular vein to create a neo-right hepatic vein and making that insertion easier. This is the case with a more highly invaded case of the biliary cystic adenocarcinoma. This is probably Danielle would also consider exciting. And then this is another case with locally advanced HCC, which again, it's infiltrating the 3 hepatic veins and vena cava, but also on the hepatic hilum. So this case would be probably more challenging to do without ex situ. So I'm going to show this. So the hepatic artery and portal vein are encircled more proximally, but this particular case, portal vein is infiltrated at the bifurcation. So in order to do portal cable shunt, you need the dacron graft to connect because portal vein would not reach the vena cava. So let's do the dacron graft, inserted portal cable shunt first, then you just cut the artery, the vena cava below an valve, and then take organ outside of the body. So that's when the ex vivo starts. In this particular case, there's already a portal cable shunt created, and then we're just going to quickly reconstruct IVC. And while the other surgeon is flushing the organ at the back table, so we can do a team operating simultaneously. I just show you a little bit of intraoperative ultrasound. In the back table setting, you can use ultrasound to guide your surgery too. And this is hepatic vein invaded case. So you have to really, do a precise resection. And then Danielle says, in the intrahepatic cholangio case, R1 is not that much of a problem. But HCC case or whatever, in general, if you prefer to perform R0 rate, I think it would be higher by this approach. And this one was challenged by the right portal vein invasion. So you have to cut the right posterior portal vein off the anterior portal vein. So this is how in the right posterior graft. So again, like I said yesterday, this is much more like creating the right posterior living donor graft, from the organ block, as compared to removing the left tri-segment of the liver. So you can do a more peripheral resection so that you can have better margin, in my mind. So like hepatic vein, this particular case, we need a patch reconstruction. Otherwise, it wouldn't be really reach easily because it's almost like a right hepatic vein in the middle of the parenchyma is connected on that. In auto transplant potent person, we create this large venotomy on the cortex and the site in a way that we're showing is pretty much exactly the same as Danielle showed us yesterday, except that I have this bovine pericardial patch to extend the vein. Then portal vein reconstruction is pretty much standard, easy way, artery reconstruction. Then we reproduce the first, and then artery reconstruction. So, in this particular case, I think, have a benefit of ex vivo, but it gets to be arguable, maybe in the next case. So this is probably, I wouldn't, you wouldn't do it without ex vivo. So then IVC sarcoma, very much expansile. And not only that infiltrated in IVC, it's in the atrium. You can see the tumor top in the atrium. and then go all the way down, involving the renal veins as well. So this particular case presented with acute bad Chiari. Patient came in pretty much crashing. We had a lot of discussion whether or not the case should be done, but we just decided to take the patient to the operating room. When we opened, everything was so congested and looks very scary. We did a shunt, IMV shunt, decompress the patient, and the patient became much more reasonable, stable. And then we did this ex vivo surgery. I'm gonna have a little bit short video. It's only a minute and a half video to show this case. So organ removal in this particular one, we really need that IMV bypass. So we did an IMV bypass, and then and also the cardiopulmonary bypass with the classic poly to remove the puba from the right atrium. The tumor is really extensive inside the right atrium. So in order to remove the tumor, the cardiothoracic surgeon ended up reconstructing the not just the right atrium, also the atrial septum. So the heart reconstruction was very complicated. They have to put the bovine pericardium to reconstruct atrial septum, and then atrium, right atrium is now closed. And then after the right atrium is closed, the cardiac surgeon putting the Gore-Tex into the right atrium, and then comes to our side of the surgery. So we did this is right renal vein reconstruction, reconstruction. And at the back table, you just remove this gigantic tumor on IVC with the caudate lobe. Then all the veins were clotted. Those are not the tumor thrombus. These are leiomyosarcoma. So those are, the chronic, not chronic, the organized thrombus. So we're able to clean out completely. Then you have to put this, again, the patch extension. So in auto transplant, again, makes this huge venotomy and Gore-Tex, and then anastomosis patch. The rest of them, portal vein reconstruction and arterial reconstruction, and then bile duct. But this bile duct is just done by duct-to-duct anastomosis because bile duct was not a part of the problem. So patient had a real rough time before the surgery, but post-operatively, she actually did really well. She had a small recurrence, and about a year after, we removed it again, and she's currently tumor-free. So this was about the ex vivo hepatectomy. So there might be some part, can be done by in situ cooling, but I think we still have some benefit of ex vivo. When it comes to this type of surgery, I think ex vivo has so much advantage over, actually probably wouldn't be done in situ. This is a large right under the liver. All the duodenum in the pancreas head is infiltrated. Hepatoduodenal ligament is completely encased. Patient developed with the abdominal pain and jaundice. So he had a PTC catheter across. So in order to remove, we really have to remove everything outside. So in the end, what we removed is like this. So this is a tumor right here in the middle. And this is the liver. Actually, liver is up like this. So what we did at the back table was to shave this liver off the tumor and then put it back. So that was a really a tremendous surgery. I will show you one more example of this tumor. So this is a real huge retroperitoneal leiomyosarcoma. Just look at this, and you probably wouldn't think this was a resectable case. But if you have this liver, pancreas, head ex vivo, you would remove this tumor. Why? So there's a plane here. Pancreas and stomach are completely pushed to the side. The pancreas tail is still here. If you get in the plane, you cut the pancreas tail above the SMA and follow the plane all the way down to the retroperitoneum. Everything is in your hand. And you have to cut the part of the diaphragm, right side of the diaphragm, together with the tumor, then everything will come up. I don't know if you understand that, but if you do that, you can still remove it. you have to do this sphenoid shunt because there's not going to be portal vein, to connect the splenic vein. Then, you take so after the reconstruction, this is an interesting case because we were able to save right posterior lobe and left lateral lobe. So the implantation was almost like a butterfly. We are able to put the butterfly liver and then both, left hepatic vein and right hepatic vein, put it back in. So that was a really interesting case. Patient had a recurrence again, but had about 3.6 years life after the surgery. The third case. So the third case is nothing to do with liver. It's much more like a pancreas surgery. Again, the Felipe would do a lot of those without ex vivo. I really, respect the complicated approach he does, or maybe it's not that complicated for him. But the case like this, I would say probably Felipe would do it in situ. But this is the tumor that infiltrated down to the secondary branch of the SMA. So, the first jejunal branch is gone. So this is like a second branch, the large branch goes off the SMA. That's in. So in order to remove this case, we chose to do ex vivo. Pancreas is again cut at the tail around above the SMA or even distal to the SMA. And distal sphenorenal shunt, everything goes out, go back in. Another case, this is I'm sorry, this is the same. This is another case with a solid pseudopapillary tumor case. Again, it's a huge tumor. So this was not really vascular thrombosed case, but this level of large tumor to remove in situ technique would be really hard. So I think, in this particular case, taking out the pancreas head and a small bowel and large bowel together would makes surgery so much easier and safer. And she did wonderful, very, very well with no recurrence today. I'm going to show you one case of ex vivo intestine. So this is a large duodenal neuroendocrine tumor. And you see here, so if you go down here, so there's a huge tumor thrombus in the SMV to the splenic junction. And then going down, you're going to see this large tumor on that. So again, because of the size of the tumor, this would be very, very difficult to do in situ removal with vascular reconstruction. So I'm going to show you the quick video of this. So this is a very different surgery. You're gonna, there was some fibrosis in the liver in this case. So this is like a Whipple procedure. The pancreas is divided above the SMA more distal. And then IMV, we created IMV to the cava shunt and also splenic vein to the renal shunt. So distal splenic shunt, IMV, cava shunt, and then everything else. And then we did the gastrostomy prior to the removal of ex vivo to make that surgery easier after. And then now that we cut the SMA and SMV, all the organ block will go out. And then from here, in the back table, so we encircle the SMV and SMA distal to the tumor, and essentially everything else in between, you're just gonna cut at the back table. This is a very simple surgery, very easy and quick. You can do that. And auto transplant is actually not as bad as you think. Okay, this is a intestinal transplant type surgery, but essentially what you're connecting is SMA back to SMA, SMV to SMV. So that's a very simple surgery. And once you reperfuse, you're gonna do all the GI reconstruction as you do in a Whipple procedure. So the pancreatical gastrostomy is already done. So you just need a cholecystectomy, gastrojejunectomy, and ileocolostomy. Patients doing really wonderful after this surgery too. The last one, this is a real challenging situation. Like this case was an aortic tumor. The tumor on the aorta, involving the celiac root and SMA root. So there's almost no way to remove the tumor except you take all the organs. So this particular case, like you show in the diagram, we took entire organ out. But this one didn't really have much of an organ injury. Even the pancreas wasn't involved. This is an aortic tumor, so the pancreas wasn't even involved. So what we did is to replace the aorta with cortex and replace celiac and SMA in this Y-graft cortex, and then put everything else back in. So this is how it looked. It almost looked like a donor surgery. And you see that IVC is replaced, and then aorta is replaced, and the renal artery is connected because the renal artery will have to be divided. And then after, in the back table, the tumor is relatively small in this case, but if you flip every single organ, the removal is so easy, right? You are removing everything from the back of the body, which you never have this exposure in situ. And then this is how it looks when the organs are put back in. So there's a CT scan showing that how. And one more case of the multivisceral ex vivo. So this was a case was inflammatory myofibroblastic tumor in the pancreas. This is the pancreatic tumor. SMV is thrombosed, splenic vein is thrombosed, everything is thrombosed. So she had lots of ascites and portal hypertension. As you see, she has celiac arteries here, SMA is in here. So again, in this case, we have to take everything out. But in this particular case, we still didn't have a guts to, keep that tail of the pancreas in this case. We just did a total pancreatectomy, total gastrectomy. Only we put back the liver and intestine in and reconnected everything in this particular case. But she did wonderful. She had 15 years of life after this. She had some diabetes-related complication. So I'm trying to develop the technology to leave the pancreas tail by reconstructing the splenic artery. Whenever I would have to do the case again. Actually, I did one case like that. It didn't that go well, but I think that's what I'm thinking. This type of surgery. So over the 17 years in Colombia, we did total of 63 cases of these extensive surgery, including 26 ex vivo hepatectomy and ex vivo Whipple liver auto transplant in 10, and ex vivo resection intestinal auto transplant with or without Whipple precision 18, and a multivisceral ex vivo 8, and ex vivo resection and bilateral kidney auto transplant. In this case, we just did another case, so now we have 2 cases of that type. Open heart was added in 5 cases. Median operative time is 15 hours. 9 hours, 38 hours. But that was on the record. The carcinoma in 30, cholangio 10, pancreas adeno, colorectal mets, fibromegaly. Sarcomas, a lot of sarcomas we did. Sarcomas I think is a relatively good target on this. And then benign to low-grade tumors too. Overall, including benign to low-grade tumor, is about 40% overall survival in the long term. Actually 5 years, 49%. The 10 years is 40%. If you divide carcinoma category and sarcoma divided off the low-grade to benign, low-grade to benign did really well. But carcinoma, sarcoma, as expected, we're not going to change the biology of the tumor, but they still have a relatively good long-term survival of 40%. Of course, this is a very selected case. We only did 67 cases in 17 years, 63 cases in 17 years, meaning that we only do 4 to 5 cases per year. So it's not like, we are doing everything, whatever comes to us. But if you're in a selective cases, it seems that you have a very good outcome. And this is a disease-free, recurrence-free survival. It goes down, but still not as bad. 30-day mortality was 44.8%. 90-day mortality was 11.1%. We didn't have much of a liver failure as a problem. Vascular thrombosis happening early in one case of hepatic artery thrombosis. We lost the patient to the hepatic artery thrombosis. We can do a liver transplant rescue on those cases. Partial thrombus that was discovered and rescued and revascularized. The patient didn't have any consequence of that. But no portal vein thrombosis case or hepatic artery complication in this series. And in mesentery vascular thrombosis, we do have a SMA stenosis in one case. That case was rescued by the stent, and in other case with SMA thrombosis happened later on that same patient, and the patient ended up losing the graft, and patient decided to withdraw support, withdraw. But she also have a 3-year survival. So in conclusion, ex vivo surgery and auto transplantation offer effective removal of otherwise unresectable tumor in our experience. While large malignant tumors with vascular involvement are usually advanced in stage with high rates of recurrence despite R0 resection, the long-term survival of adenocarcinoma and sarcoma are both 40% greater in our cohort, suggesting the value of this approach in very well-selected patients. And furthermore, for benign to low-grade malignancy, it appears to offer a cure that could not otherwise achieve. Despite extreme complexity of ex vivo procedure, this single-center series demonstrate that with appropriate experience, ex vivo tumor resection auto transplant can be performed with reasonably low perioperative mortality and satisfactory long-term survival in selected cases. Thank you very much.
Okay, so you've shown us that there is no such thing as an unresectable tumor. Everything is possible. I wanted to ask you for speaking about liver tumor ex vivo resections. Of course, for complex confluence reconstruction and for ELR involvement, I think it's a perfectly valid question. For tumors that only need reimplantation of the hepatic vein, do you think you can use in situ perfusion as an option? And do you use this or not?
Yeah.
This is
So I would definitely think in situ perfusion works. But we are still developing the series, you know, the team, sort of the team experience. So in my mind, you know, relatively simple ex vivo case with a relatively short surgery and then, you know, making it faster, I think could benefit the team. And also the team experience to do everything in the same way every time actually makes it, you know, better in terms of the overall, in my mind. So, you know, I'm a transplant surgeon. We do a pediatric living donor transplant all the time. So connecting that large artery is really not so much of a high risk to me. And then doing the case with different way, adding additional experience to the team right now, I'm not so much keen of doing that. I can see that though, that would work, you know. So I'm not really doing that. Somebody in our team wanted to do it. I think I'll be happy to go along with it. But there are probably some additional benefit, like, you know, you feel the way, we feel the same way, because, you know, it can be done by totally vascular field with a very well-skilled surgeon, you know, in the same field, looking at the organ, you know, in any way you like, any way you like. So the, you know, the surgery can be more precise, cannot be any more precise than that way. So that might be a benefit. You know?
the second question is, I saw that in some cases you had a liver remnant that was not so big. So what's your cutoff? And do you use some kind of perfusion machine when doing this type of operations that can have a long time of reconstruction?
Right. So we have not had a chance to use it because, you know, this HOPE is not approved in America. But I'm really interested in using HOPE. I'm actually trying to get the investigational use of HOPE into a program so that we can benefit from it. In terms of the size of the, you know, the remnant liver, we're not really taking much risk. So at least you have to have a good enough 30% remnant size secured, because a lot of the organs are not necessarily normal. They are, you know, somewhat damaged organ. So I think, you know, to have good enough remnant size is important.
Thank you. Last question. You've shown us that you have benign tumors as indications for this. And this doesn't surprise me because other series also include benign tumors. So what's your argument for including benign tumors in this type of operation.
Right. So we said low grade to benign, but not everything is so benign, you know? So like, for example, we actually put neuroblastoma as a benign because neuroblastoma, actually low grade to benign because this respond to the chemotherapy. So one of them are neuroblastoma, actually, for example. And then inflammatory myofibroblast tumor, or some of the tumors are not so benign, but some of them are actually benign, but benign with symptom. So I'm not gonna do this surgery for somebody without a symptom. Has to have some symptom. A lot of time it's a bowel obstruction or the portal vein of thrombosis, so the portal hypertension. Those are symptoms required. Also, the tumor sometimes erodes into the intestine, because intestinal tumor fistula, that also, intractable infection. Otherwise, you remove it.
Monsieur Bismuth, last question. Yeah, Tomoki, don't be modest. I ask you, do you know other surgeon that did you did in your type 4? I think Takis is doing the same, but it was transplantation. This is not transplantation. So there are in other part of the world, do you know other surgeon series that perform the same that your type?
Yeah, so the type 4, I don't think anybody else has done it so far. I really want to see, people. I'm really, hope I'm inspiring the young surgeon here who has the energy to do it. Instead of just spending everything in robotic surgery, sometimes you go out, open field, because this is like a big open field surgery. It may take a long time, but I think it'll be something that you can put your name on a history. So I really want somebody to join us for this.
Tom, if I'm correct, the longest surgery was 38 hours.
Yeah, I don't.
Is that possible?
I don't know if it's 38 hours, but I just don't remember that.
It's on your slides.
Yeah, one of the put that in slide. So
Because 38 hours surgery sounds
just sounds a little too much, right? But there are more than 24 hours surgery. That is true. Okay. Yeah. So it's not. The one thing that I remember was that we did a more than 24-hour surgery in one case. I have to edit the video. Just watching the video for 24 hours is crazy. I'm just.
Where'd you get all these patients? They come from all over the country?
Yeah, all over the country, all over the world, actually.
And only you in the United States do that, right?
Well, I really hope everybody else can start doing those. But if you have any patient that you don't want to do it, then send it to me. It's about 1 out of 10 cases that the self-referred patient end up becoming real candidate. It's not that many cases are real candidate. A lot of time they are very deconditioned already, and then also if this is a peripheral involvement of the tumor, that's a very different story. This has to be a locally advanced large as an indication. The multiple tumor or the peripherally involved tumors are actually not an indication. So in that sense, we still have a lot cases unresectable. It's not that, So that's the large tumor more centrally involved is a typical best indication for this type of tumor.
Thank you.
Thank you very much.
Ricardo Robles from Murcia, the role of 3D reconstruction in complex. Are you?
Good evening. Thanks for the opportunity to present our experience with 3D reconstruction. And I'm going to give this talk on behalf of my boss, Professor Robles. So as you know, operative plan is always really, really important to design well our surgeries and to be careful of the evaluation of the patient, the anatomy. The decision making is the key of surgery. And nowadays, with the new 3D modeling, we can perform a better planification of the surgery. For example, we use hepatobiliary surgery, see better the hepatic veins, portal veins, biliary ducts. We can plan our surgeries to see the liver segments, volumes, can plan the margin resection, and of course, it can help us for difficult cases, large tumors, multiple metastases, Glaskin tumor, extreme liver surgery, as we have seen previously for liver transplant. Also, we can see rare vascular and biliary anatomical variants. For example, for extreme liver surgery, we use this 3D reconstruction for perform surgeries where we can repair the vein, or for example, here, as we can see, when we repair a big lesion in hepatic cholangiocarcinoma, we can plan exactly where is going to be the cortex prosthesis, and we think it's helped us to select better the patient. Also, maybe it could be helpful for a Glaskin tumor. No, for hepatobiliary it's the maiden procedure, and we perform a national multicenter study where we saw that maybe this 3D reconstruction can help us to plan better our surgery. We also use for bioinjuries because we can see well where is the leak in the artery or the level of the biliary injury. Also, we use for liver transplant, for example, when we have to do a transplant, we can see exactly what is the problem in the artery to reconstruct where the splenic artery, or for example, to plan the surgery for a portal thrombosis. We can see exactly what is the extension of the thrombosis, as we can see here in these images. Or if we have any biliary complication, also we can plan exactly what we are going to do, mainly hepatobiliary. But we can also print our 3D virtual model. We perform this multi-center study to see exactly what is the difference between the 3D and the printed. And as we can see here in this slide, it's a low percentage margin of error, for example, for subapatic veins, portal vein, on a part artery, and also we take the distance of the resection margin, and the error was very low compared to the virtual 3D model. We asked to another surgeons, and all of them were very agree about this would be useful to improve our result. And also we use with our students, and they also think that they understand better the cases when they have a 3D model to explain it. Also, we have performed this part. This is a carcass. We print this from virtual models as we use it to drum it away, try to avoid damage the hepatic veins or the biliary tree, as we can see here. This is a project that we are developing. We put the carcass of the liver, and then exactly for this complex, for example, ablation. This is the content of the ultrasound. We also we are working now in the robots design this plan, and we implement the 3D into the robot. So it's possible during the surgery to see exactly our 3D preparative planning. It's also good for the surgeon, but also for the people who is outside the console, the residents, nurse team, and other surgeons. Here we have an example. This is our OR. We put the 3D in the console, and at the same time that we are doing the surgery, we can use this program. We can see exactly what is the variation of the portal vein, if you are going to do a right or left hepatic hepatectomy. Also, we can see our preoperative planning of the surgery, the relation of the tumor with the hepatic vein at the same time that we are performing the surgery. And we think that that kind of thing help us to prepare better our surgery and to try to be aware of any possible complications. So for example, we can see a previous resection. It's also helpful for the residents. Also, we have used it to periiliar cholangiocarcinoma. You know, we saw yesterday, it is a really complex surgery and you need all the help. And in this case, we used in the most important phases of the surgery, especially during the lymphadenectomy. For example, we have any variation of the right hepatic artery or the portal vein. We think that this is the previous phase of the augmented reality, that it's something that we want to do in the future, and we are working with our engineer to perform as soon as possible. We can see here better the plane of the vein, left, the trunk of the middle and the left. Also, we can plan exactly the small duct biliary tree, the biliary anastomosis. Case we use to rise our anastomosis, and we have seen previously in the 3D prepared model. But I think that is more important. We are academic surgeons, so we have to stimulate our students, and we use 3D model, augmented reality with them. We ask for them feedback, and they have that kind of devices in classes, because you can see here they puntuate, they score very well this practice because they understand better the anatomy. And we made a question to them. We say to them, what did you like of this printed model? And one of the students say that the explanation of the bismuth clarification using 3D printed models are better. They understand better. So we think we have to work to improve our teaching, and it will be helpful. Thank you very much for.
Any questions?
It's very difficult to use, and does your MRIs have to be done in a different way? You finish the software.
Yes, we always use CT scan and MRI if you want to know exactly what is the bile duct.
But the protocol, do you need a separate protocol for the MR and the CT? You go into the software.
No, we have the same protocol for the CT and MRI. Yes.
Thank you. Very.
Mark
Thank-
is here. Dr. Troisi? Yes.
Hi. One more question, and then we're going to move on.
Okay. Thank you for your presentation. I think we have to say clearly that it's very important that the rendering is not given to the radiologist first. So the surgeon has to look to the images because he can propose different surgical strategies for his patient. He can, for instance, increase parenchyma preserving surgery by doing simulation and rendering, or you can propose also R1 vascular resection. So one of the most important value of this, besides the didactic value, which is here, is to propose more than one resection strategy for your patient, eventually to confirm or to avoid indication for surgery. So this is very important. And finally, the true value will be not, I don't think, the 3D printing, not holograms, but fusion imaging, which will follow your section during surgery. You showed the robot, but the robot is a locked system, so you cannot put the imaging beside the detail probe. So the best would be to have a fusion and progression, real-time progression of the images. But one of the major problems, which is so far I know still unsolved, is the rendering of the elastic bodies during surgery. So there is not yet a mathematic formula to allow this. Thank you.
Thank you for your question. Yeah, we that the surgeon has to be always involved in this procedure, of course. We have to take the decision, but it will be helpful to prepare better the surgery. And we are working of the augmented reality. In the future, we think that we could see inside the liver, but this is so difficult, and our engineers are working on that. But this is, we have a new project to try to get it, but we need to go little by little, step by step, and maybe in 10 years we will see inside the liver. We will see.
Thank you.
Well, Rashad, do you have some presentation? Oh, Antonio will be presenting us initial experience with robotic HPV surgery, Porto Alegre, Brazil. Antonio.
I'm sorry to disappoint you with returning the normal life of minimal invasive surgery Cato conference. We will show you our initial experience with robotic surgery. This is our hospital in Porto Alegre, south of Brazil. And before robotic surgery, after 2018, we started a laparoscopic Whipple program, and we performed 36 cases with no conversion and a mortality in 90 days from 2 patients. The historic mortality in our group with open Whipple procedure is less than 2%. But with the 3 years ago, we received our robot a Da Vinci XZ, and we started the robotic surgery. This is show you how the anastomosis of pancreato-jejunal anastomosis was made in laparoscopic way. And we never been satisfied with this kind of anastomosis, even in other films of other groups. So we feel much more comfortable with the anastomosis with robotic way. This here we can see one of our cases where we can perform this anastomosis is much more clear. We have movements more precise. So we think this is much more important to have a safe procedure. With the initial experience, we have less than 3 years of robotic surgery. We are very sure that we need to maintain only robotic surgery or open Whipple procedures. With a robotic Whipple, we performed 18 cases, no conversion rate. We have only 1 patient mortality, which was pulmonary embolism, 3 patients with pancreatic fistula, and only 1 case which needs a blood transfusion. The other 12 cases were the distal pancreatectomy with no conversion rate, with no mortality. So we feel very safe with the procedure in
with the robotic platform. When we take a look in some papers, this is one paper of a group with a large experience in Germany. They observe that no deaths in the robotic group compared to 3 deaths in the open pancreatoduodenectomy. Of course, it's not statistically significant, but we can take a look in these numbers. This is another paper with a meta-analysis, and this meta-analysis showed a similar post-operative mortality between robotic and open procedures. No difference in the, resection. The operative time, as we observe, is greater in robotics, so favor open resections. The blood loss, there is an advantage of robotic group. Pancreatic fistula is almost the same in both groups, and the delayed gastric empty rate is always the same too. Of course, length of hospital will be better in robotic. And one of the things that we talk this morning about the number of lymph nodes harvested is much more important favoring robotic surgery. There are other advantages. This is the way that we perform robotic surgery, but this is only to show you one of advantages of robotic surgery. We can see this is a bleeding surgery, and the fourth arm is very effective in control the bleeding, and then we can have time to do the suture with the fourth arm totally stopped, and we can have time and tranquility to do this. In hepatic surgery, we performed the first laparoscopic resection in Brazil in 1997, and we have a huge experience with laparoscopic resection. And we now are interested in robotic hepatectomy too. This is a paper showing that the robotic approach can be safe and comparable with laparoscopic resection. And this is another paper comparing robotic and laparoscopic for colorectal metastasis with advantage of lower conversion rate when compared to open surgery, the robotic, and no difference in complications, mortality, and some technical advantages. And this is one of the advantages of robotic technique when we compare with laparoscopic technique. The difficulty that we have in posterior superior segments in laparoscopic, and then we can avoid in robotic surgery. We performed until now 8 cases of robotic resection in tumors, and another case of harvesting a left lateral segmentectomy for a pediatric liver donor, and there is no conversion rate, no mortality. And I'd like to talk about the disadvantage of the posterior segments. In this case, it was an hepatocellular carcinoma in a non-cirrhotic liver with 7 centimeters, and we decided to perform a central hepatectomy, and this is the section of the right anterior pedicle. We used this section. You can see here. We use the indocyanine green to have a more secure to demark the line of resection. Go to the other side. To go to the branch of segment 4. This is the pedicle ligation of the branch of the 4. And we continue the dissection. You can see here we are checking the right hepatic vein. The section. I will go a little bit faster. And here we can see the end of the surgery. Again, the use of indocyanine green to show that the liver is okay, well vascularized, and this is the surface art after this resection. So I think this is a safe procedure to do by robotic. It's very safe in a group, in a service with experience in major laparoscopic and major open resection, in a group with experience in all kinds of liver transplantation. This is our group with a lot of female surgeons. We work in liver surgery in Porto Alegre. Thank you.
Dmitry Alden will discuss.
Antonio, congratulations. In a very short period of time, since you obtained the machine, you've accomplished a lot. Really fantastic videos, great results. Again, congratulations. Just a couple things overall. The challenges of the first generation of the robots until now that we have XI and now this new system, 5, was that a lot of us were refusing to change the operation in order to adapt to the machine. And now we've been able to actually use the technology exactly the same way we would open or laparoscopically. So I think now it's the time to sort of move forward and explore and adapt to this further. The advantages that you've shown in terms of, I'm just going to talk about pancreas for a second. The advantage of pancreatic anastomosis using robotic system is, to me personally, is undisputable, that because even with magnification loops that a lot of us use in open surgery, the 20-time magnification that you can have with a robotic system, visualizing the pancreatic duct, visualizing every suture, is a tremendous advantage. The one thing that I wanted to say, that the biggest challenge has always been in open surgery and in robotic, is soft pancreas. And I would like to say to those who use the online YouTube videos that are out there for the pancreatic anastomosis to be very careful in terms of using the barbed sutures as a back layer for the pancreatic jejunectomy in the soft pancreas, because those usually don't hold too well. And I think a lot of us have done in open pancreatectomies, interrupted sutures. It works better. And, like every leak that I had, always happened with these barbed sutures, because, you get frustrated, you want to go fast towards the end of the case, and that's one of the things. Then learning curve. I think what's been published that we have to do about 40 cases in terms of to become like really, really proficient in in robotic whipple operation. And I think once you've obtained that learning curve, whichever it is in terms of numbers for you, it's probably much less with your expertise. But I think the time of surgery is cut rapidly down. My first robotic whipple took 16 hours. The last one I did 2 weeks ago took 8. So you quickly go down. And I know people who do it robotically at the same time that it normally would take me open. So I think the technology is there and we can really use it. It's great. Moving to the liver comments, that beautiful case. I really enjoyed the dissection that you presented. I think we all had extreme challenges, especially a lot of us who were trained years ago using CUSA, and the lack of CUSA in the robotic settings was a big challenge. And we all tried to adopt different energy tools that are available in Da Vinci systems, such as, Synchro Seal and Vessel Sealer and ultracision, harmonic, and all sorts of things. And I think you've shown very clearly that we have plenty of technology and techniques that we possess from open surgery that you can go without having the CUSA. Just one last comment is that when we deal with all these energy devices that we have available, I would avoid using robotic stapling early in the case, because once you have those staples in, none of these energy devices work well. So that's it. Congratulations again. It's fantastic.
Thank you.
President. Oh, John.
Nobody's mentioned it today, but since he brought up the CUSA, there is in our center, and I don't do it, but Jason and Tom do it. You can have a surgeon at the bedside if you organize your port placement. You can have a surgeon at the bedside using.
Yes.
And
Not
we'll
using
have it-
CUSA, not using CUSA.
Yeah, no, I understand. I'm just saying it does add a level of precision and cleanliness to the dissection. A lot of these compromised energy devices involve more tissue trauma, and it's a little rougher. So I think it's something to try if you're interested at all. There's a nice long CUSA for laparoscopy. It's awkward for the surgeon, for the operator, but it's totally possible, and quite a few teams do it that way.
Thank you.
We have another question. We have another question. John, you're talking about the assistant using, correct?
Yes. Bedside surgeon.
Yeah,
Two surgeon. Just a comment on that. I think we started with the bedside surgeon using the CUSA because in fact, it's the best instrument that we have for parenchymal resection, without a doubt. What we found is that even if it's experienced assistant, he never goes where you want to. It works so well.
Exactly right. We have another microphone.
I'll just, yeah, I mean, it's a hybrid technique, two surgeon technique. That the company is working on a CUSA adaptation for the robot, so hopefully it'll become available. I will say there is ability to be still fine and precise with the current tools we have. They're not ideal, but there's a way to still dissect very carefully along vascular planes and everything, as I'm sure a lot of us who do robotic surgery have found. But congrats on your work. Thank you.
And one last, John, did you have one last comment?
I just want to say that it's the responsibility of the senior surgeon at the console to create conditions so that the dissection is clean. Our fellows actually are using the bedside CUSA, and they do a nice job. Maybe we can bring some movies next.
Thank you.
Tonight, we had a board for 45 people, which is not possible. And there will be 3 boards for 10 people going forward and backwards. So if you go down as soon as you can, and don't wait for the other time today. If the boat is there and it's full, just go. The boat is exactly. Oh, yes. Thank you. I love it and
Groepen geweest? Ja, ja. Ja. Zeker niet met je. Ja. Was in 2 jaar fellow. Ah, dat is later. Ja, wat Yes. Because everybody knows about it. That's not a thing. Everybody hears about it. It's difficult. Anyway,
Mas esse salto que de 2012 para trás. Tá. Essa base aí.
Não. Daqui
Mas eu fui somente com os eu não tinha usado.
What?